We are going to start the oral paper presentation, and I must inform you that this is being transmitted live on YouTube as well as Zoom platform. Yesterday it was 750 views on Zoom on YouTube and 150 online delegates they linked to the transmission. So to start with the paper presentation, first I invite Dr. Ankur Gupta. He is from NC Medical College Hospital, Panipat, to present his paper.
Good morning, everyone. Today I am going to present my paper presentation on Good morning, everyone. Today I am going to present the paper on spectrum of macrocytic anemia in adult population, which is a study from a tertiary care center in Haryana. Introduction. Macrocytic anemia refers to the anemia in which RBCs are larger than the normal with an increase in MCV more than 100 femtoliters. It is seen in about 1.7 to 3.6% of the patients seeking medical care. It is classified into megaloblastic anemia. The causes include vitamin B12 deficiency and folic acid deficiency. The non-megaloblastic anemia, which includes causes like reticulocytosis, liver disorders, alcoholism, and hypothyroidism. It acts as a marker to identify the high-risk persons for screening of esophageal carcinoma and gastric carcinoma associated with alcohol abuse. It is a surrogate marker for adherence to treatment. Evaluation of its clinical and etiological profile can provide early diagnosis and timely initiation of treatment. Materials and methods. It is a prospective observational study in 500 patients, excluding microcytic or normocytic anemia patients and chronic illnesses like chronic kidney disease, diabetes mellitus, and hypertension. Inclusion criteria. Adults with 15 to 59 years of age, anemia, that is hemoglobin of less than 13 gram per deciliter in male, less than 12 gram per deciliter in non-pregnant female, and less than 11 gram per deciliter in a pregnant female. The mean red blood corpuscles volume was more than 100 femtoliters. Anemia was classified into mild anemia, that is hemoglobin of 11 to 12.9 gram per deciliter, moderate anemia, that is hemoglobin of 8 to 10.9 gram per deciliter, and severe anemia, which includes the hemoglobin of below 8 gram per deciliter. The routine hematological investigations like CBC, ESR, RFT, LFT, vitamin B12 levels and folic acid levels, urine complete examination, chest X-ray, and USG of the abdomen was performed in all patients. Other specific tests were done when indicated, like osmotic fragility test, direct comb test, etc. IBM SPSS statistics version 23 was used to calculate all statistical analysis. Results. The mean age was 36 plus minus 13.36 years. Mean hemoglobin was 5.02 plus minus 2.02 gram per deciliter. The mean MCV was 109.08 plus minus 6.92 femtoliters. 60% of the cases has MCV of 100 to 109 femtoliter. Rest have the MCV values of more than 110 femtoliters. The 58% were megaloblastic anemia, 6% were non-megaloblastic anemia. Vitamin B12 was deficient in 84.5% cases with megaloblastic anemia. 78.3% of the total cases with vitamin B12 deficiency were vegetarian. Anemia, mild was about 4%, moderate was 7%, and severe was 89% of the cases. Pancytopenia was the most common hematological presentation, that is in 62% in the study population. Jaundice was most common presenting features of hemolytic anemia and liver disease, where it was present in all the cases, while it was present in 29.5% cases with megaloblastic anemia. 5.64% and 1.41% of the cases of megaloblastic anemia had hepatomegaly and splenomegaly respectively. Non-megaloblastic liver disease seen in 48.27%, followed by aplastic anemia in 27.58%. The most common presenting symptom of the study was generalized weakness, followed by shortness of breath. Bleeding manifestations were most common, presenting complaints with liver disease. Discussion. Megaloblastic anemia develop gradually and often severe when first detected. Macrocytosis needs to be evaluated even in the absence of anemia, as it may be the first clue to the underlying pathology. Macrocytosis may be the presenting feature of deadly illness such as aplastic anemia, leukemia, and myelodysplastic syndromes. Thus, detailed evaluation is required in every case for early diagnosis and treatment. Thank you.
Thank you. Good study.
Thank you, sir.
Did you follow up the patients of megaloblastic anemia by treating them and seeing the results?
Yes, sir, we followed them.
So, what were the results?
Sir, with time the megaloblastic anemia resolved.
In how many percent of cases, and what was the timeline like?
Sir, we gave the treatment of vitamin B12 for most of the patients, and in about 5 to 6 months, it was resolved in majority of the cases.
Then what is the national average as compared to your results? You compare the results of your study
Yes, sir.
with national average,
Yes, sir.
right? That nationally it is 5% of the population, 10% of the population.
Yes, sir.
So did you compare your statistics with the national statistics?
No, sir, we didn't compare. Okay, sir.
That is how your study is going to gain importance.
Okay, sir.
Otherwise, what is the importance you did in Haryana and you did not compare it?
Yes, sir. Right, sir.
That will add to your discussion part should be, then in our study it was 62% megaloblastic, this is mild, moderate and severe. National average or Haryana average or Punjab average is this.
Right, sir.
Only then it will gain importance, otherwise there is no importance. आप कोई काम करते हैं उसको किसी से comparison नहीं करेंगे तो उसकी importance है,
Right, sir.
right? So good study.
Thank you, sir.
very much.
Thank you so much, sir.
Present this paper.
Good morning, respected dignitaries and my colleagues. Today I am here to present my paper on left ventricular function in type 2 diabetes patients with microvascular complication. See, this diabetes mellitus is it creates a lot of issue, a lot of comorbidities among the Indian population especially, and among this there are microvascular and macrovascular complications that are present. It is one of the cardiovascular disease caused by diabetes is one of the most leading cause of death in India, and we come across in the medical practice. Often left ventricular dysfunction is often underdiagnosed in type 2 diabetes mellitus, and my study aim was to assess the LV function in type 2 diabetes mellitus with correlation to the microvascular complications which arises. So this study, it was a cross-sectional observational study. 114 type 2 diabetes patients, all above 30 years, was inducted into the study. Exclusion criteria were hypertensive patients, non-cardiac valvular disease, cardiac arrhythmia patients, and other renal diseases were excluded. Data collected was among demographics, laboratory investigations, fundoscopy, and neuropathy test was done. Echocardiography for systolic and diastolic function was also performed. So the results we obtained is the mean age of the study population was around 62.5 years. Among that, 54% of the patients had diabetes for less than 10 years, and LV dysfunction was found out to be in 66% of this study population. Out of that, 21% have heart failure with a reduced ejection fraction, 11% have heart failure with a mildly reduced ejection fraction, and 34% of the patients had heart failure with a preserved ejection fraction. And retinopathy was found out to be in 68% of the study population, out of what 58% had non-progressive diabetic retinopathy, and 10% had progressive diabetic retinopathy. Nephropathy was found out to be in 53% of the study population, and neuropathy was present in 55% of the study population. Among the statistical results, after the statistical analysis, we found out that neuropathy is the highest has the highest correlation of heart failure functions to the microvascular complication. So the underlying pathological mechanism is the chronic hypoglycemia. It will cause endothelial dysfunction, fibrosis, and ischemia. It will cause end organ damages, and retinopathy, nephropathy, and neuropathy are the markers of a cardiac disease. And there has been multiple studies regarding this topic earlier also, and this also confirms the same findings. So at the end, early echo screening can detect a dysfunction before overt heart failure, and this microvascular complications which can point when we have to start an echo evaluation of this patient. So in conclusion, LV dysfunction is to diabetes mellitus patients with the microvascular complications, and routine cardiovascular screening should be inducted into the medical practice for patients with microvascular complication, especially when the patient have a neuropathic conditions. And early detection and intervention may reduce the morbidity and mortality and reduce the disease burden of a country.
So what is the inference like? This is the usual presentation. What is unique about your study? Implication on the already existing literature says that about 48 to 50% of the people will have LV dysfunction if they have microvascular problem.
Yes, sir.
So what are the implications of your study?
So my study is not a pioneer study. It is a follow-up. It's a single.
Basically, why do we do this study? आप study क्यों करते हैं?
So in order to reinforce the notion that a patient with a microvascular complication is
Any study is being done for three purposes: public health implications,
yes,
if it is contradictory to the existing data,
yes,
or it supports the existing data region-wise.
so
There is no such study from Haryana, so I am doing this study from Haryana to add to the statistical, you can say, addition to the
yes,
already existing study कि इंडिया में सब जगह हुई है जी, हरियाणा में नहीं हुई, तो मैंने हरियाणा का डाटा दे दिया. So what is the implication of your study?
So
आप अपनी माइंड में रख के करते हैं ना
yes, sir.
कि क्यों स्टडी करनी है, जैसे लास्ट स्टडी थी,
Yes, sir.
so that added to the already existing data
Data.
from your region.
Yes.
So what is your?
So first of all, it's a region-wise and new data from a region in our area, especially.
Not compare the data with the existing national data. If you don't compare with the national data or your own data from some other institute, how will you add to the knowledge? So that
Yes,
is
sir.
the basic difference,
Yes, sir.
right?
Yes, sir.
So nobody is surprising you. Basically, I don't expect you to do that. But your guides, your all, they are going to see the paper, what you are presenting, and add to that. If you don't compare,
To the national data. Yes, sir.
तो एक ही बंदा था रेस में, वो फर्स्ट आ गया,
Okay.
फर्स्ट का सर्टिफिकेट मिल गया, लोगों ने पूछा ही नहीं कि कितने बंदे और थे यार.
Yes,
So
sir.
next time what you do any study, you have in mind what you want to infer or conclude from that study.
Yes, sir.
Okay?
Yes, sir.
Thank you.
Thank you, sir.
So next I invite Manju Chopra from Mulana to present his paper.
Good morning, everybody. Today, my paper presentation is on correlation of LV mass index and vitamin D levels in essential hypertension. Introduction: essential hypertension is a major risk factor for cardiovascular disease, often leading to left ventricular hypertrophy, which is best assessed by left ventricular mass index, which is the quantitative value to measure the left ventricular hypertrophy. Vitamin D deficiency increasingly recognized in hypertensive patient, which may influence cardiac remodeling through effects on renin-angiotensin system and myocardial function. Studying the correlation between vitamin D levels and LV mass index can provide valuable insights into the cardiovascular risk and management. Aim and objective: to evaluate vitamin D status and correlates its association with echocardiographic indicators of LVH in patients with essential hypertension. This study is a prospective study which was conducted on 100 patients of essential hypertension after obtaining approval from Institutional Ethics Committee. Inclusion criteria were non-cases of hypertension aged above 18 years, while pregnant females and patients with causes of left ventricular hypertrophy other than essential hypertension were excluded, like causes of secondary hypertension, renal endocrine causes, and also the left ventricle valvular heart disease related to left ventricular hypertrophy. These were all excluded from the study. All participants underwent baseline investigation, including serum vitamin D levels, thyroid function test, random blood sugar levels, and 2D echocardiography for assessment of left ventricular mass index. Echocardiographic measurements: LV linear dimensions including interventricular septal thickness IVSD, posterior wall thickness PWD, and left ventricular and diastolic diameters were measured. To calculate LV mass using the formula, LV mass is equal to 0.8 into bracket 1.04 into LVEDD plus PWD plus interventricular septal diameter cube minus LVEDD cube plus 0.6 gram. The LV mass index can be was derived by dividing LV mass by body surface area. So normal reference were defined as 95 gram per meter square in females and less than or equal to 115 gram per meter square in males, and left ventricular hypertrophy was diagnosed when LVMI exceeded these thresholds. Mean age was 59.7 plus minus 12.7 years, majority 60% were 51 to 70 years, with slight female predominance 55%. Overweight obesity was seen in 66% and only 2% were treatment compliant out of total people who are getting treatment. Vitamin D deficiency was common, 62% deficient, 20% insufficient and 18% sufficient. These results were consistent with our national average of 75% of people with low vitamin D levels. In my study, deficient plus insufficient is 82%. So these values is consistent with the national average. Echocardiography showed in high prevalence of abnormalities, abnormal LVMI in 66% patients, interventricular septal thickness in 90%, posterior wall diameter in 92%, and left ventricular and diastolic diameter in 53% is abnormal. Significant association found between vitamin D levels and posterior wall thickness. P-value is 0.031, which is less than 0.05. Trend shows higher LV mass index and wall thickening in vitamin D deficient patient. The mean values of posterior wall diameter amongst vitamin D groups were 1.38 centimeter deficient group, 1.32 centimeter in vitamin D insufficient group, and 1.31 in sufficient individuals. While the difference were not statistically significant, categorical analysis showed only 3.2% of deficient patient had normal PWD versus 22.2% in the sufficient group. So the mean values of posterior wall diameter among the different group in lower vitamin D levels and normal vitamin D levels, is not much difference is there, but the number of patients which I get in the deficient group is way more than the sufficient group. Like only 3.2% patient of deficient vitamin D group has normal posterior wall diameter, but 22.2% in the sufficient had normal. So the difference between the number of patient is bigger, but the absolute mean values of PWD has not much had difference in between. Like they are abnormal, but not much difference. Additionally, patient with abnormal posterior wall diameter had a mean vitamin D level of 21.12 plus minus 19.4 nanogram per milliliter compared to 32.63 plus minus 15.9 nanogram per ml in those with normal thickness. The deficient vitamin D individuals were 62% and insufficient were 20% and sufficient is 18%. So this consistent with the national average data, and these in this second graph, this is prevalence of echocardiographic abnormalities in all the patients. In deficient, sufficient, insufficient patient, these are the echocardiographic abnormalities in all the parameters: LVMI, interventricular septal thickness, posterior wall diameter, and end diastolic diameter. So we found only the significant relationship of LV mass index with only posterior wall diameter. But as you can see, the trend shows this is the first is normal LVMI, abnormal, then in all the parameters. The trend shows the blue mark with the in the deficient individuals, vitamin D. So the trend shows the higher values of abnormalities in a vitamin D deficient individual across all the parameters. Across all the parameters, we can see the highest abnormalities seen in the vitamin D deficient individual, followed by insufficient, followed by sufficient individuals with vitamin D levels. Conclusion: vitamin D deficiency was highly prevalent, 62% in hypertensive patient who also showed obesity, diabetes, and proteinuria. A significant association was observed between vitamin D status and posterior wall thickness, indicating a protective role of sufficient vitamin D against myocardial thickening. Although other parameters showed non-significant trends, these findings suggest that routine screening and correction of vitamin D deficiency may aid in cardiovascular risk management. Thank you.
How do you know that in general population the prevalence may be 80%, in hypertensive patient may be 62%? How do you know?
Sir, in my study, the low vitamin.
In your study,
Yes, sir.
your study you have told
Yes,
that
sir.
62% in hypertensive patients.
Yes, sir. Sir, if we add up the insufficient data also, in deficient only.
I am just asking,
Yes, sir.
how will you compare the hypertensive patients with non-hypertensive patients?
Yes, sir.
Whether hypertensive patients have more deficiency or non-hypertensive patients have more deficiency? Until and unless you have a control group, you cannot.
Yes, sir.
So this study will gain importance only if you compare your data with normal controls, that is non-hypertensive
Non-hypertensive.
patients. Then check
Yes, sir.
that what is the prevalence of vitamin D deficiency in hypertensives
And
and
non-hypertensive.
non-hypertensives, right?
Yes, sir.
Then in non-hypertensives, what is the LV mass
Yes, sir.
with vitamin D deficiency and LV mass in hypertensive
With
with
vitamin
vitamin
D
D
deficiency.
deficiency? Only then this study will gain importance.
Yes, sir.
Otherwise, it is just a ritual to get your certificate that you have presented a paper.
Understand.
आप खड़े हैं,
Yes, sir.
आपको मैं छोटा कर सकता हूँ, आपके साथ बंदा बड़ा खड़ा करके,
Yes, sir.
आपको बड़ा कर सकता हूँ, छोटा बंदा खड़ा करके। तो आपका कंपैरिजन तो होना चाहिए ना।
Yes, exactly.
So try to inculcate this thing. This is lacking in all the three papers. Until and unless you have a control group, you cannot.
Yes, sir.
ठीक है कि नहीं? रिचुअल होगा, मंदिर में जाते हो, टीका लगाता है, वो लगाता है, प्रसाद लेता है, घर पे आ जाते हो। Okay? Thank you very much.
Thank you. Thank you. Thank you, everybody.
So this completes our paper presentation, and we are going to start with our normal scientific session, dot at time, that is 10 a.m. And I must tell you, sometimes we are discouraged that there are less people in the hall, but in the social media concept, or you can say online, we have been joined yesterday by 750 people on YouTube and 150 doctors on online registered platform. So please don't be discouraged. So we start with the regular session, and I must compliment Dr. Parvinder Kaur and Dental IDA, so Indian Dental Association, for giving us the opportunity to add to our scientific program 3 dental lectures. What I feel, I was sensitized by the association of dental diseases with the body diseases, systemic. You can say the dental doctors and the conventional doctors. By Dr. Bishop Mohan, we were there 5 years back together in a conference. Then he told me about the association because his wife is a dental doctor. They have gone into research in some issues. So from that time, I am started to, making efforts to include dental doctors. And last year, Dr. Pravinder was honored, we were honored by her lecture included. I, on individual basis, tried to contact a few dental doctors from civil hospital. I met him at gym. कि डॉक्टर साहब आप lecture दीजिए. So there was no good response. But I think I have found a leader in that. So I will request all the 3 dental doctors to stress upon IDA that next time give me 5 doctors so that I have a good session of Indian Dental Association, including the chapters connecting the dental diseases and systemic illnesses for awareness of the people. So I was made aware that orodental hygiene is affecting cardiovascular diseases like anything, and it is most neglected. So in diabetes also, we have a orodental hygiene group specifically dedicated to interlinked diabetes or metabolic diseases with oral health, or you can say dental diseases. So I'm very, very thankful, Dr. Parvinder, and you have honored us to moderate this session also, and you also connect to the Dental Association for this. I think no other conference is having a dental session, but we will like to have a dental session in our conference. Next year, we have already announced the dates from 17th to 20th September 2026, and we are fortunate to have about 80 registrations for that early bird. So you also motivate the doctors to register as well as present the lectures. So thank you very much. I'll invite you to moderate the session of Indian Dental Association.
First of all, first and foremost, I thank you, Dr. Vitul. As a chairperson, you have given us a proud moment to be part of MAPICON. I'm so happy. I was thrilled last year, and I am honored more by my colleagues, 3 colleagues today, who have done a wonderful job. I hope you'll like it, and we'll be able to connect with the faculty, and we'll be able to highlight that dental is as important in diseases, interlinking all the diseases with the dental hygiene. Yeah, it is very important. Yes. Yes. I mean, one day you just told me that we have to emphasize all doctors look into the patient's mouth. And that is what we are going to stress and highlight. That mouth is equally important, and all medical fraternity has to have a look in the patient's mouth. That's one thing. So now coming to the IDA chapter, first is Dr. Nidhi coming. She is a graduate from GDC Patiala, Government Dental College Patiala. Then she has done her master's from Dashmesh, Faridkot. And she has added with diploma in hospital administration. And the best part about it is that she has upgraded her qualification after putting her siblings into medicine. Both her sons were already doing MBBS or masters in medicine, and she completed her post-graduation. That is so awesome. She will be like talking on interlinking gum disease with medical problems. Thank you so much. And now I invite Dr. Nidhi Verma.
Good morning, everybody. First of all, let me thank Dr. Vitul and the organizing team of the MAPICON who has invited me at this prestigious platform. And the The topic of my discussion is gum diseases and your health. Periodontium refers to the specialized tissue that surround and support the teeth and maintaining them in the maxillary and mandibular bone. And the component of the periodontium include gingiva, cementum, periodontal ligament, and the alveolar bone. And periodontal infections can serve as a source of various systemic diseases, and the area of research in periodontology that relates periodontal diseases to the systemic diseases is called as periodontal medicine. This is a normal gingiva which is firm, pink, stippled with a knife-edge margin and a pointed interdental papilla, and with a normal physiological pigmentation. Next, we come to the dental plaque. The dental plaque, this is the invisible layer which is formed in our mouth daily. Sometimes when we touch our teeth without brushing in the morning and we feel sticky layer in our mouth, that is a dental plaque, and it is made up of millions of bacteria and the proteins. 1 milligram of plaque contains 2 raised to power 10, 2 into 10 raised to power 8 bacteria, and there are 700 types of microorganisms present in the plaque. And when the plaque keeps on collecting on your teeth, that will lead to the inflammation of the gums, that is the gingivitis. Gingivitis, in the gingivitis, there is a redness of gums, puffiness in the gums, bleeding. Patient may feel bleeding while brushing or while eating hard things like apple, and the pain may be there or may not be there. When the plaque keeps on collecting on your teeth, that will lead to formation of hard stony structure, that is the calculus. And calculus is the or the tartar, which you see normally in dark green-like structure or brown structure on the teeth, and it is mostly present on the lingual surfaces of the lower anteriors, because the salivary ducts are present near those teeth. And it is made up of calcium, magnesium, zinc, and other metals. And mainly the crystals are the octacalcium phosphate, brushite, hydroxyapatite, and magnesium bitlocite. And the calculus composition is the proteins, viruses, bacteria, environmental debris, food remnants, and the toxic heavy metals. And when the calculus keep on collecting on the teeth, and that will lead to the inflammation of the periodontium, that is called as the periodontitis. And in the periodontitis, we see red, swollen, painful gums, loose teeth. The patient may complain, the gums will start receding, or they may start separating from the gingiva. There will be the bad breath in the mouth, or the teeth will start shifting. And the patient main complaint is that my teeth are becoming loose, or the patient may complain that his teeth are coming out, they are flaring. So there will be the main complaint of the patient. And the best part of the disease is that is most of the time it is painless. So without pain, patient doesn't go to the dentist or for the consultation. And so without good periodontal health, you can't have good general health. Because periodontal infections can affect your respiratory system, they can affect your bones, they can lead to preterm low birth weight babies, they can lead to stroke, heart diseases, and the uncontrolled diabetes. So now we come to the periodontal medicine. The periodontal medicine is a rapidly emerging branch of the periodontology that focuses on the wealth of the new data, establishing a strong relationship between periodontal health and systemic health or disease. So there is a two-way relationship in which periodontal health of an individual has a powerful influence on the individual systemic health and the vice versa. So there are main 3 different mechanisms by which oral bacteria, they contribute to the non-oral diseases. that is a metastatic infection caused by translocation of bacteria, metastatic injury related to microbial toxins, and metastatic inflammation due to immune injury. And the goals of periodontal therapy is to prevent tooth loss and to restore normal oral health, form and function, and to maintain the systemic health also in the same way. And the main organ systems and conditions influenced by periodontal infection are cardiovascular and cerebrovascular system, that is atherosclerosis, coronary heart disease, angina, myocardial infarction, cerebrovascular accidents, anemia, endocrine system, that is diabetes mellitus, reproductive system leading to preterm low birth weight infants or preeclampsia, renal diseases, respiratory system, that is COPD, and the acute bacterial pneumonia. Rheumatology involving rheumatoid arthritis and ankylosing spondylitis, cognitive function disorders like the dementia and the Alzheimer's disease, cancers like colorectal, pancreatic, and hepatocellular carcinoma. So, in this, as the periodontitis starts, there will be the inflammatory pathway starts in the mouth, and that low grade inflammation will become systemic and can affect the other systems, leading to the inflammatory conditions in the other systems of the body also, like causing heart diseases, neurological diseases, arthritis, SLE, diabetes, and the gastrointestinal diseases. Potential biological pathway between periodontal disease and the systemic diseases, that when the biofilm or the plaque starts collecting over the teeth, that will lead to the that will disseminate into the blood and can lead to the hepatic response, leading to the production of the acute phase proteins. So, this will lead to the production of the oxidized LDL accumulation and arterial plaque formation, leading to the MI and stroke, and this can also cause further complications. The main pathogenesis of the periodontal disease is that the tissue destruction in periodontal disease comes from imbalance between host protective and destructive mechanism induced by the periodontal infection. The periodontal infection lead to activation of neutrophils. They will migrate to the area of the infection, and there will be the induction of antibodies, leading to the release of the matrix metalloproteinases, which destroy extracellular matrix component of the gingiva and the PDL, leading to the destruction of connective tissue, and there will be the production of pro-inflammatory cytokines, leading to the resorption of the alveolar bone. Previously, it was thought that is accumulation of bacterial plaque is the cause of main destruction, but gram-negative microorganisms that present in the subgingival microflora are the main culprit. These are the various microbial complexes which are present in the subgingival plaque, that is the red complex bacteria, orange complex, purple complex, blue complex, green complex, and the orange associated. And among them, the red complex bacteria, they are the more harmful. They are the main culprits, that is the Porphyromonas gingivalis, Tannerella forsythia, Treponema denticola, and the Aggregatibacter actinomycetum comitans. So, as unhealthy mouth is full of bacteria, and these bacteria, they go to the various system and they affect them. That is in the cardiovascular disease, mainly P. gingivalis, Treponema denticola, Tannerella forsythia, they all are found to be the main culprit for the cardiovascular disease. In case of colorectal carcinoma or oral carcinoma, P. gingivalis and F. nucleatum is found. In respiratory tract infection, P. gingivalis and C. pneumoniae, they are all found for causing the respiratory infections. Similarly, in the diabetes and in the case of Alzheimer's disease and the adverse pregnancy outcomes, all the bacteria, these are found to be the main causing the disease. Effect of periodontal disease on the cardiovascular diseases. As this periodontal infection starts, this will lead to the increase in the blood viscosity by the increase in the fibrinogen, increase in the white blood cell count, and increase von Willebrand factor, and this will cause a ischemic heart disease. And the mechanism by which these infections, they contribute to atherosclerosis is there is a direct effect of infectious agent in the atheroма formation, or indirect or host mediated effects, then common genetic predisposition and common risk factor like the lifestyle. Then is the periodontal disease and the stroke. Presence of systemic infection before the stroke leading to the great ischemia and causing the main post-ischemic neurological effect. And stroke patients are found with the higher level of plasma fibrinogen and CRP than those without the infection. And these are the various studies for this disease. And then there's the periodontal disease and the diabetes mellitus. Periodontal disease is considered as a sixth complication of the diabetes, and diabetes increases the risk and severity of the periodontal disease, and these are the main complications of the diabetes, that is the retinopathy, nephropathy, neuropathy, macrovascular disease, altered wound healing, and the periodontal disease. And mechanism by which the diabetes, it influences the periodontium is there is a change in the subgingival microbiota, GCF, glucose levels, periodontal vasculature, host response, and the collagen metabolism. And this is the proposed model that explains that there is a two-way relationship between the periodontitis and the diabetes. As periodontal disease, this causes a connective tissue destruction, and this starts the as pro-inflammatory cascade is there. And also in the diabetes, there is a production of the advanced glycated end products. So this also lead to the production of the degradatory cascade, leading to the connective tissue degradation. Periodontitis increases the diabetes, and in the case of diabetes patients, the periodontal infection also increases. Then comes the periodontal disease and the pregnancy. The gram-negative bacteria, they play a major role in the low birth weight infants, and as their products, they are through the they transfer through the placenta, and then this is the proposed model for the adverse pregnancy outcomes. Periodontal infections leading as a mother with a poor oral hygiene, it is exposed to the periodontal pathogens and their products, and fetus is exposed, leading to the inflammation. This will lead to premature rupture of membranes, preeclampsia, intrauterine fetal growth restriction, and low birth weight babies. Then is the COPD. Periodontal disease and the COPD, it is also very, has very close link, because neutrophil influx released to the oxidative and hydrolytic enzyme leading to the tissue destruction. As we all know that lung infections are caused by bacteria, fungi, viruses, parasites, and microorganisms which infect the low respiratory tract by inhaling infectious aerosols by the spread of infections from nearby contagious sites, and oral cavity and the saliva and the dental plaque with the patient, and in the patients with the periodontal disease seems to be source for pathogens to accumulate and spread to the lower airways. And mainly the several oral pathogens are involved for this. Then is the, and this can lead to the pneumonia. Then the Alzheimer disease. In the patient in which the periodontal disease, it is found that the periodontal pathogens like the P. gingivalis and Treponema denticola are also, they are isolated from the short-term post-mortem Alzheimer disease human brains, so that it is suggested that these patients, these diseases, the patient, they are prone for it. Then the periodontitis and the cancer. In the colorectal carcinoma, which is the fourth leading cause of cancer death, and it is found that F. nucleatum and Clostridium difficile is found in the intestinal microbiota, and gram-negative anaerobic bacteria are also associated with this. And Campylobacter species, Fusobacterium leptotrichia are also identified in the patient with the tumors. So, effect of treatment of periodontitis on the systemic diseases. It is demonstrated that if the patients, periodontitis patients, are treated with SRP, that is scaling root planing, they will exhibit significant reduction in cardiovascular disease biomarkers. And also it is reported that if the mouth is disinfected, so there will be the decrease in the serum biomarker, and also preventive and treatment, if it is done for the periodontal infection, this will reduce the likelihood of preterm low birth weight infants. And if the patient is given chlorhexidine twice a day, it is found that incidence of pneumonia is also reduced. These are the few studies which show that even the use oral rinse of the 0.2% chlorhexidine rinse lead to 60% reduction in the pneumonia. So periodontal disease and the systemic health and the clinical practice. So basically, periodontitis is a gram-negative infection resulting in severe inflammation and the potential intravascular dissemination of microorganisms and their products throughout the body. So it is a silent disease until the destruction results in acute symptom. And so many patients and many medical professionals do not recognize a potential infection that may exist within the oral cavity. So to prevent periodontal disease, brush your teeth twice a day in the right way, floss your teeth once daily, visit your dentist 6 monthly, avoid smoking and smokeless tobacco, and eat a balanced diet containing vitamin C, E, and A. So I conclude that periodontal disease may affect the host susceptibility to systemic diseases through subgingival biofilm, acting as a reservoir of gram-negative bacteria, transit bacteremia, release of microbial toxins, and as a reservoir of inflammatory mediators. And more research is needed. So to prevent, to treat periodontal disease as strategy to prevent or treat CVD, diabetes mellitus, preterm birth, and other adverse pregnancy outcomes, and also for the respiratory diseases. Thank you.
Thank you, Dr. Nidhi, for showing that it is so alarming, a simple matter for us, that is just calculus in the mouth for the dentist, is so alarmingly destructive for the whole body. And so many systems are affected. Thank you so much for stressing this point. And now I leave it to the house to ask her questions, if any, doubts, if any. She'll clear it just now. Any questions, please? Thank you, Dr. Nidhi.
The latest research is that cancer is they are all related to the oral health. So patients should be careful about the oral health.
So, although it is not fatal, and the worst part is this problem is not fatal. So neither the patient nor the clinicians are very much conscious about it. They should be like dealing it 100%. Thanks a lot.
If you say some person that you have a heart attack, he won't go home, he will go to the hospital. But if you say someone you have a bad oral dental hygiene, or you have diabetes, or you have hypertension, he will go here and there for next 1 year, and the mortality rate is almost equal for hypertension, diabetes in the long run as for myocardial infarction. So basically we need to generate awareness among the physicians as well as the people. Only if the physicians are being aware of the condition, only then the people will be aware. But I find most 90% of the doctors, they are not aware. They are prescribing antibiotics and viral illnesses. So thank you very much for making us aware about the disease.
Awareness among physicians
yes.
to motivate people to maintain the oral hygiene.
Yes.
Thank you so much.
Nahi ji, Dr. Parvinder. So I have given her the responsibility for next year's 5 lectures. Yes.
Thank you.
Thank you.
So moving ahead, I invite Dr. Inderpreet. She is graduate and postgraduate both from Government Dental College, Amritsar. She is President-elect of Punjab chapter of Prosthodontics department. So that is, she is a very dynamic dentist in our city. She is practicing. She is working in Adesh as HOD of Prosthodontics and Maxillofacial department also. She is doing really well. She is going to talk to us about interrelationship of occlusion, that is bite, teeth occluding teeth with TMJ joint. Now mostly we don't think there's any interrelation. The orthopedicians, they treat it themselves, not thinking, not giving any thought that the teeth can affect that. So guys, Here's Dr. Inderpreet. She'll lay more stress on the point. Thank you.
Good morning, Vittal sir, Parvinder ma'am especially, Usha ma'am, and all the audience sitting here. I am thankful to all of you that you have given me this opportunity to present some relationship of dental sciences to medical sciences. The way your teeth fit together, it is just not shaping your smile. It actually influences how your jaw joints work every day. So today we'll discuss few aspects of occlusion and how they are related to temporomandibular joint. Both the topics, occlusion is a very vast topic. Temporomandibular joint is again a very vast topic. So in 20 minutes, I don't think I'll be able to cover much, but we'll be touching a few aspects, and I think it will start with the basic little anatomy of TMJ and then little physiology. Then we'll move. So this temporomandibular joint is a complex joint. It is a hinge joint. That means that whenever the joint is moving, both the condyles, they move simultaneously. It is not possible that we are moving one condyle without affecting the other. And this is the most movable joint of the body. Cursor moves? Okay. Coming to the parts of temporomandibular joint, we see it comprises of 4 parts. That is the condyle, which is the part of mandible. Then this mandibular fossa, glenoid fossa, which is the part of the squamous part of the temporal bone. Both of these bones, they are separated from each other by a small cavity called synovial cavity, and there is an articular disc in between these 2 bones that gives a cushioning effect when the movements are there. This articular disc is anteriorly attached to superior and inferior borders of the lateral pterygoid muscle, and this articular disc, it extends posteriorly as retrodiscal tissue. So these are the parts of TMJ. Now we'll see how the TMJ functions. This is a small clip. I think the things will be very clear so that we can see the TMJs. This is the temporal bone. This is our mandible. This is the movement taking place. Coming here, this pink part is the articular disc in between the 2 bones, and anteriorly we can see the superior and the inferior head of the lateral pterygoid muscle, and this is the continuation of articular disc as retrodiscal tissue. Whenever the movement takes place, it takes place as condyle and articular disc, they move together. There is no pain in the normal movements. Why? Because this disc is neither innervated nor vascular. So it means when the condyle disc assembly moves anteriorly to the articular eminence, there is no pain to the patient. On the contrary, this part, which is the retrodiscal tissue, it is highly innervated and vascular. In case of the movements, when we move the mouth till 20 millimeters, there is only rotational movement going on in the condyle. But in this case, where this is the wide opening of the mouth in which whole condyle disc assembly is moving up and down. This is the normal movement. What happens when disc displacement is there? First of all, let me make it clear, the most common disorder of temporomandibular joint is disc displacement, and it usually displaces anteriorly. When the disc is displaced anteriorly, then this retrodiscal tissue is pushed here in between the condyle and the mandibular fossa. It means then when this condyle settles here back in the mandibular fossa, it closes on retrodiscal tissue this way. So this is the most painful condition for the patient. Now, this clicking sound will come whenever the patient opens the mouth when the condyle crosses the posterior border of the articular disc here. Otherwise, the closing and opening was smooth, but when the condyle it crosses the posterior border of the articular disc, it gives a click. Similarly, when it goes back, it gives another click. So it means when there is disc displacement with reduction, there are two clicks or two pop sounds. Another case. Now, after some time, what happens is this retrodiscal tissue, it becomes scar tissue. This is a fortunate thing that after some time it adapts. So this starts behaving like a pseudo disc here. And the pain of the patient eliminates. Now, this pseudo disc starts moving down with the condyle in the forward and backward movement. But in cases where this tissue doesn't go back, whenever the condyle is going back to the original position and the disc is not going back, this is called disc displacement without reduction. So it means when the disc is displaced and reduction is done, then there are two pop or clicks which can be heard. It can be palpated when we check the joint of the patient, and when there is disc displacement without reduction, there is one popping sound that is only during opening. During closing, there will be no sound. Okay, now we just talked little about TMJ. So what is the relationship? Why are we talking about TMJ and occlusion now? Actually, the connection between temporomandibular disorders and occlusion is complex. There is a reciprocal relationship, meaning that each of them can influence and exacerbate each other. So it is quite difficult to pinpoint which came first, as a dysfunctional system can be both the cause or effect. I will try to simplify occlusion now, because I think more of physicians are sitting here. So I'll be talking occlusion, but in quite simple language so that we all can comprehend. So what is occlusion? Occlusion, we have lots of definitions, different kinds of dynamic, physiologic, functional, and many others, but we'll be talking of basic occlusion. So, occlusion is the static or dynamic relationship between the incising or masticating surfaces between the maxillary and the mandibular teeth or teeth analogues. In this picture, we can see there is alignment. Anterior teeth aligned, posterior teeth aligned, and in occlusion. There is proper overjet and overbite present in anterior teeth. This cursor is not moving properly. Can I have a pointer? नहीं चल रहा? ठीक है. I'll try like this. So, now, we will see the effects of malocclusion on TMD now. What is malocclusion? We just saw in the previous picture what is occlusion. It is actually the alignment of the maxillary teeth and mandibular teeth so that we can achieve maximum intercuspation, maximum masticatory forces without any kind of interference or disturbance. But then malocclusion, whenever the teeth, maxillary and mandibular teeth, they are malaligned, that is, they are out of alignment and do not fit properly when the jaws are closed. That is called malocclusion in simple language. So different kinds of malocclusion could be whenever there is excessive spacing in the teeth, we call it malocclusion. Whenever there is crowding of teeth, we call it malocclusion. Open bite, overbite, cross bite, underbite, increased overjet, overbite, or eruption problems. They are all different kinds of malocclusions. I think the audience might be thinking here that if there are so many kinds of problems and which are seen most commonly, very frequently in population, so it means do all of them lead to TMDs? The answer is no. Why? Because there are certain other occlusal characteristics which are also significant contributing factor for TMDs. Because there is, by nature, there are so many adjustments which TMD adjusts, but there are certain which it cannot adjust and leads to TMDs. So an improper bite can place excessive stress on the muscles and joint components, predisposing a person to TMD. So it means the most important factor which we see as the causative of TMD is excessive pressure, undistributed excessive pressure because of any reason. What happens when there is uneven force distribution? See, whenever there are any kind of occlusal interferences, whenever there are prematurities of occlusion, then what happens? Prematurity means any one tooth coming in contact to the other, to the antagonist, before all the other teeth come in contact, before the proper intercuspation. One tooth is coming in contact before all others are contacting, right? That is prematurity. So what does prematurity do? It actually disrupts the harmonious path of closure. The normal path of closure is disturbed when there is some high point, some interference, or some kind of disturbance in occlusion. So this leads to a shift or deflect in the path of closure of the mandible, which causes undue stress in the entire system. Now there is a disturbance here, which is creating undue disturbance, undue pressure, which is getting transferred here to the joint, leading to some kind of deviation. What will the TMD do here? We'll come on to next slide. What will happen? In this slide, whenever there are occlusal disturbances of just what I talked about, that is filling is high, crown is high, then what happens is that the TMJ, the forces have been uneven forces, they have been transferred to temporomandibular joint. Now, temporomandibular joint moves in such a way, it tries to achieve maximum intercuspation, and in that process, it moves either downward or forward or in any deviation from the normal to achieve maximum intercuspation. This is called occlusomuscular pain. See here in this picture, everything is shown in red. These are all muscles. This is temporal muscle, this is masseter muscle, this is the superior and inferior head of the lateral pterygoid muscle. All the muscles are shown red. Why? Because all the muscles are in contraction now. What happens? Whenever we open the mouth, that is depressing the mouth, only the depressors are active and the elevators are relaxed. When we close the mouth, vice versa. So it means during one function, one set of muscles contracts and the other relaxes. But this is not happening in this case now because of interference. So now what happens? This is leading to muscle hyperactivity. All the muscles are in contraction, all the muscles are in a hyperactive state now. So the pain now goes from the masticatory muscles to whole of the face. And it gives us the impression that there is certain kind of TMD, because we are not able to comprehend where does the pain arise. The pain has gone to TMD. Now what to do? This is a quite simple case which I think all the dentists can handle, especially all prosthodontists. In such cases, because of posterior interference, what we can do is we give anterior splint. We have to disocclude the posterior teeth. We have to differentiate between TMD and the occlusomuscular pain. How will we do that? We are giving here anterior splint. Here you can see in this picture, here, this is an anterior splint given, which is causing the posterior disocclusion. So this permits the condyle disc assemblies to seat up in centric position, because in this position, this inferior lateral pterygoid muscle, it relaxes, which is the depressor muscle. It relaxes here. Since it relaxes and releases itself, again, peaceful, comfortable muscle activity can be achieved. Now, what happens in altered bite? Because of altered bite, uneven force distribution, what is happening actually? Different joint position change. The upper and lower teeth, they are no longer able to fit together as they earlier did. So patient is having a kind of feeling in which he feels like feeling off or uncomfortable. Patient is not knowing what is the problem going on with him, but he or she is feeling uncomfortable. So now, this altered bite, it can manifest itself in the following ways. We'll see to it. This is the anterior open bite. This is a case in which both the joints, they are affected. The inflammation or joint changes can cause the jaw to rotate backward. This creates a gap between these maxillary anteriors and the mandibular anteriors. This means that patient is not able to touch the incisors. This is anterior open bite. We'll come to the treatment part later on. Now, this is the case of posterior open bite. This is usually a unilateral or one-sided joint problem. The joint may affect shift, causing the posterior teeth on that side to lose the contact. It means that on one side, there are no contact teeth, and on the other side, the teeth are coming in contact with each other. There can be a feeling of rocking sensation to the patient when the patient bites here. This is only one side. This is the lateral view. You can see? Unstable bite. This is the most common cause again for altered bites. What is a stable bite? For knowing the unstable bite, we have to know what is stable bite. Stable bite is actually a balanced bite which allows chewing forces to be evenly distributed axially along the long axis of the tooth. This way. This is the stable bite. And in unstable bite, the forces, they are misdirected either tangentially or torque. This is causing chipping, fractured, and loose teeth. So this is the most case, I think, if anyone has got the dental treatment done, there are sometimes fracturing of the teeth is there, teeth are getting loose, or there can be chipping of a crown or chipping of the tooth structure, or fracturing of the tooth is going on. This is because of the unstable bite. Here the patient may report that bite feels off. He is not finding any comfortable way where to close. So it means this again feeling, this leads to deviation in the jaw closure, because the jaw will try to seek a pain-free path again. See, wherever there is pain, we try to shift to the other side so that the pain decreases or eliminates. Now, there are certain malocclusions which are also the risk factors causing TMDs. They are deep bite. As we can see in this picture, this is the normal bite of the patient, normal overjet, and overbite, right? But in this condition, here, where it is deep bite, the lower teeth are severely overlapped by the upper teeth. It means that whenever there is forward movement of the jaw, that is protrusion of the mandible, it is going to put more stress on the joint, and it will lead to uncomfortability to the patient. Coming to another bite, which is cross bite. This is an alignment issue, as you can see here, where some upper teeth bite inside the lower teeth. This will result in uneven forces and lateral jaw shifts, which can place significant stress on TMJ and the associated muscles. This is the most common clinical case, which is the loss of posterior support. Most commonly, as dentists, we come across this kind of case. Either there is unilateral teeth missing or decayed, or bilaterally, this condition is there. This leads to collapse of the VD. This means that if the teeth are missing or worn down, then the remaining teeth will put disproportionate amount of chewing load, which is transferred again to the temporomandibular joint. This can lead to reduction in the vertical bite and placing the joint in very compromised and overclosed position. There are certain parafunctional habits like bruxism, bruxomania. In such case, whenever such kind of habits are there, then the body may subconsciously try to grind away the occlusal interferences. Whenever there is any kind of occlusal interference in the teeth of the patient, then by nature, it is going to grind off, because then a war between the muscle and the teeth starts. And when that happens, then muscle always wins. The high constant forces generated by these habits, they are a major cause of muscle and joint pain, contributing significantly to TMD symptoms. Again, in this picture, you can see this is the normal, and you can see here, teeth grinding has been done, teeth are getting treated, gum recession is there. These are all the outcomes of parafunctional habits. In such cases, sometimes the habits are not very peculiar in the patient. But still, if there are even small habits, or at least night grinding is there in the patient, from the occlusion of the patient, we can see the wear facets present. So it means by just checking the condition of the teeth, we can check whether the patient is having any kind of parafunctional habit which is damaging. All these altered bite, undue stresses which are being transferred to the temporomandibular joint, what is it going to do to the joint? It's going to do damage to the joint. How? It can lead to swelling, it can lead to inflammation, it can cause joint effusion, that is, there may be buildup of the fluid within the joint capsule, there may be internal derangements which can physically change the position of mandibular condyle within the glenoid fossa. So it means that whenever there are unexplained migraines, any kind of jaw pain, neck pain, ear pain, tinnitus, the dental reason could be one cause. So always refer to your dentist whenever such kind of problems arise. Whenever the joint is swollen, what is going to happen to the condyle? See, the anatomy, we did not discuss too much anatomy of the condyle, but the anatomy of the condyle says, because of the bone present medially and so many ligaments which have been articulating it in a manner, the joint can only move downward and forward. A displaced disc, which is a normal function is the cushioning effect, it can alter the smooth path of closure of the condyle in the mandibular fossa. So these all, what they will do, they can lead to slight but then clinical shifting of the jaws, resting and closing position. How does this go in muscle memory? When repetitively the joint is making the mandible move to a deviated path, then this pain and muscle spasm will try to avoid pain. It will guide the jaw into an altered closing path. So deviation, this deviation, as we can see in this picture, the mandible has deviated to one side. This is in a response to reduce pain, to avoid pain. This change in muscle memory reinforces a malocclusion and can become a self-perpetuating problem as the new painful bite becomes the brain's normal way of closing the jaw.
Dr. Inder, sorry for interrupting you. Yeah, if you have laid enough stress, and if we could come
Coming to management.
Conclude kar do.
Okay. So for the management, we can go in for dental point of view, we can go for splints and mouth guards. And for stress management, patient has to go for like yoga, meditation sessions. He can have heat and ice packs and shift to soft tights. Then he can modify his behavior by consciously not grinding, not clenching. And then most important, the resting jaw position should be maxillary and mandibular teeth slightly open with the tongue resting to the anterior palate. And non-invasive procedures all include physiotherapies, then oral appliances which we can give, medications and injections. Invasive procedures, if required, they could be arthrocentesis and arthroscopy. And I will skip this then. No, I will conclude. So the relationship between TMD and occlusion is actually a cycle of dysfunction. A pre-existing malocclusion stresses the temporomandibular joint and its muscles, leading to joint and muscle pain. That is TMD. And the pain and the muscle spasms from TMD can cause the jaw to shift, which further worsens the malocclusion and creating even more strain on the system. So breaking this cycle needs a multifaceted approach which addresses both the joint health and the occlusal factors as a contributing problem. So it means that if there is TMD, it can lead to occlusal discrepancies, and if there are occlusal discrepancies, it is going to cause TMD. So both are so much interrelatedly, this is a vicious cycle. It has to be broken somewhere, and we have to have the help of a
Dentists have to intervene. Thank you, Dr. Inder. Thank you so much. बताने के लिए खाने के और दिखाने के दोनों सही होने चाहिए दांत.
Yes. Any questions from the audience?
I think everybody will be checking the ticks
Yes.
after your lecture. Whether there is one click or there is two clicks.
Yes, yes.
So if there are two clicks, they will approach you. If there is one click, they will try to, correct their occlusion or something which they can do. Thank you very much.
Thank you, sir.
Thank you. Thank you, Dr. Inder. So last but not the least, Dr. Jitendra Singh. He is graduate from Mangalore and postgraduate from Manipal, and he is the first PhD. PhD in dentistry is now in trend according to Dr. Jitendra. He is pioneer in doing this, and we will hear him on interrelationship of dental diseases with diabetes type 2. So he has many national, international papers like Inder. Inder also had that. Let's now not waste time and listen to him. Thank you. Welcome, Dr. Jitendra.
Good morning, everybody. Thank you, MAPICON. Thank you, Dr. Vittal. Thank you, Pravinda ma'am, for giving me this opportunity. Today I'm here with the topic periodontal therapy and glycemic control in type 2 diabetes. So we all are very well aware what diabetes is today. It is a public health concern worldwide, and the estimate by the World Health Organization says the number of people with type 2 diabetes reaching 366 million by the year 2030, and India being the capital for that. When you talk of periodontitis, it's also a major public health concern, contributing significantly to the global burden of oral diseases. And half of the Indian adults, they suffer from some form of the periodontal disease. Severe periodontal disease affects 10 to 15% of the adult population. When you talk of prevalence of periodontitis, males, they have a higher proportion of periodontitis as compared to females. And subjects aged 65 years and above, they have higher prevalence of periodontitis, whereas subjects aged below 35 years, they have higher proportion of gingivitis. So mainly periodontitis is a disease of 4th to 5th decade disease. It starts with from 4th decade onwards. In the urban-rural comparison, the urban population have a higher burden of gingivitis, whereas periodontal disease was more common in the rural population. Now, what actually is periodontitis? Dr. Nidhi has already told us. So it's an inflammatory disease of the supporting tissues of the teeth caused by specific microorganisms or groups of specific microorganisms, resulting in the progressive destruction of the periodontal ligament, alveolar bone, with periodontal pocket formation, gingival recession, or both. So the damage to any supporting tissues of the tooth is periodontitis. Now, what is the relationship of periodontal disease and diabetes mellitus? It's a two-way relation. So, bidirectional relationship. Individuals with diabetes, they are about 2.5 times more likely to have periodontitis than medically healthy controls. And when severe periodontal disease often coexists with severe diabetes, and the disease tends to be most severe in patients with the poorest glycemic control. And as the infection and the advanced glycation end product mediated cytokine increases, the tissue destruction in diabetic periodontitis becomes faster, and this is how the periodontal infection may complicate the severity of diabetes and the degree of metabolic control. Now, what actually happens when we reduce the periodontal inflammation by reducing the periodontal infection? There is significant reduction in insulin requirement in the diabetic patients, thus significantly indicating short-term improvement in the concentration of glycated hemoglobin. So now, since there is very limited information available till date regarding the effect of the periodontal therapy on metabolic control, we came up with the objectives to evaluate the influence of non-surgical periodontal therapy on serum levels of HbA1c in patients with type 2 diabetes mellitus. We came up with the hypothesis that non-surgical periodontal treatment, it reduces HbA1c, improving the metabolic control in patients with type 2. The program of the work, we had around 150 type 2 diabetic patients suffering from generalized chronic periodontitis selected from amongst the patients reporting at the diabetic units from the medicine department of AIMSA. The subjects for the study were selected in a non-randomized manner between the age group of 30 to 70 years. Their detailed medical and dental history is taken. The patients explained the purpose of the study and the procedures involved. The inclusion criteria for the participants of the subjects was, now patient, they had the confirmed diagnosis of diabetes for the last 6 months and they were on regular follow-ups. Patients suffering from moderate to severe periodontitis, patients with at least presence of 15 natural teeth, patients not have received any periodontal treatment in the past 6 months, patients with 4 or more pockets of 4 millimeter or more, and probing attachment loss of 4 millimeter or more in at least 2 different quadrants, which bled on probing. Patients have not used any antibiotics in the past 3 months, and patients with the physical and mental ability to control their plaque to a clinical and acceptable level. In the exclusion criteria, patients with type 1 diabetes were excluded. Patients suffering from diabetic complications like retinopathy, nephropathy, and neuropathy were excluded. Patients with a history of stroke in the last 12 months were excluded, and patients who had their medication changed during the course or in the previous 6 months were also not allowed for the study. Patients with any severe dental infection requiring drainage antibiotics were also not the part of this study. Pregnant females and patients currently receiving dialysis. Now, to assess the periodontal status, we had this CPITN probe given by WHO. The periodontal status was assessed using the following parameters, mainly the 2 indicators, gingival bleeding and periodontal pockets. Just the absence or presence of gingival bleeding with this probe, which had a 0.5 millimeter ball, and for the presence of periodontal pockets, we had the markings from 3.5 to 3.5 to 5.5 millimeter, a black band, and then another band at 8.5 to 11.5. Now, this was the charting done, and it was very simple. If the bleeding was present, a score 1 was given. Bleeding absence means score 0. And for the pockets, if the pockets are from 4 to 5 millimeters, score 1 was given, and for pockets above 6 millimeters, score 2 was given. Now, the methods for the collection of data. On the first visit, the periodontal status of the patient was assessed using this CPI index given by WHO. And along with that, the blood sample also was taken for the subject to evaluate the serum glycated hemoglobin. And if the HbA1c was falling between 7 to 9 and the periodontal status was between moderate to severe, the patient was enrolled in the study with the informed consent. So moderate periodontitis was classified when the pocket depth was between 4 to 5 millimeter, and when the pocket depth was 6 millimeter and above, it was severe periodontitis. So after 12 weeks following scaling and root planing, or only scaling or no treatment, the subjects were recalled for recording the periodontal status using the same CPI modified index. Again, blood sample taken for the serum glycated hemoglobin. None of the final analyzed subjects had their medication changed during the course of study. So these were the interventional procedures. In the treatment group A, we gave full mouth debridement consisting of oral hygiene instructions, subgingival scaling and root planing using ultrasonic device, and Gracie curates under local anesthesia, done in 2 visits at 1 week interval. And the group consisted of patients with pocket depth of 6 millimeter or more. In the treatment group B, we just gave oral hygiene instructions and supragingival removal of plaque and calculus with ultrasonic scaler. It is just a simple scaling process in dental terms. The group consisted of patients with pocket depth of 4 to 5 millimeters. In the treatment group C, which was a control group, there was no treatment delivered. The observations, we had HbA1c changes from baseline to 3 months visit, and changes in the clinical measurements of chronic periodontitis, whether bleeding it reduced or not, the mean periodontal pocket score, and the clinical attachment loss. The recording and analysis was done, and permission from the research and the ethical committee was taken prior to the study. So in the total subject size of 150, 116 were males and 34 or 22.7% were females. Now, the duration for which subjects were diabetic, around 24% of the subjects, they were having diabetes from 5 to 10 years, and 31.3% were for more than 10 years. Now, this charting shows us the bleeding status, the mean periodontal pocket score, and attachment loss before the treatment was delivered. Around 492 sites bled out of 600 sites. The mean periodontal pocket score was 4.82 and 7.96 was the mean attachment loss score. The mean HbA1c score before treatment was delivered. In group A, it was 8.15 plus minus 1.43 standard deviation. In group B, it was 8.01. That was the only scaling group. Group C group was the control group. It is 8.11, and when group A and B was combined, it was 8.08. Now, this is the charting where the bleeding status, the mean periodontal pocket score, and attachment loss score was recorded after the treatment was delivered, whether it was scaling and root planing or only scaling. Now we are left with just 98 bleeding sites out of 492. There was a reduction of around 65% in the bleeding sites in the treatment groups. The mean periodontal pocket score dropped from 7.2 to 3.2, and the attachment loss score from 7.96 to 3.05. The mean HbA1c value. So these are of much importance to the physicians here. The mean HbA1c values, they dropped from 8.15 to 7.02 in group A. In group B, the reduction was from 8.01 to 7.60, and in group C, the control group almost 8.08 to 8.04. So when we make a comparison of the treatment modalities on HbA1c, the group A had almost a percentage reduction of 13.9%. Group B almost 5.1%. It was just the scaling group. When both the groups were combined, A and B, the percentage reduction was 9.5%. And in control group, it was almost negligible, 0.8%. So comparison of the mean HbA1c value among the scaling and route planning group and only scaling group. Group A and B comparison, it was found to be statistically significant. And comparison again of HbA1c value among the study groups before and after treatment, that is with the control group, again was found to be statistically significant with the p-value of 0.031. So this charting shows us most of the sites for bleeding were statistically significant, and periodontal mean score only one site was statistically significant, and for attachment loss score again other than one, almost all sites were statistically significant. Now the discussion part. Now the observations that the periodontal therapy appears to reduce the periodontal infection and inflammation, it suggests that periodontal therapy may facilitate the metabolic control of diabetes, improving insulin sensitivity by reducing peripheral inflammatory cytokine levels. But the exact mechanism by which this happens have still not been fully elucidated. But the popular hypothesis involving the inflammatory pathways common to the pathogenesis of periodontitis and insulin resistance. Now, Grossi and Janko, along with Amar and Hen in 2003, they suggested the upregulation of pro-inflammatory cytokines, the tumor necrosis factor alpha, IL-1, IL-6 in periodontal disease may be responsible for insulin resistance and the poor glycemic control. Another study by Koromantos et al. In 2011, again all the parameters measured bleeding, the gingival index, the periodontal pocket depth and attachment loss, they all improved after 3 months of non-surgical periodontal therapy. In another study by Singh et al. In 2008, HbA1c and all the other periodontal parameters, they showed improvement after 3 months. And also the percentage of sites with probing depth of 4 to 6 millimeter and greater than 7 millimeter, they reduced significantly in scaling and route planning group. Now, a study by Rodriguez in 2003, where group 2, where one stage full mouth scaling and route planning was done, they showed a reduction of HbA1c levels of up to 11%, and it was statistically significant. Another study by Panseria in 2012 also showed a reduction of 12% after 3 months of non-surgical periodontal therapy. The results were similar to our study, where we had around 9.5% when both the groups were combined and 13.9% in group A, where deep scaling and curettage was done. Another study by Koromantos in 2017 evaluated the reduction in glycated hemoglobin at 3 to 4 months after periodontal treatment. It showed a reduction in HbA1c ranging from 0.27 to 1.03. Now, this meta-analysis, they indicated that effective non-surgical periodontal treatment in people with diabetes, they result in statistically significant reduction in glycated hemoglobin levels at 3 months. Now, these studies, they did not show any significant additional impact of the antibiotics use on glycemic control. Another study done in New York University, United States, the mean reduction in HbA1c noted was around 7.8%, which was almost similar to our study of where we showed a reduction of 9.5%. The reduction in HbA1c in treatment group A was 1.13, and in group B it was 0.41, whereas HbA1c decreased by 10.8% in a study done by Kaur et al. In 2015. Another systemic review on RCT by Chen et al. In 2021, he concluded that the significant benefit of periodontal treatment on glycemic control in patients with type 2 diabetes and periodontitis. So the clinical benefit was mainly found with high baseline glycosited hemoglobin level. Now, it has been reported that the inflammation directly induces insulin resistance in type 2 diabetes patients. There has been significant decrease of plasma levels of several inflammation markers like interleukin, IL-1 beta and IL-6 compared with the baseline levels after periodontal therapy. The periodontal treatment in type 2 diabetic patients is effective in improving the metabolic control, possibly through reduced tumor necrosis factor alpha levels and thus improving the insulin resistance. Now, this is more important. The clinical implications of achieving better metabolic control of diabetic patients, they're clearly established. Specifically, the microvascular complications related to diabetes, they are reduced by 35% for each 1% decrease in HbA1c level. Additionally, an absolute decrease in 1% in HbA1c level can decrease the risk of any death related to diabetes by 21% as shown by Selvin in 2010. Now to conclude that the non-surgical periodontal therapy, it was clinically effective and had a statistically significant effect on the participants' glycemic control. The implications for clinical practice. Now, the clinician has to be very well aware of the two-way street of the disease cycle. The results in greater periodontal disease in those with diabetes and poorer glycemic control. The healthcare provider should inform the patients of diabetes of this link and engage in oral health education programs. Oral healthcare provider should perform a periodontal examination in each newly diagnosed diabetic patient, and physicians should seek the evidence for the presence of periodontitis in patients with diabetes and ask about the signs and symptoms of bleeding gums, drifting dentition, halitosis, and gum soreness. Thank you.
Thank you, Dr. Jitendra. I think Dr. Bitul will be better, he'll have better observation on all the protocols maintained in your study. Like he was earlier mentioning, you had comparative things also and the control group also, everything. And you have summarized very nicely all the points, and I think the physicians don't require to be over told about all these significance, because you have highlighted that the periodontal diseases leads to resistance to insulin and it requires to be taken care.
Simple scaling is showing us the improvement. A simple scaling process which almost every dentist recommends, or even the physicians, they can just tell a diabetic patient to just have a scaling done. Because now in my practice, whenever I come across a diabetic patient and I counsel that patient, and sometimes the patient say, I am taking the medication, I am doing the exercises, the diet, every part, and still my diabetes is not coming down. So a simple scaling process for such patients is improving as HbA1c after 3 months.
So again, it's nice that simple procedure reverses the thing in the oral mouth also and as well as the diabetes also.
Yes,
That's
yes.
great. Over to Dr. Bitul.
Thank you very much for apprising us. Basically, this is now being propagated in all the medical, associations. In Diabetes India, we have a special oral health group seeking the treatment or modalities or research how oral health is affecting diabetes. So there is a specific group formed last year.
Okay.
And I think Dr. Manchanda is here. He is going to comment a little bit on this.
Yes, actually the concept of even periodontal disease, diabetes and coronary artery disease also was also well established a decade back. And this is, though it is not part of this study, but when we see the lung abscess infection, first thing we ask about any tooth infection. From there it percolates and causes the posterior segment of the lung is very important. You mentioned scaling of diabetic populations. What should be the frequency of a person who is asymptomatic?
Who is asymptomatic, that is once a year, is good enough. But a patient with the HbA1c level of 7 to 9 or above 9 can have scaling process after 6 to 8 months. Welcome.
So once again, Dr. Bitul, thank you so much. This is the end of our idea chapter, and we promise to get you more speakers next year, and these were my enthusiast speakers who had to be breakdown, and there was no end to their lectures. They have more knowledge, and we'll be sharing next year. Thank you so much, and thank you for the patience, audience. Thank you.
Thank you, ma'am. I think this session had one of the very interesting lectures from all the lectures delivered. Especially I congratulate ma'am, because you know, that will be, whosoever has watched online or offline, they will be checking their temporomandibular joint for the clicks, whether it is 2 clicks or it is 1 click. So that is the most important part of all the lectures. Thank you very much. Thank you very much, Dr. Parvinder, for conducting this IDA session. And next year, we are hopeful that 5 lectures, so interesting lectures as you have delivered today, will be incorporated in MAPICON scientific program for coming years also. So thank you very much. And with this, we start our journal session. And for that, the first speaker is Dr. Usha Goyal, most versatile, dynamic district health officer, and she is going to talk about the upcoming, maybe hyped or not hyped, maybe required or not that much required, about millets, and that is reinvented. So we are going back to traditional things, whether it is diet or it is pollution or it is cultural effects. So I invite Dr. Usha to please apprise us about reinvention or resurgence of millets.
Good morning and namaskar. It was Dr. Vittal around, it was 2.5 years back, we had here in Sepal only. In fact, I only took time, asked him for 5 minutes on the stage. And I was just speaking on the preventive aspects, being a district health officer, Bathinda. So the very same year, he asked me to speak on this topic, but because of some urgent VC meeting we had, I could not come. So this year again, he told me last year itself, so I made it, and I told him, let it be a non-working day. So that is why I am here on Saturday. It was actually a Friday earlier. So I knew I'll not be there on Friday again. So millets, you know, when people talk about it, most of the people think of, kya hai ye? Difficult to eat, difficult to cook. It is. It is really, for at least the housewife or the cook, it is something very, very difficult. But now it is the in thing. In thing is, why? Now, let us first start with the names, various names that have been given to this. It is Shri Anna. Shri hum lagate hain in our country when we have to honor or we have to give lots of respect to something. So it is Shri Anna, then or honored grain. Then it is also called mother of all grains. Hamari desi bhasha mein it is mota anaj. And you know, I'm surprised nowadays, farmers coming up and taking the non-traditional names that is in English, you know, the foxtail millet, phala millet, all this. And I always tell them, aap traditional kyun nahi bolte ho? It is actually easy to connect with the people. So it is mota anaj, and then we have the superfood that has now come in. Now, this Shri Anna term was actually coined by our Prime Minister, Mr. Narendra Modi, and this is the name of various millets. I will not go into the details. So he said it is a powerhouse of nutrients. The various types of millets, and these are actually the names the farmers come and take. They will not speak bajra, jawar, no. They will speak these names, porso millet, brown millet, and I always get confused ki ye kaun sa wala hai? I mean, because I'm not used to, I always take the routine names that we take. So this is it. Pearl millet is bajra. This is the commonest form of millet that we are consuming. Jowar is sorghum, finger millet ragi. Then we have Kangani, Kodo, Kutki. Now, Kodo millet is one millet which is actually in Punjab related with our first guru. I think we have a small story which we'll, I have a PPT, but I'll speak here only. Because Guru Nanak Dev Ji was offered food once by Malik Bhat and then Lalo Bhai. Now there was, Lalo Bhai was a very poor carpenter. Usne kya diya? Kodo roti and saag. That is the poor man's food in Punjab. Saag is considered, and bajra roti or a kodo roti is considered to be a poor man's food. So what did the other person give? He offered a very sumptuous meal, a rich meal. But Guru Nanak Dev Ji, he accepted the kodo roti from Bhai Lalo, and he said, because he said it was, that time it was ki nahi ji, it is because of honesty and his hard work that I am taking it. But what we try to emphasize in all our talks, or whosoever speaks on millets, is that since time immemorial, millets have been a part of our diet. It was actually a part of our diet, and now it has disappeared. Now it is actually a C4 plant with a high photosynthetic efficiency, with a short growth period, then resistant to heat, drought. We know all these things. Now, why are we, as Dr. Vittal told me, reinventing or rediscovering them, or whatever you can say? It is because they are gluten-free. And gluten is a term which everyone in the society nowadays knows. But gluten hai kya, ye kisi ko nahi malum. Gluten किसी को नहीं मालूम क्या है. No one knows what gluten is. Gluten भला क्या है, पर gluten free सबको मालूम है. Everyone is, every village person knows, everyone, whether educated, whether literate, not literate, everyone speaks on that. Now, it represents a diverse collection of small seeded cereals, and it belongs to the grass family Poaceae, and the super grain is cultivated extensively worldwide. And it is used primarily as cereal crops, animal food, and for human consumption. Millets in Hindi. This was purposely added. इन्हें मोटा अनाज कहा जाता है. छोटे छोटे गोल पूर्ण अनाजों का समूह होता है, and various types. I think everyone, I don't know how many of you know, but we are the leading producer of millets in the world. And India is producing, now it is producing more than 12 million MT of millets annually. And mainly Odisha, Madhya Pradesh, Jharkhand, Rajasthan, Karnataka, and Uttarakhand. Now, why millets and why now? As Dr. Vittal in the beginning said, that we are rediscovering, or we are actually going back to what we have lost or we have forgotten. All our traditions, all our dresses, all what we were eating, what we were using in our routine, and the climate also, everything. So, resurgence of millets is actually not a coincidence. We all know 2023 was declared by United Nations as the International Year of Millets. And actually, this was the year when people around the world were forced to rediscover millets. And now it is not only in India, it is as a favorite topic in other countries also. And for doctors, for other reasons, because as the dentists, we had an eye-opening session for us, all diseases from head to toe. Similarly, millets would cure, and they are the causes, our diet is the cause of all the diseases. So in the Indian government in 2018 named it as the National Year of Millets, and after that 23 was declared by the UN. And on December 6, 2022, actually in Rome, Italy, 23 was decided to be declared as the International Year of Millets. Now, why millets matter? Kyun? ज़रूरी क्यों है? They are actually not grains. I always say they are a way of life. Rich in fiber, खूब सारा, which we doctors, सारे physician कहते हैं बहुत ज़रूरी है, surgeons, everyone says. And they are all packed with proteins, brimming with essential minerals, support digestion, then the most important, blood sugar in check, and long-lasting energy. Unlike processed grains, they are gluten free. Again, this term gluten free. अगर आपको किसी को millet खिलाने लगाना है, तो tell that person ये gluten free है, बस. The work is done. 80% काम हो जाता है. उसके बाद they will ask you, मुश्किल है खाना, बनाना मुश्किल है. And next thing is roti hard बनती है. At the end of my topic, जब वो मेरा thank you slide आएगा, I'll give all of you a very simple trick to make a very soft roti like a wheat chapati. That's a promise, and if I forget, ma'am, मुझे याद करा दीजिएगा, because I always keep telling अगर मुझे कोई भी पूछता है वो. So they require less water, no chemicals, we all know. When you are cooking with millets, you are actually not feeding your family, you are nurturing them. So we'll see how they do it. What are the challenges? As I said, lack of awareness. Supply chain is also limited. Even now we have, and cost. Cost is important because production has gone down and we don't have processing units in the country as much as we ought to have them. Future is we should be introducing them in the school meals, public programs, and public programs it has come up. In the last 2-3 years, it has gradually come up in the country, and global markets for healthy foods. Now we have two types of millets, major and minor. Major होते हैं छोटे बड़े वाले grains, थोड़े से लंबे, और minor गोल और छोटा size. बस that is what you have to remember. इससे ज़्यादा अगर we start इसको पढ़ना लग जाए ना तो as doctors हमें बहुत ज़्यादा याद नहीं रहता है. So this I have already said. Now in G20 summit we all know because G20 summit का एक session अमृतसर हुआ, Delhi हुआ, various parts of the country, and I think if all of you remember, millets was served to all the people who had come in and dignitaries from various countries. So imagine a country like India. I always say a country like India, maybe more than the population of Europe we have. And if the head of that country decides that in G20 summit, we have to feed millets, we have to serve millets, showcase them, there must be something. I mean, a head of a country can't be just doing something for no reason. So there was a very deep meaning to it, and he did it incorporating local and seasonal ingredients, artistic presentation. Yes, I will show you a few food which students of one of our colleges of Bathinda prepared 2 years back. I'll present those pictures because you should be knowing how beautiful it looks, how I mean, you feel like abhi mil jaye mere samne. I mean, it is that ways. So it is blending tradition with modernity to create a world on your platter experience. Now the lifestyle, various lectures have already been sedentary lifestyle, sab kuch ho gaya. Now the key nutrients are, जैसे finger millet grains हैं, they are high calcium levels. Then some have protein, the others would have fiber in it. Then many have significant levels of iron, and then gluten-free it is there. Then minerals, it is a powerhouse of minerals. We are all asking our patients to take multivitamins packed with all the minerals. That is what we are doing, all the B complexes, iron, calcium. I tell you, if you can ask your patients to start on a millet diet, if not more, twice a week, you will realize after a month or two, they will themselves come and say, कि नहीं, sir, Dr. Sahab, we are taking it maybe 15 to 20 days a month, because usse they feel more of that they are energetic. Yes, energy does come in. And also that many of the diseases, the medication has gone down, and they have become disease-free. Environmental benefits are mitigates global warming, ensures food security. Now you must be, I don't know how much all of you know, but yes, 300 liters of maximum, this is the water required for. क्योंकि राजस्थान में कहते हैं कि ऐसे आप फेंक दीजिए बाजरा या कुछ, एक बरसात आएगी, it will grow. It doesn't need any water, it doesn't need any insecticides, chemicals, nothing. It will grow on its own. And similarly here. And for 1 kilogram of sugarcane, you need 2500 liters of water. For rice, you need maximum 5000 liters for different varieties. So that is the maximum that we need. Now, Dr. Khadarwali is called the millet man of India. I don't know how many of you have had a chance to listen to him. Yes, he was in Bathinda 2 years back. I had the opportunity to listen to him. Once you listen to him and then you realize that what we are eating today and what we are being served today is nothing less than, I shouldn't be using the word, but it's something like poison. Yes, it's a slow poison. It is actually a slow poison. I mean, if you really ever come to know that Dr. Khadarwali is delivering a lecture anywhere in your city or surrounding cities, and if you can manage, just go in and listen to him. It'll be an academic feast. Like Dr. Vittal gives, he is providing an academic feast in Bathinda for 4 days every year. So he says if farmers cultivate all these positive grains, drought can be totally avoided in India in the next 50 years. Now, heritage, पुराना time था, दादी माँ का पिटारा जिसे हम कहते हैं, उसमें से all these things used to come up, right? But nowadays it has disappeared. Now from hype, अब हमारे पास क्या आया है? Millets में we have energy bars, we have noodles, we have pastas, yes, we have cookies, we have cakes, we have brownies, everything. You just name the thing. Smoothies. I'll show you what the students of one of our girls' college in this city did for a month. Yes, we had a special program. So we are actually not modernizing millets. Whenever I go and talk, I say I'm not modernizing them, but I'm here to unleash them. Now this was the famous 4-week millet challenge. This was it was done in the SSD Girls College. I mean, very difficult for various colleges to go in for a challenge. बहुत मुश्किल था millet challenge, only 1 month, 4 weeks. So this college, they were very ready. They said कि ma'am हम करेंगे पूरा. So we started and see, you have the Hari Kangani Pinni, you have the Sikh Cup. This was all prepared by the girls of Home Science Department under the supervision of their lecturer, Dr. Neha Bhandari. I mean, I must say, that lady, and even yesterday she was telling me, ma'am कुछ और करवा दीजिए. मेरे को कुछ इनोवेटिव आइडियाज आते हैं ऐसे चैलेंजेस में. Yesterday night I had a word. Then kutki ka cutlet, then kangani smoothie. These are things which the students made. If the girls could do it, even we can it. Then the kodo millet kofta, then the kodo payasam, then you have the jawar roti, and just see what they all did it. And this was actually the cake they baked on the very first day. This was a ragi cake they baked on the very first day, and we inaugurated the 4-week challenge by cutting that cake. So this was the concluding day, and I must say the press was surprised, and press wale, they used to wait for me, ma'am, आज क्या बन रहा है SSD में? और सारी press वहाँ होती थी. I mean, even they used to this. हमने कभी सोचा नहीं था इतना अच्छा कुछ millet से बन सकता है. So, this is my favorite place in Punjab. Various restaurants, hotels, they have added millets to their into their menu. I don't know if you have had a chance to visit this restaurant in Mohali. If anyone has, should be able to speak out the name. The name is very interesting, Jhumru. It's a restaurant in Mohali. And this is the ragi dosa that my husband and I are both having it. And I first tasted it, my class fellow made me visit that restaurant, and I took my husband the next day. He says, नहीं मैं नहीं जाऊँगा, पता नहीं क्या होगा. मैं कहा आप चलो, अगर आपको पसंद नहीं आया आप नॉर्थ इंडियन खा लेना. Now whenever we visit Mohali, हमारा lunch dinner वहीं होता है. That is it. बस मोहाली जाने का एक मकसद होता है. This is Jhumru, and this is the malpua with kheer. This is a millet malpua with kheer, and kheer also not rice kheer. Sir, they are. You must visit that place. So, It is a tradition that has been reinvented, and millets have been taken beyond our thalis. Whenever we imagine a millet roti, क्या सोचते हैं? Hard सी, लोग क्या describe करते हैं मेरे को? सीमेंट जैसी hard होती है रोटी, सूखी होती है. Day before yesterday, I'll show you in the end. मुझे कल रात को एक slide मैंने वो add की है. A branch manager of a bank visited and what he did after that. See the roti, the cookies, then the puffs, everything has come up. So the ingredients are actually the same. कहते हैं ना, चाल में नज़ाकत आ जाए या attitude add कर दीजिए, तो चीज़ बदल जाती है. So that is what we have done to millets now. And the chefs are doing it internationally. So gluten-free, again the last lecture, dentists was talking about glycemic index. So rest all I have already said. Now, फिर वही बात, कोई नहीं बनाएगा आजकल इडली 45 मिनट स्टीम करके, सब सूजी से बनाने लग गए हैं, 2 मिनट लगते हैं. Isn't it? कोई दाल चावल नहीं भिगो रहा है. So, बट अगर आपको 10 मिनट में हम कह दें कि हेल्दी कुछ खाना मिल जाएगा in 10 minutes, I think you should be in today's world where we are very busy and we don't have time, especially the women who are all working, shortage of time. If they are told that instead of those so-called 2-minute ready to eat, if you can spend I think 10 to 15 minutes. So that is what we are doing. And if you tell them इसमें carbs नहीं है, आप एक ग्लूटेन बोलिए, दूसरा कहिए इसमें एम्प्टी कार्ब्स नहीं है, सब बनाने लग जाते हैं. We are here to reclaim, reinvent and relish them. So they aren't a trend, they are actually a return with some new flavor, form and fire. They are getting the attention that they actually deserved, but we forgot them. I have already had a part. Now, just small diabetic friendly. Why diabetic friendly? I was giving a talk in one of the parks in Bathinda, and a branch manager came up to me कि मैम मेरा sugar 200 plus रहता है. So I heard you talking a few months back, and I am totally on millet diet, and his sugar was controlled and off medicine. I turned allergic to gluten. I went off gluten. I turned a hypertensive on 2 drugs, morning, night. I am off wheat and my night dose has disappeared. Hypothyroidism, if you tell your patients, please be strictly gluten-free on pure millets, but which one to take, that has to be decided. You will realize after 3 months, your patient's L-toxin dose would come down to half. But yes, it has to be religiously followed. ये नहीं कि 2 दिन खा लिया, बीच में नहीं मन किया, आज पेस्ट्री खा लिया. That is not done. So, cardiac patients, then psychiatric patients, GI, gastroenterologists, everyone is saying yes, it is helping. Digestive system, why? Because they are rich in fiber. Millet has some prebiotics, and it is important for the gut health and immune system in general. So people with celiac disease, even the gastroenterologists nowadays are saying, I don't know, Dr. Vittal would be able to tell you much about that. They say it is there in our books that patients with ulcerative colitis, if they can go gluten-free, they will be off their medication and symptom-free. So I have a very good friend of mine, one of my colleagues, she has ulcerative colitis. Once I just told her, for a week she was off wheat and everything, and she says yes, but she says mushkil hai banana. I mean, she's still taking that medicine and has those symptoms, but जब भी नवरात्रे आते हैं, व्रत रख लिए 2 दिन, she says मैं पूरी symptomatic free होती हूँ और मैं medicine भी नहीं खाती हूँ. So tradition. अब आप we'll talk something of नवरात्रे 6 months once आते हैं, twice a year. So see how religion was actually related to science. 9 दिन के नवरात्रे, what are we there eating? Gluten-free diet. It is purely gluten free. It is that detox fab jo aajkal chal raha hai, which the younger population is spending thousands, that is the fees they take, 25,000 to 30,000 detox karne ke liye. तो हमें तो detox करना हजारों साल से सिखाया जा रहा था, every 6 months. 9 days we were fasting, we were off wheat and sara anaj, and what we were taking, only gluten free diet. So that was the best way. I think that was the best way. Or we were purely on fruits. I mean, there are two choices. Either you are on a gluten-free diet or you are on fruits. So that is how you were detoxed every year. And even nowadays it is being, अब क्या कर रहे हैं लोग? पैसे देते हैं और 3-3 महीने के लिए detox करते हैं. वो कहते हैं ना 50,000 स्पेंड किया तो वो थोड़ा सा मोटिवेशन मिलता है, 50,000 लगा इसीलिए वीट नहीं खाना है, बेकरी प्रोडक्ट नहीं खाने हैं. So that is how it is nowadays. So millets contain magnesium. We all know what it has a role. Then it elevates the levels of, this has been the research proven things that it has elevates the levels of protein adenopectin, and so it is also cardioprotective. Improves the mood. Why? Because it has a very high concentration of tryptophan. We all know that it is a mood elevator. Then diabetes, I have already said, and obesity, we all know it is helping. If not, yes, it will bring your weight to a standstill. It will not increase further on. Then dementia. A high-fat diet, we all know, it has, I don't know how many of you are aware, but if you talk to the neurologists or the people working in it, a high-fat diet is a risk factor for the development of dementia. And if you put the patient on millets, then it increases the oxidative stress, and that is why this is reducing dementia in patients. It will increase wound healing, maintain bone health, so on and so forth. So I already said climate, pani nahi chahiye, no chemicals, soil health is maintained, water efficiency is maintained. Now, by increasing awareness, promoting production, integrating millets into our diets, let's first harness their nutritional and environmental benefits. If we as doctors can do it, and we can advise our patients to do it, don't take the patient as a patient कि इसको medicine लिखनी है तभी मेरे पास महीने बाद आएगा, hypothyroid तभी आएगा, diabetic तभी आएगा. Our role has to be more of now a curative one. Medicines are not curative for these chronic diseases. We know most of us are, so many of would be hypertensives, diabetics, hypothyroid in this sitting here. And if we turn on to millets, I switch over to millets, you will realize you will be off half your medications. At least I am. I was a hypothyroid, I have reduced the dose, I was on 2 medicines, 1 has gone down. So that, touch wood, no diabetes. So that is a difference. So please do it. And now, पढ़े लिखे नहीं सिर्फ करते, आप देखिए what the tribals are doing. The so-called, जिनको हम illiterate कहते हैं, education and literacy are 2 different things. So there's a very famous name, Lahari Bai. She is known as the millet woman of India. She's a tribal woman. Just 2 minutes, I will take. So in 23 Republic Day पे tableau था पूरा लहरी बाई के नाम का. She was honored by the Prime Minister. Then we have the Queen of Millets. She is Raimati Guria. She again is from Odisha, and she has saved 30 varieties of millets and 72 varieties of traditional wheat. आजकल जो हम खा रहे हैं वो hybrid है. So, and this is Dr. Khadarwali. This is what we did in Bathinda in 21. We had FSSI had organized Eat Right melas and walkathons, and in Bathinda it was a huge success, although we had a downpour those 2 days, a walkathon, and this is the various, we served only millets in this mela. So then the deputy commissioner there, and see he's relishing he had proper lunch, 100% millets. So We will have to reimagine millet recipes, bridging the gap between culinary traditions of our grandmother and today's innovative food trends. These versatile grains allow us to celebrate our heritage while embracing modern flavors and techniques. Whether it's a nostalgic dish with a contemporary makeover or an entirely new creation, they provide perfect canvas for delicious, nutritious, and sustainable millets. So please dive into the world of millets and enjoy the best and of both worlds, time-honored tradition and contemporary flair. This is the millet roti, the manager. Now this is the tip. I added this last night. Anyone, if इसको मैं एक टिप बता देती हूँ, आप थोड़ा आपको if you ask someone कैसे बनाना है, आटा बॉईल कीजिए मिलेट का, बॉइलिंग वाटर में आप स्पून से फिर उसको कवर कीजिए एंड देन यू नीड इट एंड प्लीज़ आई डोंट हैव दैट टाइम. मैं डेली सुबह मिलेट की रोटी अपने और अपने हस्बैंड के लिए बनाती हूँ. बड़ा सिंपल सा टिप है. ईसफ गोल आता है, नॉट द मेडिकेटेड वन, वो सिंपल सत्य ईसफ गोल. 2 ब्रांड्स का बेस्ट है, डाबर टेलीफोन, वही हम लोग सब यूज़ करते हैं. जस्ट इफ़ यू हैव टू मेक 4 स्मॉल चपातीज़, तो 1/4 टीस्पून ऑफ ईसफ गोल को आप पानी में सोक कर दीजिए. वो कटोरी भर जाती है, स्मॉल बाउल. उसमें प्लीज़ नीड दैट फ्लोर एंड देन यू कैन मेक इट लाइक अ व्हीट चपाती एंड दिस इज़ अ ज्वार रोटी. एंड ही सेंट मी दिस फोटोग्राफ रात को 8:30 बजे when his wife made it for him. So that is what it is, and I believe this was the first session, and I believe we can have another speaker next year on millets, maybe a more scientific approach. This was just a basic introduction. Thank you.
Thank you very much. सब तो ज़्यादा ताड़ियाँ बजियाँ जी थोड़े. Without telling, so that is an indicator of your lecture and reinvention of millets, what people are going to think, and they will definitely try the isabugol thing to make a chapati.
You can all try it today
and
itself. It
thank
works.
you.
It works. It does wonders.
Thank you very much. As we were discussing, we will request you for next year 3 lectures of preventive part on diet and millets. So give me good speakers. So we will be honored, क्योंकि तालियां बताती हैं कि हमको 1 से 3 लेक्चर की तरफ जाना चाहिए. ठीक है जी. And contact the Millet Man of India. So we can have fun 1 4-hour of session if he comes to Bathinda. So that will be a great honor as guest of honor. So, definitely, definitely. Definitely. Thank you very much. So with this, we proceed to the next lecture by Dr. Meghna Gupta. She is Executive Organizing Secretary of MAPICON, most critical person. So whatever you see is corrected and approved by her. So give her a big hand to talk about an important topic, that is preventing suicide among youth. So this is there in each and every newspaper daily. So this is a very sensitive topic. Dr. Meghna Gupta, please.
Hello. So I'll be speaking about preventing suicide among youth. Introduction. Suicide is derived from the Latin word and it stands for self-murder. It is a fatal act that represents the person's wish to die. So suicidality ranges from thinking about killing oneself to acting out and performing the act. Suicidal ideation is more common than completed suicide, and most people who commit suicide have a psychiatric disorder at the time of death. So some definitions: deliberate self-harm. It refers to willful self-inflicting of painful, destructive or injurious acts without the intent to die. Suicidal attempt. It is a self-injurious behavior with a non-fatal outcome, but with the evidence that the patient intended to die. Suicidal ideation, it includes thoughts of serving as the agents of one's own death. Suicidal ideation may be passive or active, and suicidal intent refers to subjective expectation and desire for a self-destructive act to end in death. Lethality is the danger that the method has with that objective danger to life associated with a suicide method or action. As per WHO, suicide is defined as the act of killing oneself. The act must be deliberately initiated and performed by the person concerned in full knowledge or expectation of its fatal outcome. So September is National Suicide Prevention Awareness Month, and it is very appropriate that we are having this talk over here. Epidemiology, as per WHO, 2019 estimates, suicide is among the leading causes of death worldwide, with more than 7 lakh deaths every year. It accounts for approximately 1.5% of all deaths, and deaths due to suicide are more than those due to breast cancer, war, and homicide. Suicidal death rates are likely to be even higher, but suicide is underreported. Amongst young people, that is 15 to 29 years of age, suicide is the 4th leading cause of death globally, and the first few causes include road injury, tuberculosis, and interpersonal violence. 77% of suicide deaths occur in low and middle income countries. 1 death by suicide is reported every 40 seconds. So in India, we have around 1,70,000 deaths due to suicide in 2022, and it is a 27% jump from 2018. In 2021, according to NCRB data, 13,000 students committed suicide. Every hour, 1 student commits suicide, and the attempts range till up to 30 every day. A study conducted, which was published in Lancet, stated that suicide death rates in India are amongst the highest in the world, and the largest proportion of adult suicides occur between 15 to 29 years of age. So some statistics. So per 1 lakh population, the suicide rate in India in 2021 were 12 deaths that were occurring due to suicide. The proportion of men that commit suicide is higher than women, almost double, more than double. And the modes included hanging with the highest frequency, followed by poisoning, drowning, immolation, death due to vehicles and trains, and jumping. So if we look at state-wise data, so there are states which have death rates above 20, which is Kerala, Tamil Nadu, Telangana, Chhattisgarh. So Punjab comes in the range of 5 to 10 suicide deaths. So most of the victims who committed suicide were below 45 years of age, and most of the proportion of such individuals were daily wage workers, followed by housewives, self-employed persons. So risk factors for suicide can be divided into individual factors, relationship factors, community and societal factors. Amongst individual factors, the most important risk factor is previous suicide attempt, followed by mental health concerns, social isolation, history of substance use. Amongst relationship factors, adverse childhood experiences is a very important risk factor. Then bullying, family history of suicide, family or peer conflict. Community and societal factors include barriers to healthcare, stigma associated with mental health or help seeking, and easy access to lethal means, unsafe media portrayals of suicide, and systemic trauma or marginalizing experiences based on socioeconomic factors, race, ethnicity, gender or sexual identity. So various causes, most common were family problems, which contributed to 33% of the people committing suicide, followed by illness, addiction, marriage-related issues, and unknown causes accounted for approximately 20%. So it's very important to recognize the signs. Whenever we see a patient, we have to identify the signs and address them so that the risk of suicide is nullified. So whenever you're in doubt, you have to question, ask the person. Questions specific to suicidal ideation are very important. One must be persuaded to seek help, and then further referral to a psychotherapist or a psychiatrist should be done. So there are some direct verbal cues that the patient might give in the OPD. Certain factors like saying, I've decided to kill myself or I quit. These cues suggest the risk of suicidality in a person. Some indirect verbal cues, such as that people would be better off about me, it's not like you all want me here, and things on social media. People might put depressive things or things that are suggestive that one is depressed and are thinking or contemplating of suicide. So all those cues should be picked up. This behavioral warning signs are there, like sudden interest or disinterest in religion, giving away prized possessions, decline in academic behavior, high-risk impulsive behavior, drug or alcohol use or relapse, and physical symptoms such as changes in sleep and eating patterns, headaches, stomach problems, menstrual irregularities. Any talk of suicide or making a plan, stockpiling pills, purchasing poisons, self-destructive acts like cutting, all these suggest that the person has a strong wish to die and there's preoccupation with death. One might withdraw from family, friends, and society, may seem anxious or depressed, expresses no reason to live. The statements of hopelessness and despair and unexplained anger, aggression, or irritability may also be present. Situational warning signs, these are triggers that might increase the chances of a person suffering from a psychiatric disorder to commit suicide. So these include being expelled, loss of any major relationship, death of a friend or a family member, loss of any influential mentor or teacher, family problems, diagnosis of a serious illness, sudden unexplained loss of freedom or fear of punishment like being imprisoned. Other situational warning signs include feeling embarrassed or humiliated, victim of bullying or cyberbullying, disappointment or rejection, financial problems, feeling trapped with no way out. So there are certain college-specific stressors which young adults often face, due to which their risk of committing suicide increases. These include difficulties adjusting to a new environment, lack of adequate coping or social skills, academic and social pressure, feeling of failure or decreased performance, sense of alienation, lack of social support, onset of mental illness, bullying, financial stress. So this is how a suicide crisis episode appears. A person who has been stable for many years suddenly encounters some sort of a stressor, which might be internal or external, and the crisis begins, which can last for days. Then within hours, the crisis peaks and the risk of suicide is most. Then gradually, if the patient does not commit suicide, the risk diminishes and patient again becomes stable. So these are factors which present as resistance to committing suicide. These are all protective factors. So these include having counselor or therapist, seeing your job or your other daily activities as a duty to others, ki bacche paalne hai, EMI parni hai, all those things. Sobriety, that is one person who's not currently abusing any drugs. So that is a protective factor. Good health, if a person is on antidepressants, so compliance to medications is a protective factor. Fear of the unknown, or fear that if they do not succeed in a suicidal attempt, they'll be left with a lot of comorbidities, so fear of that. Job security, responsibility to children, difficult access to means, all these are protective factors. And most important, what we used to be taught in our post-graduation, which is the one situation in which a patient will not commit suicide. That is when the person is sleeping, right? So if a patient who presents in active suicidal crisis, sleep is going to be a huge protective factor. And the most risk to commit suicide is when others are sleeping. So in wee morning hours, the risk of suicide in a patient who's suicidal increases manifold. So most important is that it is okay to ask direct questions. Addressing the thoughts of suicide must be done, and we should listen to the person with empathy and extend support. So talking about suicide has some basic rules for intervention. That is, one must not judge, lecture, or get angry. If a patient tells you that, or anybody around you, your friends, family members, people often have this reaction ki tu sade bare nahi socha, how can you do this? So all those things are going to further increase the sense of alienation, further leading them to suicide and not actually preventing them from doing so. Secrecy should not be promised. In any person who has any suicidal ideation, we must not tell them that whatever they are informing us is confidential. Most psychiatrists usually tell people that everything that they're telling you during the course of history is confidential. But in case of suicidality, secrecy cannot be promised. One must not get over-involved, and the patient must not be left alone. So it's a 3-step intervention, which basically includes listening carefully, being genuine, asking questions, asking about suicidal ideation, and making sure that we get them help. They are not left alone. Medication can be started, or they are asked to see a psychiatrist or a psychotherapist at the earliest. So asking direct questions about suicide does not increase suicidal ideation. And one must take care of ourselves also. We must acknowledge the intensity of our feelings. We must seek support. We must share our feelings and avoid over-involvement. And we must always acknowledge that no one person is responsible for another person's choice to end their lives. So another important entity is inevitable suicide. We come across media and everything saying that suicides are preventable, but we must always remember suicides are not 100% preventable. Over 1/3 of all completed suicides occur in persons who are receiving treatment for psychiatric disorders. Some receive the best care, but still the suicides cannot be prevented. A study done showed that almost 1 in 5 people who died by suicide had seen a mental health professional. So for a suicide to be considered inevitable, certain criteria must be met. There must be strong history of suicide in family members, heavy genetic loading of psychiatric disorders, history of physical, emotional, or sexual abuse, history of divorce, unemployment, male gender is more prone to completed suicides, and recent discharge from a psychiatric hospital, prior suicide attempts, drug addiction, presence of medical illness, persistent suicidal thoughts. In these cases, even the highest standard of treatment cannot prevent the suicide from occurring. So we must always remember that we should do everything that we can, but we must know that we cannot do everything. So take-home message is that talking about suicide does not cause it. And almost all people who die by suicide talk about it. So when they are talking about it, if we get them help, the suicide can be prevented. There are almost always warning signs. We must pay attention every time. Suicide can be prevented, but it is not 100% preventable. And anybody can learn to intervene. Thank you.
Very much. And suicide in young is becoming a great public health issue. And I think each and every person should be aware of where they can interact and intervene to try to prevent suicide whenever possible. And as physicians, we treat depression daily, and I think they should know when to refer. What I do in my OPD, you have given the warning signs. If someone is going to tell me, "Ke ji mera maran nu dil karda hai," I stop there and then I refer that patient to a psychiatrist. And referring to a psychiatrist is again a stigma. But there you should put your foot down that I am not going to treat. You have to go to a psychiatrist and explain the importance of psychiatric consultation over the physician consultation. Thank you very much for apprising us about the suicide in young, where we can intervene and try to prevent it wherever possible. Thank you very much. Any questions?
I think what we should, as doctors, do it, that suicide amongst doctors, especially amongst the students, be it undergraduates or the postgraduates, is increasing day by day. Gone are the days when we used to be, when we were doing our post-graduation, the professors would behave in any way. Our times were different, but today's generation, I think it's high time we all changed. We can't just treat our postgraduate students like we were treated. Isn't it, sir?
Definitely, both ways.
So I mean, we have Principal Adesh, I think they are there. Adesh, I don't think, I haven't heard much about from students that we are being harassed.
Especially when Dr. Pramod has taken over.
Yes.
Before
now
that,
I have
it,
not.
the condition was different.
We are being very
Yes.
honest, and that's a feather in your cap
Yes.
that yes, and under your principalship,
He is the
and
most
we don't
student.
have it. We have not heard it.
No, most student-friendly person.
Exactly. But we should be at least talking about it, that the professors, the so-called teachers, I mean, if they want to be teachers, they should learn to be teachers.
Basically,
You can't bully your candidates.
definitely.
No.
Basically, the problem is now assistant professor, 32 years, 35 years are becoming associate professors and 40 years professor. When we were students, the professors were senior. So these students were like their children. Now they are competitors. So assistant professor or associate professor is competing for the same girlfriend as the PG student is. So that is where there is a peer pressure rather than teacher-student relationship. And we graduated from a smaller, humble well-being. There was no separate room in the house. And when we went to the hostel, it was upgradation in the lifestyle. Now it is downgradation of the lifestyle because you have so much facilities at home, and when you go to the hostel, it is a shocker. So that is also going to create stress. So basically it is multifactorial, but what we can do is we can identify and intervene. So that is what we can do. We cannot change the social structure or educate. We can educate our children, and the teachers have the responsibility. We have to counsel the teachers also.
Exactly. Counseling sessions are more important.
Yes.
With peer pressure from the parents also.
Parents also. Exactly.
Like Rajasthan, in the quota, load of almost every month there is one less because they are putting so much
Yeah,
pressure.
quota has.
Sir, when I attended a parent-teacher meet, one parent was fighting with the teacher. So I overheard that the student got 98 out of 100 and she was fighting why not 100 out of 100. So there are 100 students in the class, everybody cannot get it, and we must actually assess how much capability is that and cultivate that capability. Thank you very much. Now we are going to have another enthusiastic young person. So we are contemplating a young people session also from next time. This time also, we have young doctor, Dr. Achal Goendi. He will be talking about acute ischemic stroke, imaging and mechanical thrombectomy, former SR, neuroradiology, AIMS, New Delhi. ਜਦੋਂ AIMS ਦੀ ਨਿਊ ਦਿੱਲੀ ਦਾ ਨਾਮ ਆ ਜਾਂਦਾ ਨਾ ਅੱਖਾਂ ਜੀਆਂ ਫਟ ਜਾਂਦੀਆਂ ਕਿ ਬੜਾ ਇੰਟੈਲੀਜੈਂਟ ਬੰਦਾ ਹੋਊਗਾ ਬਈ, and you are. So I invite him to please deliver his talk. Young versatile person is son of my very close friend, my brother Dr. Tejinder Singh Goendi, and I am thankful to him. From the busy schedule he has taken out the time to come to Bathinda and give me the opportunity to meet my friend also. Thank you very much.
Thank you for your very kind words, sir. So today we'll be discussing about a very important topic, the acute ischemic stroke, and it is perhaps one of the most important medical emergencies which we encounter almost in our day-to-day lives in the emergency setup. So this is the basic overview of what we shall be discussing today, the patient selection and the imaging modalities being used for acute ischemic stroke, and along with that we will touch upon the topics such as what are the criteria and which all patients are suitable to undergo procedures such as a mechanical thrombectomy. So in the course of this next 15 to 20 minutes, we will come across certain clinical and radiological scoring systems which might look complex, but I will try to simplify as much as possible. So the first clinical scoring system which we shall be discussing when it comes to acute ischemic stroke, again, we are talking about ischemic stroke and not about the hemorrhagic stroke here. So the first clinical criteria that is being used right now in present scenario is the NIHS score. So the basic criteria in this is that we assess when the patient comes in an emergency setting and a stroke is suspected, we give scores according to the deficit the patient has. And the crux of this particular scoring pattern is that the more the score is, the more is the clinical deficit. That helps us to decide what kind of therapy the patient will eventually have. Again, another clinical scoring is the modified ranking scale. It basically tells us about the disability status determined at the discharge and again at 90 days, because most patients who achieve functional recovery do so within this time frame. So an ideal time to undergo to have a mechanical thrombectomy is somewhere between NIHS score of 6 to 25 and modified ranking scale of 0 to 1. Then what is the age? Which patients of what age should be having treatment? So there is no as such cutoff for mechanical thrombectomy perhaps. Medical treatment, we won't be getting too much into it because it is basically dependent on the time. Anything which falls in the golden criteria of 4.5 hours and has a stroke and has a clear-cut evidence of stroke should undergo the medical therapy unless it is contraindicated in a few selected cases. But for mechanical thrombectomy, we have certain guidelines which need to be followed. So right now there is no cutoff for the upper age limit, but perhaps as the age increases, the outcome of the treatment is likely to decrease. So pre-treatment imaging with acute ischemic stroke, how will we establish a stroke? Why is imaging important? Because it allows us for the assessment of intracranial hemorrhage. A simple modality like a non-contrast CT will tell us whether it is an ischemic stroke or a hemorrhagic stroke. And then certain higher investigations like CT angiographies and MRI and MR angiographies can tell us exactly where the site of occlusion is. And the studies like CT and MR perfusion can also tell us whether the tissue is salvageable, the brain tissue which is undergoing infarction, how much of it is salvageable and whether the therapy will work or not. So according to the 2018 American Stroke Association recommendations, it is reasonable to perform vascular imaging before performing a renal function test in patients without a history of renal impairment. So they say कि भी हमने RFT नहीं हुआ है patient का, contrast देना चाहिए नहीं देना चाहिए. That should not be done in emergency situations like that of a ischemic stroke. If the patient has had no prior history of renal dysfunction and the patient has presented with stroke-like features, immediate vascular imaging should be and must be done in all these cases. So on NCCT, how do we identify what are these fancy signs which we see on NCCT? What are these signs of ischemia? It can be some insular ribbon sign, lentiform obscuration sign, disappearing basal ganglia, focal hypotenuation, cortical sulcal effacement. These all hi-fi terms, basically what it means is that the gray-white matter differentiation is basically lost. That is the first and foremost feature which helps us to identify that an ischemic stroke is happening. So in these few images here we can see basically that this is the lentiform area which is being obscured, the insular ribbon is lost. And again, in this last image, we can see that the middle cerebral artery on the left side is appearing bright as compared to the right side. So this bright linear structure is nothing but the clot within the proximal segment of left MCA. So these are few features with which we can determine how a stroke appears, especially an acute ischemic stroke, the early ischemic stroke appears. And then we come on to a very important radiological score which is called the aspects. What an aspect score is that for the anterior circulation especially, we divide the brain in 10 zones. And for each area where we see that the stroke is happening, we keep on deducting points. So basically aspect score of 10 means a good brain, a healthy brain, and an aspect score of 0 or 1 would mean that a large volume of the brain has been involved with and is going to get infarcted. So basically why this aspect score is important? It helps us to decide whether medical as well as endovascular treatment is recommended or not. And a score of greater than 6, basically a lot of trials have happened and are still ongoing, and they have reached to this conclusion that an aspect score of 6 basically gives a good prognosis with medical as well as endovascular treatment. Then similarly for posterior circulation, the primary aspect score was for anterior circulation. So if there is a posterior circulation territory stroke, for that we have something called the PC, or the posterior circulation aspects. Again, it is based on the similar principle, a 10-point scoring system, but this time instead of the areas of the anterior circulation, we will have the posterior circulation areas like the brainstem and the cerebellum. Instead of the 6-point scoring of aspects, we will have the 8. Anything above 8 is good outcome, and below 8 means it will have a poor outcome. Then the next imaging modality we use is CT angio, which is perhaps a very important modality to decide whether one should go in for a endovascular approach or a mechanical thrombectomy. What a CT angio helps us to helps us in identifying the exact site of the thrombus as to which vessel is involved, whether it can be approached through endovascular route, and whether it can be retrievable, the clot can be retrievable or not. All of this information we can have a fair amount of idea with the help of CT angiography. And there are various types of CT angiography which can be done. The most common one being done these days is the single phase CT angiography. It is nothing but just a plain contrast is given and a scan is acquired one time, and that gives us the information of the clot, where the clot is, and how we can go about it if we have to go in for a mechanical thrombectomy. It also gives us information about the clot burden score. Clot burden score is nothing but the number of vessels in which the clot is present. It is again a 10-point scoring system. The more number of vessels filled with clots, the lesser is the score. So basically lower score means lower functional outcome, larger final infarct volume, and a higher risk of parenchymal hemorrhage. CT angiography source images, again, as we can see in this particular image, the contralateral side has good perfusion, whereas the infarcted area, we can see that there is no perfusion whatsoever. So this is one of the important advantages of doing a CT angiography, single source. Also, we can have a fair amount of idea with the collaterals about the collaterals of that area with the CT angiography, because a patient who will have a good collateral circulation, we will have more time in that particular subgroup of patients who have good collaterals to act upon, because the perfusion while a stroke is happening will be maintained with the help of collaterals for a longer time against those people who will have bad collaterals or poor collaterals. And for collateral scoring, the better modality to use is a multiphasic CT rather than a single phase CT. So in multiphase CT, what the main difference is that we acquire the CT scan after giving contrast repeatedly for 3 times. So once an arterial phase is acquired, followed by a capillary phase, followed by a venous phase. So if we acquire multiphasic CT, even if there is delayed filling of the collaterals, we can have a better idea of the collateral circulation, and that will help us to decide as to how the treatment will help and how much time we have when we are proceeding towards the treatment. So this is again the collateral scoring systems, which is basically the higher score depicts that it is a good collateral, and 0 meaning the collaterals are basically absent. Then comes another very important topic, which is the perfusion imaging. So why is perfusion imaging important? it is mostly important when the stroke is outside of the golden window of mechanical thrombectomy, which is mostly considered as the 6 hours. So any stroke which presents after 6 hours of onset. So in this, perfusion imaging is recommended. Why is it recommended? Because it helps us to delineate what is the amount of core. What is core? Core is nothing but the tissue which is already dead and it cannot be revived. So perfusion helps us to decide how much is the core and how much is the penumbra. What is penumbra? Penumbra is nothing but the tissue salvageable. The salvageable tissue which can be revived if we give proper medical therapy or we give the endovascular therapy or both. And then there is an entity called benign oligemia. Perfusion also helps us to delineate that, because these benign oligemia patients will respond on their own without any therapy as such. So these are the perfusion parameters, the relative cerebral blood flow and the cerebral blood volume, and the mismatch between these parameters, the clinical cerebral flow and the volume, will help us to decide which part of the brain is the core and which part of the brain is penumbra. And these are some basic profiles, and the ones we will target in this on the perfusion imaging are the target mismatch population, in which there is a relatively small core, higher sized penumbra, and the PC mismatch ratio, which is the core to penumbra mismatch ratio, is greater than 1.2 to 1.8. Again, these are all automated softwares which are available, which help us to decide which are the patients that have to be undertaken and which need medical or endovascular therapy. So then what is the role of MRI imaging when it comes to ischemic strokes? MRI imaging is very important, but due to the limited availability of MRI in all setups, it is not being used so often. But the most important sequence or perhaps the most sensitive sequence which is being used nowadays is the diffusion weighted imaging. It is one of the sequences which can catch strokes even after like half an hour of onset, and there is no other modality which can pick up acute ischemic stroke so early. And then there are other sequences such as FLAIR and gradient echo imaging, which also helps in assessing the stroke. So diffusion I have already talked about. What is the importance of FLAIR imaging? So suppose you have a clinical scenario where a patient goes to sleep totally fine, no deficits when the patient went to sleep, and when the patient woke up, you suddenly see that there are clinical deficits, there are significant neurological deficits. In these particular subgroup of patients, we don't know when was the actual time of onset, because stroke happened sometime during the sleep. So to decide whether the patient is still in the golden window, we will look at the diffusion images, which will tell us about the exact area of the stroke, and we will try to match the same pattern with the FLAIR imaging. So if there is a diffusion FLAIR mismatch, basically meaning that the stroke is fresh, there are bright signals on DWI images, no corresponding bright signals on FLAIR imaging, go in for the medical management right away, because the patient is in a golden window period and patient can be saved from significant neurological deficits. Susceptibility imaging will help us to delineate the clot. Just like CT angio, it is another modality with which we can see the clot as well as the microhemorrhages present between the infarcted area. All these things can be depicted with the help of a susceptibility weighted imaging. Again, an MRI based sequence. So the early window, as I already talked about, aspect score of more than 6, patient having a large vessel occlusion presenting within the 6 hours of symptom onset, having a small core and a large penumbra, one has to go in for a mechanical thrombectomy, no questions asked. The problem lies when the patient falls outside of the 6-hour window period. In these particular subgroup of patients, which is mostly the case because very few people present within the golden period, in these particular subgroup of patients, there have been 2 very important trials which have happened, the DAWN and the DIFFUSE 3 trials, And according to these, these trials recommend perfusion imaging, and they have laid certain criteria as to which patients after the golden window period can undergo endovascular treatment. So these are some other landmark trials which have happened. Still, a lot of work and research is still being done, and it is a ever-evolving topic. And there are some subgroup of patients with limited evidence. What are these subgroup? Patients with a score, NIHS score of less than 6. Basically, they have good collateral circulation, and again, we have very limited work in this, whether endovascular treatment is beneficial in this particular subgroup of patients. Again, in large ischemic core, where already the core size or the dead tissue is large and there is very less viable tissue, whether to go in for a vascular therapy in such cases or not, endovascular therapy in such cases or not, that is a question mark still. But the trials which have happened, they have shown that it does have a good improved clinical outcome even if we go in for endovascular therapy in such cases. But there is no criteria as of now, established criteria. Same is for the case for posterior circulation stroke. The best trial has happened, but again, main work or the higher, still a lot of trial work is still going on. And same is the case for a distal vessel or small vessel occlusion. The main problem with distal occlusion is it is difficult to access these smaller vessels and to retrieve the clot from these smaller vessels. So to summarize, what we have discussed is age group more than 18, modified ranking scale of 0 to 1, NIHS between 6 to 25, aspect score of more than 6, large vessel occlusion present, and time less than 6, go in for the endovascular and medical treatment. Between 6 to 16 hours and 6 to 24 hours, you have to decide on the basis of perfusion imaging whether to go in for a vascular treatment or not. And this is a complex looking chart, but it basically signifies the same thing. Also in cases of wake-up stroke, we can take the help of MRI and decide which path to follow. And this is how we can make a difference. This is a patient who presented within the golden window with the right MCA cutoff. There was no circulation. There would have been a large infarct in the MCA territory with with disability for life, but with suitable therapy and mechanical thrombectomy, we were able to recanalize the whole thing, and the patient improved on table and walked out of the hospital with no deficits whatsoever. I thank you all for your very patient listening.
Thank you very much, Dr. Achal. So basically, we are evolving in cerebral system as we are doing in primary PTCA for heart attacks.
Totally, sir.
And definitely great talk, apprising us all the latest modality and how we should proceed. So that also is a awareness program for physicians when to refer and immediately refer, because in our region, once patient is having stroke, so they give just a little bit of OPM. कि जी अफीम देती सी ਉਹਦੇ ਨਾਲ ठीक हो गया. And अफीम is one of the biggest treatment modality in rural areas because of lack of awareness.
Yes.
So thank you very much. If there are any questions.
Basically in stroke we have a saying. In normal saying goes like time is money.
Yes.
Well, in stroke it is time is neurons.
Yes.
With every passing second you are losing important neurons. So you have to be very careful with the window period, and you can't be कि कोई नहीं देख लेते हैं, हो जाएगा, कर लेते हैं. You know patient has stroke, you have to act promptly. The more prompt you are with your approach, the better it is for the patient. It can be, trust me, it can be life-changing for the patient. You can actually help the patient from serious lifelong disability if you just happen to do things on time.
But here, अफीम ਦਿੱਤੀ ਸੀ ਜੀ ठीक नहीं होया ਤਾਂ ਤੁਹਾਡੇ ਕੋਲ ਲੈ ਕੇ ਆਏ हैं. So that is the issue. Thank you very much.
I would like
Great
to thank
talk.
you, sir, for giving me this opportunity.
No,
really.
no, you deserve. All the young people deserve, or we are going to reserve 30% of the lectures for below 35 years of age. enthusiastic speakers. But this is because at that stage we were also given chance to speak. Pehle wari jado bolde si, hun jado we see our slides previously in 1995. Sometimes we think, yaar, acha aise bolte the hum, aisi slides banate the. So it is evolving, and I must congratulate my mentor, Dr. Gurpreet Singh Wander, who gave me the opportunity and boost and motivating thing to do academics as well as lectures. So we wish you all the best for future, and MAPICON is always going to give you opportunity next year also. Please note down the dates. So it is great honor to have our young children progressing.
Thank you so
very
much. Thank you.
And next in line is Dr. Parth Bansal. He is Consultant Orthopedics, Spine and Trauma, Max Hospital, Mohali. He is also going to speak on important topic, osteoporotic vertebral fractures, a silent epidemic. So osteoporosis, nobody thinks it is a disease. And Dr. Parth is also son of my great friend, Dr. Arun Bansal. So it is great pleasure to have you here.
Thank you so much.
So
sir.
we are really honored.
Thank you so
Thank
much.
you.
Good afternoon, everyone. So let me talk about osteoporotic vertebral fractures. When we think of osteoporotic fractures, the first thing that comes to our mind is probably hip fractures. That is how it works for everyone else. But can anyone tell me, like, what is the most common osteoporotic fracture in any age group? Generally speaking, yes, sir, you're right. It's the vertebral fractures. They have a 3 times more incidence than hip fractures, and they have a similar mortality rate, 1 year and 2 year mortality rate as compared to hip fractures, but they are not as widely recognized. So let's start talking about this. Let's talk of a typical patient, maybe a 76-year-old female. They'll present to you with a trivial fall at home. Lot of the times they are neglected. Lot of the times they don't even fall. It's just a rotational injury, sudden jerk or something. They'll have severe backache, and the X-ray, if done, will show a wedge fracture. Just a very simple case example. So what is osteoporosis? First of all, it is a reduction in the mass of bone per unit volume, and 1 in 2 women and 1 in 5 men above the age of 50 will suffer an osteoporotic fragility fracture in their lifetime. This is as high as that. So again, coming back to the first thing, the most common fragility fractures, they are vertebral, followed by the forearm, wrist, hand, other regions, and hip and femur is also very common. Subsequent fractures after suffering one fragility fracture, also vertebral fractures are the most common types of fractures. So why is it a silent epidemic? First of all, in 80 to 90% of the cases, it's a missed diagnosis. Symptoms are ignored and attributed to back pain of old age. Most commonly, they occur at junction of T12 to L2 in the thoracolumbar junction. And so we have data worldwide of osteoporosis, osteoporotic fractures and everything, but the data and statistics from India are very limited. They are confined to small localized study groups. We don't have data from large groups. Estimates say that over 20% of women over the age of 50 have osteoporosis. Osteoporotic fractures occur a decade earlier in Indian patients as compared to Western counterparts. Widespread vitamin D deficiency, almost more than 80% in the Indian population. And prevalence of osteoporosis has been estimated to be 10 to 55% in women and 3 to 20% in men. This was a study done by the Delhi Vertebral Osteoporosis group, and they said that in just screening X-rays, screening thoracolumbar lateral X-rays, they found that 17.9% of patients had a prevalence of vertebral fractures which were undiagnosed and just detected. So we know that these fractures are occurring, we know that these are coming up, but then why are we worried because of them? First of all, they are a major cause of acute and chronic lower back pain. They decrease the quality of life. Chronic compression due to fractures can lead to kyphotic deformities, altered biomechanics of the spine, which can lead to pain in hip, knee, and generalized body pains. Once a patient has a fracture, the risk of future fractures increases by at least 5 times. If a patient has multiple fractures, the lung capacity can decrease over time, and this can cause multiple morbidities. And like I said before, the 1 year mortality of these fractures is equivalent to hip fractures. So how do these occur? Mostly these will occur due to an axial loading of a weakened structure. The spine is weakened and then it gets loaded axially either in a fall or with the weight. They may be accompanied by some rotational forces. Most cases it is an anterior wedge compression fracture, but in some of these cases they may extend to the posterior elements as well. And coming to the risk factors, we have both non-modifiable and modifiable risk factors. So age is directly correlated with the occurrence of osteoporosis and the occurrence of fragility fractures. It is more common in females. In Caucasian women and Asian women it is more common. Hispanics and blacks it is slightly less common. And post-menopausal females have a massive decrease in their bone strength, and so osteoporosis is more common. Genetics plays a role and a history of osteoporotic fracture. These are all the non-modifiable fractures. When we come to the modifiable fractures, the first and foremost is obviously osteoporosis, because osteoporosis, if screened, detected and treated, we can prevent the occurrence of these fractures. Low BMI is a major risk factor for these fractures. Inactivity, most patients above the age of 55 or 60, a majority of patients, they are not physically active, and this leads to a predicament to osteoporotic fractures. Prolonged steroid use, smoking, alcohol and vitamin D deficiency. All of these play a big role in the occurrence of fractures. How do these patients present? So only about 20% of the patients will present in the acute stage with complaint of localized pain, some deformity. A very small percentage, maybe 10 to 15% will have a neurological deficit. This is not common because these are mostly low energy traumas, and so the neurological structures are not affected. And in most cases, this is an incidental finding on screening. If a patient comes to an OPD with a back pain and you get an X-ray done and you'll find that one or two of the vertebrae are compressed. What imaging do we get initially? So X-rays, these are always the first line investigation. They will usually reveal the injury. And these can also be used as an early marker for decreased bone density, although we do not have any quantitative measurement on these, but you can always figure that out. After this, we come to a CT scan. It is not really indicated. It is not commonly done. It is only indicated when the fracture morphology is not clear or when a patient is being planned for surgery and needs to be evaluated accordingly. An MRI is absolutely must when we detect these fractures. Why is that? So first of all, we need to differentiate between an acute and a chronic fracture. It changes the pain management protocol. And also very importantly, we need to rule out the differentials in this case. Let me come to the differentials first. So what has to be ruled out? What is important to rule out? We are talking about patients who are mostly more than 60 years of age. So the first and foremost thing that has to be ruled out when you see a compression in the vertebra is a metastatic disease. With men, it will be prostrate, CA lung, CA prostate and large intestinal tumors. In women, it will be more commonly ovarian, breast and uterine tumors. The second differential, again very common, often diagnosed very late, is multiple myeloma. It can cause multiple bony lesions, but sometimes the first place it is detected is in the spine. When we're talking about an Indian population in our country, in our subcontinent, POTS always has to be a differential diagnosis. It can always manifest as a compression of the vertebra, although there will be other associated changes as well. And in very few cases, it might be a primary spinal tumor. But getting an MRI done and ruling these out, along with some investigations which I'll just talk about, is very important. Classification, not really important from a physician point of view, but when we are planning a surgery, maybe we think of what. Basically, we have to see whether one or both of the end plates of the vertebra are involved, whether the posterior structures are involved or not, and whether there's any translation or rotation. So, what investigations need to be done? A complete blood workup as is necessary, a calcium profile, parathyroid hormone, ALP. Bone turnover markers can be done, but these are not exactly aids in diagnosis. But it is very important to get your multiple myeloma markers, which includes the SB electrophoresis, serum, urine for bench-dose proteins, and then your cancer markers, which includes PSA, CA, and CA19-9. These are adjuncts to the MRI, and these can help make a diagnosis. A very important investigation, obviously the gold standard to measure bone density is the DEXA scan. It is now more easily available than it was maybe 10 years ago, but still not as much as it should be, and it is not used as much as it should be. So of the age of 60, actually it should be used as a screening tool every 2 years or so. So in the DEXA scan, the interpretation, if we have a T-score of more than 1, that's a high BMD. -1 to 1 is normal. That's absolutely okay. -1 to -2.5 is osteopenia, which is the range in which a majority of the Indian population will lie if you do a screening. So that will be about 60 to 70% of patients. And a score of less than -2.5 is osteoporosis. So sometimes patients will ask us that why are we seeing, if you get someone who's a little educated, who can read the reports, they'll see, and we get 2 scores on a BMD. We get a T-score and a Z-score. So the T-score is when we compare the spine to that of a 20 to 30-year-old in the same population. The Z-score is when we match the age and gender and compare to that. So why do we use the T-score? The T-score is important because we are trying to get the patient to have the bone density which is in a normal healthy patient. If we take the averages in their own age group, then the scores will be higher, but ultimately the interpretation is flawed. So it's very important to always see only the T-score when you are So let's get to the management. So I would say about 80 to 90% of patients can actually be managed non-operatively. So unless the vertebral height is less than 50% with significant pain, which is not being relieved on pain management, only then we have to consider surgery, or if there is a neurological deficit. So pain management is important. We don't give prolonged NSAIDs. We do have to use some drugs like maybe tramadol. We have to resort to that. And then bracing can be done. It helps to maintain the spinal alignment, helps to prevent future kyphosis, progression of the deformity. But usually bracing has poor compliance in older patients because it can be very hard, especially in the summers. It can be very hard. So bed rest is not really recommended for very long because as in hip fractures, it's very common. We want to mobilize the patient as early as possible. We don't want any of the complications related to immobilization. These will include deep vein thrombosis, bed sores, and basically pulmonary edema because of lying supine. So we want to prevent all that. With a brace, with pain management, we want to mobilize the patient. Calcium and vitamin D supplementation, absolutely necessary, and also anti-osteoporotic treatment. Operative management, so it is only for non-responders to conservative measures. When there is a decrease in the vertebral height on serial X-rays which shows that the deformity is progressing, they may be developing kyphosis, which can then preclude to more fractures as well, or if there is a neurological deficit. There are multiple options. There is a vertebroplasty, kyphoplasty, vertebral body stenting. I'll just give a brief overview of this. But first we need to know what is the goal of surgery. The goal of surgery is bony stabilization. We want to restore the height of the vertebral body as much as possible. That is usually possible more in the acute fractures, but in chronic fractures you can't really restore too much height. Pain relief, absolutely. We want to reverse the kyphosis as much as possible, and again, most importantly, all of this is so that we can mobilize the patient as soon as possible. So these are mostly all percutaneous procedures. You don't need to do open spine surgery for these now. So vertebroplasty and kyphoplasty are essentially similar, but the difference is that we are putting pedicle screw, approaching the vertebral body via the pedicle. In vertebroplasty, we are going to inject the cement directly into the vertebral body, and in kyphoplasty, we are going to put a balloon. We are going to inflate the balloon and then put the cement inside that. The balloon helps to maintain the height slightly more. Now we're coming up with more options. We have vertebral body stenting. Most of the companies now have an implant. Basically, you can just put a metallic stent inside the vertebral body. You can inflate the stent and then you can inject cement or PMMA in that, even hydrogel in some cases. Mostly it is cement augmentation as well, but it helps to maintain the height even better. In very few cases, if there is a deformity, if there is a deficit, if you think even pedicle screw fixation, you have cemented screws, you have fenestrated screws, which can be placed percutaneously, and cement can be injected at all fracture levels. And these are mostly reserved for patients who have a deformity which needs to be corrected. You need to also restore the spinal alignment. Okay, so that is all about the fractures, but let's talk about osteoporosis as well. So we should be screening for these when should we be screening? Women over the age of 60, men over the age of 65, all postmenopausal females or males 50 to 64 if they have any additional risk factors such as steroid use or any other medication, if the patient has a history of a fragility fracture, and if any condition that predisposes to osteoporosis. treatment, first and foremost, is to increase the physical activity. You'll see, we see so many patients in our OPDs, they come to us and they barely have any physical activity. For them, physical activity is just within the house. That is the first and foremost thing that you have to tell them. My personal thing is that I tell patients, just go outside, walk for 10 minutes, 15 minutes. We start with that. If patients are able to, the goal is to get them to start basic weight training. Like just, maybe a 1 kg or a 2 kg weight. Weight training just helps build muscle mass, helps build bone mass, and increases everything. Then we want to limit alcohol and smoking. Prevention of falls is also very important. With or without the history of a fragility fracture, there are simple things that you can tell patients which can help in fall prevention. Using a mat, anti-slip mat in the bathroom, using handrails in the bathroom so that when they're getting up, they don't fall. These are the most common times, bathrooms, and when you're at night time, you'll hear from so many patients that they were going to the bathroom, fell down, more commonly probably had a hip fracture, but we're talking about everything. Dietary intake of calcium, absolutely. High protein diet, 100%, because Indian diet in general has a very low protein, and I think people are slowly becoming more aware of this, but still it needs to be supplemented. Either there are some good protein powders out there, but it is very easy to supplement these in their regular diet as well. And of course, pharmacological management of osteoporosis. The pharmacological treatment of osteoporosis, this includes bisphosphonates, calcitonin, and then we have teriparatide, which is a PTH, and then we have denosumab, which is a RANKL inhibitor. These can be used. There's a proper algorithm for this, but I won't go into details of this. Basically, the point being that you need to refer these patients either to an endocrinologist or an orthopedician who treats these, so that the osteoporosis is treated as well as the fracture. It should be a holistic treatment for the patient, not just one thing. Just a small summary. So these are the most common fragility fractures. Only 20% are detected at the time of injury. Significant morbidity and mortality. And we should always know our goals of treatment, which include pain management, prevention of further fractures, and early mobilization to prevent any complications. Thank you.
And in fact, it was information to me that now stunts are being implanted in bone also. Absolutely. With fracture. So it is stunts in the brain, stunts in the heart was there, stunt in gastrointestinal system, now bones.
Everywhere, sir.
Thank you very much for apprising us such an important modality. But I have one question, whether osteoporosis can be reversed or not with medical therapy or exercise, or you can say.
Absolutely. First of all, we want to stall it. We don't want it to progress. But on medications, again, I think Dr. Sandeep is just going to talk about that, but there are proper guidelines on how you go about treating osteoporosis. I'll leave Sir to it because I think he's...
So thank you very much.
Thank you, sir.
You
Thank
have
you for
justifiably, you can say substantiated my thing that you will be a great versatile speaker.
Thank you so much, sir.
Great to hear you. Next I present Dr. Sandeep Gupta. Most humble, scientifically oriented, and once you interact with him, he explains it each and everything. I have a personal experience of that, to the extent that patient becomes a doctor. So I am very honored to have you here, sir, for our MAPICON, and I request you to become a regular feature of MAPICON to apprise our audience as well as general public, because we are going to put your lecture on YouTube now also. So many people are watching you on YouTube and online this thing. So it is bone health in 21st century, thinking beyond calcium. Again, it is a basic important topic which Dr. Sandeep is going to make us aware and educate us about it. Thank you, Doctor, for coming.
Thank you, sir, for the kind words. Just to set the tone, Parth has covered a lot of things. India spends around 3 to 4% of its GDP on healthcare, which is compared to the Western world spends around 9 to 10%, and US spends 17 to 18%. So that means we are a poor spender on healthcare, and every penny we spend, it is the responsibility of the medical professional to make it cost effective. And talking about that, this is what the everyday case scenario is for any physician or a doctor. A perimenopausal lady with low bone mass, elderly walk-in routine patient, elderly patient presenting with fragility fracture with no prior treatment, elderly patient with fragility fracture on treatment. How many of you are confident of treating all these 4 different scenarios? Before I prepared this lecture, I was not. And if I thought I was mistaken. Now, let's have a conservative estimates of how bone health and osteoporosis lines up in India. The at-risk population, which is diagnosed as more than 50 years, is 30 crores in India. Hip fracture incidence per year is 6 lakhs. Significant spine fracture incidence is even more, it is around 10 lakh. As path delineated, they kill. They are not only morbid conditions, they are mortal conditions. 1 year mortality rate with hip fracture at a conservative estimate is 20%, so it makes it 1.2 lakh deaths because of osteoporotic hip fractures. 1 year mortality with spine fracture is at the rate of 10%. It makes it 1 lakh deaths in India itself because of osteoporotic spine fractures. Median hospital stay for any osteoporotic significant fracture, vertebral or hip fracture, is around 12 days minimum. Total number of hospital days spent by our elderly would be 1 crore 92 lakhs. Average hospital day cost is around 5,000 rupees per day, including bed, everything. So it would be 9,600 crores spent on osteoporotic fractures only. These are conservative estimates. Let me put it. I may be off by at least 50% here. Now, for those who are thinking, why are we talking about osteoporosis? It's not that important. I mean, unless somebody has a fracture, it's not important. But this is how it lines up with the serious diseases which we all like to treat. It is at par with all the serious medical diseases, which include stroke, pneumonia, heart attack, with the mortality rate which is comparable, which has a cost which is higher than any of these. Cost spent on osteoporotic hip and vertebral fractures is higher than any of the serious diseases which we would like to treat. And the number of days a patient spends in the hospital because of osteoporotic fractures is way higher than any of the serious diseases which the same patient is going to suffer in his or her lifetime. So it is important. Not only that, if you have a osteoporotic hip fracture and you happen to be treated even in the best care centers, the best you can expect is only 20% chance of complete recovery, even with the best of the treatment. 20 to 30% would not make it to the first anniversary of the fracture, and those who make it to the first anniversary of the fracture, 50% of them would not be what they were before the fracture. So it is a serious disease. And add to it the complications of the treatment itself. So the disease is bad itself. The results of perfect treatment are at best average. And if somebody happens to have a complication on top of it, you can imagine the scenario for that patient. You can have implant cutouts, you can have infections, you can have n number of complications which can be not only morbid but mortal. So for any condition, we have been told ever since we were MBBS students, prevention is better than cure. And there is no condition like a bone health which can be prevented. And the prevention starts from the day the child is born. Why is it so? Because the bone in our body is like a bank. We have a bone bank. Now, whatever we may do, it's the natural law that our deposit in the bone bank will increase till 35 years of age. And whatever we do, the bank balance would decrease after that. So if we do certain things before 35 years of age, we will reach a peak bone mass, which would be good enough that even if it decreases, we would not reach the risk level. So everything done at the age before 35 is good enough. So bone health is something in which if you intervene at very level, at any level, you will make a difference. So you need to know it. And for that, you need to know the bone structure. Now, what we think is that bone health is directly related to vitamin D, calcium, but that's not true. That is as far from the truth as it can be. Bone is like a pillar. So you have a metal matrix, which is the protein fibers, the collagen fibers. It's like a saria of the building. The calcium and phosphate is the cement of the building. The vitamin D is the worker who's making that building, and the exercise is the willingness to build that building. So until or unless you have a proper protein intake, you have a proper calcium intake, you have a proper vitamin D intake, and you have proper stimulus, and that is weight-bearing exercises, as Path also delineated, you cannot have a good solid bone density. All four are equally important, and all four of them have to be taken in unison. So calcium has to be good, vitamin D has to be good, protein intake, oft neglected in India in vegetarian diet, has to be good. I'll just give you an example. 0.8 to 1 gram per kg body weight. That's the minimum requirement of protein per day. And exercises, 20 to 30 minutes of any sort of weight training is good enough. It need not be bodybuilding, it's just a weight training. That body is being loaded. As simple as walking or gardening is good enough. Now, regarding the existing treatments, they are highly efficacious. They reduce the risk of osteoporotic fractures by 30 to 50%. That they are that efficacious, and they are cheap and they are safe. But the question is, are they beneficial as compared to the other modalities? Yes. With the use of anti-osteoporotic drugs, you can decrease the risk of your patient of dying by 20 to 40%. You can decrease the risk of new fracture by 20 to 40%, and you can decrease the cost by 20 to 40%. That is the amount of benefit these drugs have on bone health and treatment of osteoporosis. If we like to compare it with the other diseases which we want to treat, you can see the mortality reduction per dollar spent is highest with anti-osteoporotic drug. So they are considered to be the most cost-effective therapy medical profession knows, which is even better than the anti-diabetics, anti-hypertensives, and the drugs to prevent stroke and everything. So these are those effective. Compared to the cost effectiveness, again, oral bisphosphonates are amongst the best to treat any disease, any condition across medical fraternity. So when we are talking of osteoporosis, we have a disease which is amenable to treatment. The treatment is cost effective, and it prevents deaths, it prevents morbidity, and it saves cost. But next question, then why are we not doing it? Is it not safe? This is the safety profile. Of all the medications in medical fraternity, probably anti-osteoporotic drugs are the safest amongst all. Now, everything is falling in place. Next, then we must not be having the right diagnostic modalities. That's why we are not treating it. Diagnostic modality, it is right there on your cell phone. You tap on online and you do a FRAC score. And a FRAC score would give you immediate guidelines of what to treat. Even if you do not have a DEXA scan in your vicinity, or the patient cannot afford it, or if you cannot, or you do not want to get it done, just a FRAC score is enough for you to guide treatment for osteoporosis. Now, we have a disease which has high incidence, has a high morbidity and mortality, has a high cost of treating complications, can be easily diagnosed early, has effective treatment which is both cheap and safe, but this is how we are performing. 80% of the people who should be having treatment are not having treatment. And this is first time. Even when the fracture, even when the patient presents to a clinician with a fracture, out of those patients also, 80% do not receive treatment. We are failing as clinicians. Why is that so? I can only think of these reasons. We do not appreciate the seriousness, or we do not know the right way to evaluate, or we do not know the right way to treat, and because of those three things, we tell that our patients are not compliant. But if we cater to the first three things, and we ourselves are convinced that these patients need treatment, most of the patients would follow the treatment just the way they do for diabetes, just the way they do for stroke, just the way they do for coronary artery disease. So let's begin to change. First, how to evaluate. and whom to evaluate. Anybody more than 50 years of age should be evaluated with a FRAC score. If you just go out of this hall after this lecture and do a FRAC score for yourself, it would take less than a minute. Now, next question, how do you interpret it? That's the next question. FRAX Plus is an app which is paid, so obviously we have reluctance to use it. I can appreciate it. It is around 7,000 rupees per year, but doesn't matter. The NOC guidelines give you this table, so you just have to dial in what the FRAX score is, and you have to dial in the age, and you have to see on this chart. You will get green, yellow, light red, dark red. And what does that mean? It basically gives you a 10-year probability of a major osteoporotic fracture, and you see where your patient is falling, and based on that, you can be in the green half where you just give the lifestyle advice. In the middle half, you treat them yourself. A physician, a simple plain MBBS doctor can treat it, and if they fall in the top bracket, very high risk group, then you consider referring to a specialist who has interest in bone metabolic disorders. So very, very, very easy to follow and very objective with clinical guidelines, international clinical guidelines backing the entire concept. Now how to treat? We know all calcium has to be taken, vitamin D has to be taken, protein, blah, blah, blah. But what we need to know is there are osteoporotic drugs, and they are of two classes: anabolic, which build the bone, and anti-resorptive, which decrease the resorption of the bone. And there is a science to what you should prescribe in what patient. And since osteoporosis is a lifelong disease, you need to know the sequential therapy, because no one class of drug can be given end on for life. So the maximum a class of drug can be given is 10 years, and that to only select patients. So these are the drugs. So anabolic drugs are teriparatide, abaloparatide. Abaloparatide is not available, and rososumab. These are the anabolic drugs, and anti-resorptive drugs are bisphosphonates, which can be oral and IV, as well as the denosumab, the wonder drug, so-called wonder drug. But you need to know sequential therapy. Why? Because any anti-osteoporotic drug has a specific duration for which it can be given safely. For bisphosphonates oral, the duration for which it can be given is 5 years, maximum 10 years. For an IV bisphosphonates, it is 3 years minimum and maximum 6 years. For denosumab, it is 5 to 10 years. For teriparatide, it is 18 months to 24 months. For rosumumab, it is 1 year. Hormone replacement therapy, again, that is a domain which endocrinologists should look at, seeking the risk-reward ratio. So a patient who has been diagnosed with osteoporosis at around 50, if the average life expectancy is around 80, for 30 years, you would have to think of a sequential therapy, where you start with one drug and then you move on to other drugs so that you can have a disease-free, event-free life. And what is that sequential therapy? This table guides you what is the sequential therapy. So certain drugs would have a reversal of benefit immediately, like denosumab. You give denosumab and you withdraw and do not give anything else. The baseline risk actually increases. So patient who has been on denosumab, if the drug is withdrawn and nothing else is given, there would be a reverse significant osteoporosis with multiple fractures. So, and similarly, this table gives you what works after what. So typically, any anti-resorptive therapy has to be substituted with an anti-resorptive therapy. So if the patient has been on bisphosphonate, you follow it up with a denosumab, which is anti-resorptive. Any patient who is at a high risk, you start with building the bone. So you give anabolic drug like teriparatide and rosumumab, and then follow it with bisphosphonates. A good sequential therapy chart is like this. Bisphosphonates being easy to take and cheap, most of the patients qualify for taking bisphosphonates. After 12 to 16 weeks, you call the patient again and see whether they are compliant or not, and then every year you sequentially evaluate them. there was a question by Dr. Vitul who asked that can the osteoporosis be reversed? It has been shown that if the treatment is started at the right time and is diligently followed, it can be reversed, and you regularly follow. If the patient is compliant and the risk is low, then you can think of giving a drug holiday. If it is not, then you sequentially shift the patient after the complete dose to the next class of drug. So this is a table for the oral bisphosphonates, which tells us how to follow the patient and how to sequentially get to the different class of drugs. So now if we have an everyday case scenario, perimenopausal lady with low bone mass, any takers, what would be done? It's a common phenomenon. Perimenopausal lady comes to you with a backache, and you do a FRAC score or a BMD, and it has a low bone mass. It's not osteoporosis, it's low bone mass. So what should be done? The answer is you start the patient on oral bisphosphonates. And if the patient is low risk for breast cancer, then hormone replacement therapy also can be considered till the time the complete menopause has not set in, right? Now, elderly walk-in routine patient with multiple joint pains, multiple backache, would you screen for osteoporosis from now on? Any elder? Yes. So if you screen and the patient is a high risk for fracture or is classified as a treatment group, what would be the choice? So again, the drug of choice would be bisphosphonates oral, and if he is a very high risk, then IV bisphosphonates. Elderly patient presenting with a fragility fracture. The fracture has happened and you're treating the fracture and you're doing the BMD also and the FRAC score, and the BMD shows very high risk. So what is the treatment then? So you start with anabolic first, teriparatide, give it for 2 years, then shift to bisphosphonates. After 10 years, shift to denosumab. That is how you will take the patient to 20-25 years. Elderly patient with fragility fracture on treatment. The patient had treatment, it can happen. Despite treatment, it is not 100% guarantee that the patient would not fracture. So if the patient is on osteoporotic treatment, has a fragility fracture. Now the treatment would depend on what treatment the patient was. If it is teriparatide, you continue with teriparatide, and then after teriparatide, obviously you shift to bisphosphonates and denosumab. But if the patient was on denosumab, don't make the mistake of shifting the patient to teriparatide. If at all teriparatide has to be taken, it is an add-on therapy. It is not a substitute for denosumab. Otherwise, there would be a reflex increased bone loss. So these are the certain things which have to be kept in mind, and there is a one guideline, NOGG, NOG guidelines, and ACE guidelines, which every physician should read, whoever is looking after a geriatric patient, to make real difference in the bone health of an elderly patient. Don't panic if there is a fracture. What all of us should know, one basic point is that mobility is life. In an elderly hip fracture, there would be comorbidities, and guidelines are in place which tell us that comorbidities are not to be treated before the fracture is fixed. Rather, fracture should be fixed along with the comorbidities for better rehabilitation and better clinical outcome. And the time from fall to first walk should be less than 48 hours. That should be the aim. And most of the patients, if they are treated in a specialized center, would be able to achieve this. And the reason is this last picture. We owe it to our elders to treat them well. Thank you so much.
Thank you, sir, for a great informative talk. I felt myself like, taking a class in 3rd year. So all fresh knowledge and excellently presented briefly and most informatively. Because if you read an article on osteoporosis, you are sometimes confused what to do, what not to do. Yes, and I must congratulate, we will be widely circulating your this thing, and at least I am going to change my practice considering bone health as a premier modality, because what you have shown that it is going to benefit the patients more than any other modality.
Yes.
So thank you very much. Any questions?
Thank you, sir.
Thank you very much, sir.
Sir, I'll send you across the latest guidelines and you can circulate in your physician groups.
Definitely,
Thank you, sir.
definitely. We will be most honored. So thank you very much, Dr. Sandeep Gupta. Now I am preponing 3 lectures from our faculty from Delhi. So first I invite Dr. J.K. Sharma. He is Director, Senior Consultant, Central Delhi Diabetic Center, Secretary General and Global Ambassador of Innovative Physicians Forum, New Delhi. He is the most versatile person what I have come across in last 5 years, and I respect him a lot. I have learnt a lot of things from him, and I have saved his number as ethical considerations in diabetes, Dr. J.K. Sharma. So I am honored to present him to you, and I must tell you that 750 doctors are online watching you. Out of that is 150 our registered delegates. So that is why we are conducting this in a small hall, so that the concept of online is better than offline these days. Yes. Thank you, Dr. Sharma, for coming. So please.
Thank you very much, Dr. Vitul. First of all, I must extend my thanks and greetings from Innovative Physicians Forum. Dr. Vitul himself is also a academic life member of Innovative Physician Forum, which is a body of all academic people. And then I am thankful to him again for giving me this topic and giving our Innovative Physician Forum a platform in this important conference, where, as I have been told, a good number of people have joined online. So in next say 20 or 19 minutes, I will be taking you through a very important topic, and that is type 1 diabetes and cardiovascular risk. We all have been reading about, listening about the micro and macrovascular complications, but when we talk of these complications, it comes to our mind that it is of type 2 diabetes. Because these complications, they start much before the clinical diagnosis of diabetes is there. As we all know, the beta cells start failing, or their work goes down by 5 to 6% every year. So by the 10th year, 50 to 60% of beta cell function has already gone down, and the remaining 40 to 50% beta cells are not enough to produce insulin, which will be sufficient to keep the patient in the euglycemic phase. And that is the time when the micro and macrovascular complications start. But this is all about type 2 diabetes, which we say, because in type 1 diabetes, the things are different. As it is well known that diabetes is a complex chronic condition which requires continuous medical care with multifactorial risk reduction strategies beyond the glucose management. So it is not only the glucose management. Nowadays, earlier it was the glucose-centric approach, and now it is the patient-centric approach in the management of diabetes. And type 1 diabetes, which is an autoimmune disease that leads to the destruction of insulin producing pancreatic beta cells, and there is heterogeneity in the metabolic, genetic and the immunogenetic characteristics of type 1 diabetes, and age related differences requiring a personalized approach for each individuals. And that is the reason that many of us who are treating diabetes, 90% of the people are treating type 2 diabetes only, because it is, you should have a passion to treat type 1 diabetes. Patient demand, the family demand, and self-satisfaction, which is very, very important. Cardiovascular disease is a long-term complications of even type 1 diabetes that is a major concern for patients and healthcare providers. And these events are more common and occur earlier in patients with type 1 diabetes than in the non-diabetic population. So when we compare the non-diabetic with the type 1, definitely they come early, and the overall risk of the cardiovascular disease for people with type 1 compared to people without a diabetes is increased 2 to 3 fold in men and 3 to 5 fold in women. So a significant increase in the cardiovascular death mortality related to increasing the HbA1c has been reported in type 1 diabetes patients. And talking about the epidemiology in the EuroDiab IDDM complications study, where including more than 200 patients with type 1 diabetes from 16 European countries, prevalence of CVD has reported to be 9% in men and 10% in women respectively. And according to the results of a large Finnish database, CVD mortality in patients with type 1 diabetes at the age of 45 to 64 years at baseline increases by 50% with every 1% increase of the HbA1c. This does not mean that the people are only from 45 to 64 years. Type 1 diabetes, as we know that it develops early, though we can see the patients of the adult patients also with type 1 diabetes in certain situations. Now there are certain important factors which contribute and disease progression in type 1 diabetes. You can see that the genetic risk, which is the foremost starting point, 15 times increased risk of type 1 in those with relatives with disease. So if there is a relative with disease, then we have to screen them first, and then the immune activation, that beta cells are attacked through the immune activation, leading to development of single autoantibodies. Coming to the stage 1, 2, 3 and 4, when the blood sugar levels are normal and if there are 2 or more autoantibodies, that is the stage 1. But when the blood sugars they become abnormal, then it goes to stage 2. And when there is clinical diagnosis of this diabetes, then plus. And when there are 2 or more than 2 autoantibodies, this is stage 3. And stage 4 is that when long-standing type 1 diabetes is there. Coming to the immunopathogenesis of type 1 diabetes, the development of type 1 is thought to be initiated by presentation of beta cell peptides by antigen presenting cells, that is the APCs. And these APCs bearing these autoantigens, they migrate to the pancreatic lymph nodes where they interact with autoreactive CD4 plus T lymphocytes, which in turn mediate the activation of autoreactive CD8 plus T cells. So, and this is the immunopathogenesis. But when we talk of the pathophysiology, long-term hyperglycemia, both in type 1 and type 2 diabetes, they lead to microvascular and macrovascular complications. And the microvascular damage affects particularly the retina, the kidneys, both the autonomic and the peripheral nervous system, while the heart, brain, lower limb are affected by both micro and macrovascular disorders. Now this is a very important slide, and we just have to put some mechanism of vascular damage in type 1 diabetes and their putative amplification by a dysfunctional immune response. We know that when there is decreased central immune tolerance to self, which is the pathogenesis of type 1 diabetes, and on the top of that, when there is environmental, like if there is a viral infection, so when there is viral infection that leads to, and when the subject is genetically susceptible, beta cell destruction starts, and that is type 1 diabetes. Hyperglycemia is there, and on the other side, through the anti-myosin antibodies, they all lead to systemic inflammation and subclinical myocarditis. But through the hyperglycemia, when we see the oxidative stress, through these 4 very common pathways, the hexosamin pathway, the polyol, PKC and AGS pathways, and when on the top of that, if there is hypertension, then microcirculatory damage, tissue hypoxia, inflammation, and they all lead to these complications of nephropathy, retinopathy, neuropathy, atherosclerotic vascular disease, and heart failure. So type 1 diabetes is considered to result from dysfunctional tolerance to the self antigens in susceptible individuals after exposure to incompletely understood environmental factors like the viral infection, which we do not know much about that. Now the risk factor for the microvascular complications influenced by several factors like the puberty, the blood pressure, dyslipidemia, gender, diabetes duration, smoking and the lifestyle. and the poor metabolic control that was identified as an important factor contributing to the microvascular complications. When you look at the relative association between specific cardiovascular risk factors and CVD in type 1 versus type 2 diabetes, you can see that hypertension, cigarette smoking, inflammation, they all have a significant effect on both type 1 and type 2, but high LDL cholesterol in type 2, low SDL cholesterol in type 1, on triglycerides there are no data available on type 1 diabetes, microalbuminuria on both sides. Insulin resistance is more in type 2 diabetic patients, and poor glycemic control of course in both type 1 and type 2. And this is the cardiovascular risk engine where you can see in the various studies the steno T1, UKPDS and the Q risk, where we can see that the LDL, exercise, diabetes duration, HbA1c, age, gender, systolic blood pressure, smoking, total cholesterol, SDL ratio, ethnicity, atrial fibrillation, migraine, corticosteroids. So all these, they are the various cardiovascular risk engines. Now the level of cardiac autoantibodies in subjects from the different groups, we see that cardiac autoantibodies in type 1 are directly associated with the glycemic control. More the HbA1c levels, more is the risk of CVD in type 1 diabetic patients. And when we look at the heart rate function, NACVD and the MACE, intensive diabetes therapy during the DCCT trial for 6.5 years has long-term beneficial effect on the incidence of cardiovascular disease in type 1 diabetes that persists for up to 30 years. Cardiovascular events in type 1 diabetes, again we see that the intensive diabetes therapy has long-term beneficial effect on the risk of cardiovascular disease in patients with type 1 diabetes. Then intima media thickness. Mean progression of the intima media thickness was significantly less in the group that had received intensive therapy during the DCCT than in the group that had received conventional therapy. Intensive therapy during the DCCT resulted in decreased progression of intima media thickness 6 years after the end of the trial. So they all show that better control, intensive control of diabetes is very, very important here. And the benefits of this intensive glycemic control, early intervention designed to optimize glycemic control have been shown to reduce the development and progression of these complications. And the participants in the DCCT with further follow-up in the ADDIC study, they demonstrated all this. And in the year 2005, 10 years after the completion of DCCT, reported that the period of initial intensive diabetes therapy also reduced the risk of developing cardiovascular disease, and the 30-year follow-up also showed CV benefits upon intensive glycemic control. So intensive glycemic control is very, very important in these patients, but take care of patients should not go into hypoglycemia. Now when to screen for the cardiovascular disease in these patients? In symptomatic individuals, routine screening for coronary artery disease is not recommended. In asymptomatic individuals, as it does not improve the outcome as long as atherosclerotic cardiovascular disease risk factors are treated. And consider the investigation for coronary artery disease in the presence of any of the following: atypical cardiac symptoms like unexplained dyspnea, chest discomfort, sign or symptoms of associated vascular disease like the carotid bruit, transient ischemic attack, stroke, claudication or peripheral arterial disease, or the electrocardiographic abnormalities like Q waves. So then we must definitely screen, and these are the various risk factors which I have tabled into this: hyperglycemia, CKD, dyslipidemia, then the hypertension. All these they should be considered when we screen and when we treat type 1 diabetes patients. Blood pressure is very important. It should be measured at every routine visit. In youth with high blood pressure of more than 90th percentile for age, sex and height, or in adolescents more than 13 years, blood pressure of 120/80. More than 120/80 on 3 separate measurements, ambulatory blood pressure monitoring should be strongly considered. And treatment of elevated blood pressure defined as 90th percentile of 90th or to less than 95th percentile for age, sex and height, or in adolescents more than 13 years. Lifestyle modification focused on healthy nutrition, physical activity, sleep, and if appropriate weight management, and after that if required then we have to go for the pharmacotherapeutics. This is the recommendation for the treatment of confirmed hypertension in people with diabetes. And then the lipids, type 1 diabetes adolescents. Initial lipid profile should be performed soon after the diagnosis. preferably after glycemia has improved and age is more than 2 years. If initial LDL is 100 or less than 100, subsequent testing should be performed at age 9 to 11 years of age, and initial testing will be done with a non-fasting lipid level with confirmatory testing with a fasting lipid panel. Then lifestyle modification focusing on weight loss if indicated, application of a Mediterranean or dietary approach to stop hypertension, patient reduction of saturated fat and trans fat, increase of the dietary N3 fatty acids, viscous fiber and plant sterols intake, and the increased physical activity should be recommended to improve the lipid profile and reduce the risk of developing atherosclerotic cardiovascular disease. And for people with diabetes aged 40 to 75 years without atherosclerosis cardiovascular disease, use moderate intensity statin therapy in addition to the lifestyle therapy. This is the another very important factor, the smoking and the pollution. Elicit a smoking history at initial and follow-up diabetes visits. Discourage smoking in youth who do not smoke and encourage smoking cessation in those who do smoke, and also look after the passive smoking. Electronic cigarettes use should be discouraged. Glycemic control. Less stringent A1C goals may be appropriate for youth who cannot articulate symptoms of hypoglycemia. So prevent hypoglycemia. Even less stringent A1C goals such as less than 8 may be appropriate for individuals with a history of severe hypoglycemia, limited life expectancy, or where the harm of treatment are greater than the benefits. It does not mean that these patients, only type 2 diabetic patients, they reach to this stage. Even type 1 diabetic patients also have a long life. Now look at the microvascular complications, neuronal damage and structural damage, diabetic retinopathy, look for diabetic nephropathy, diabetic neuropathy, and other non-classic targets like the microangiopathy and the metabolic damages, and macrovascular, of course, for the lower limb microangiopathy and the metabolic damage, coronary artery disease and stroke. Of course, we have to look for that. Now, one very important but neglected component of the complications of diabetes is the diabetic autonomic neuropathy. Diabetic autonomic neuropathy remains underdiagnosed, thus contributing to the morbidity of diabetes and may not be reversible. ADA recommends screening for DAN at the time of diagnosis of type 2 and 5 years after the diagnosis of type 1 diabetes mellitus. Diabetic autonomic neuropathy is an under-recognized complication of diabetes and the pre-diabetes state. Wide range of manifestations can be seen due to involvement of cardiovascular, gastrointestinal, genitourinary, pseudomotor and the neuroendocrine system. Cardiac autonomic neuropathy is the most dreaded complication carrying significant mortality and morbidity. Early detection and control of diabetes and other cardiovascular risk factors is the key to treat and prevent progression of autonomic neuropathy. So please do not forget this and go for this. This is the overview of diabetes cardiovascular complications. You see here that coronary artery disease, heart failure, peripheral arterial disease, stroke, nephropathy, neuropathy and the retinopathy. And one very important the complications I can say is the erectile dysfunction, which I have not mentioned in detail, but that is very, very important. Any patient of diabetes coming to you with erectile dysfunction, please look for and evaluate for the cardiovascular disease. Because when there is constriction of the penile artery, if there is erectile dysfunction, of course, the patient will have the cardiovascular disease, and please evaluate for that. This is the type 1 to 2% of the patient are type 1 and type 2 are 98% of the diabetes. Major modifiable risk factors I have already told you, and control of the risk factors, especially the blood glucose as parameter for cardiovascular disease prevention in diabetes is very important. So dear friends, to conclude, type 1 diabetes remains one of the biggest global health concern in the world. In the last 4 decades, the number of patients diagnosed with type 1 diabetes has steadily increased. Complications associated with diabetes culminate in an increased risk of neuropathy, retinopathy, nephropathy and the cardiovascular events. Enhanced form of exogenous insulin replacement have improved the quality of life in type 1 diabetic patients through fast and long-acting insulin analogs. Their overall life quality and life expectancy is decreased. There is enormous need for the development of new approaches for prevention and treatment of type 1 diabetes, and any healthcare provider looking after the type 1 diabetic patient should have a zeal and a passion to look after these patients. So, type 1 diabetes does not just alter insulin production. It alters the cardiovascular equation. Every effort to control blood sugar level is a step towards reducing the risk of heart complications in these type 1 diabetic patients. And with that, I thank everyone, and my special thanks to Professor Vitul Gupta and the entire team for this wonderful conference and giving us the opportunity. Thank you very much, sir.
So thank you very much. The Innovative Physicians Forum session will be an integral part of future MAPICONs also, and we will request everyone to visit the Innovative Physicians Forum website and become the member of Innovative Physicians Forum, because I have been attending 2 conferences and it is a great conference, great academic scientific event which you will be relish, and it will add to your academic knowledge also. So thank you, Dr. J.K. Sharma, for coming from Delhi and honoring us with your presence as the part of session of the Innovative Physicians Forum.
Thank you very much, sir, and thank you everyone who have attended. Thank you.
Thank you. So next session included in Innovative Physicians Forum session is by Dr. A.K. Manchanda, Medical Director, Carewell Diabetic and Cardiac Center and Treasurer of Innovative Physicians Forum. I welcome you, sir, to Bathinda. And again, the topic is very important: gut microbiota and cardiovascular disease. Gut microbiota is implicated in almost all the conditions, medical conditions or adverse health effects, and Dr. Manchanda is going to apprise us about its role in cardiovascular disease. Thank you, Dr. Manchanda, for coming. Thank you.
Thank you, Dr. Vitul, for inviting the Innovative Physicians Forum to represent this MAPICON 25. So, this is my article on gut microbiota and cardiovascular diseases. We know that human gut has a lot of bacteria teamed inside our colon, so it actually makes our microbiological ecosystem, because myriads of roughly trillions of bacteria reside and they are producing their metabolites, and that becomes a whole microbiome that is causing some kind of impact, maybe metabolical and other impacts. So dominant bacteria in our gut is particularly bacteria more than virus and fungus, and among the bacteria it is the Firmicutes, Bacteroides, Actinomycobacteria and Protobacteria are the more important bacteria in this phyla, and they are doing some kind of functions which are mostly useful, like energy absorption, breakdown of complex carbohydrates. There was a talk on regarding ragi or so. So these basically undigested particles are broken down into a useful substances by certain bacteroids, and then nutrient metabolites and metabolic functions are also imparted by the bacteria that we'll see in the subsequent slides. Like normal function in our body by these bacteria are digestion, defense, maintaining the intestinal epithelial integrity, regulation of immunity, supporting central nervous system, as well as very important, that is the metabolic effect. So there are so many modifiable and non-modifiable risk factors, and despite all the control of the risk factors, still we have not been able to bring down the cardiovascular risks. So there is another factor, and after this reading and going through the role of microbiota, I think this also should be incorporated in one of the risk factors, the management of our gut microbiota. So on the left side we see that directly effect of the microbiota is on our body and is on the atherosclerosis, hypertension and vascular inflammation, and indirect impact through the lipid metabolism through acting on obesity, glucose homeostasis and platelet activity. It finally has its own role in management of cardiovascular events. So these are the few of the microbiome. Microbiome is the microbiota itself, as well as its derived products, which are combined known as microbiome. So microbiome derived compounds are like short chain fatty acids, lipopolysaccharides, choline related compounds, even secondary bile acids, etc. They have their role in participating into the metabolism and lot of cardiovascular effects. So just naming few, lipopolysaccharides is a substance which is released from the gram-negative bacteria, and it comes to the circulation and goes to the liver, where it causes lot of inflammatory effects, and through its inflammatory effects it can cause lot of metabolic activities, and even the inflammatory markers there also are important, even obesity, hypertension, diabetes, and even cancer also. And other important substances are small chain fatty acids, TMAO. I will just narrating few one after another. So small chain fatty acids are very important. Actually, inside when we say that you take lot of fibers, so microbiota inside our body converts these indigestible polysaccharides into the useful substances, particularly butyrates, which prevents against the inflammation, and it maintains the intestinal integrity also. So this SCFA is very important, and it is working through the undigestible fermented fibers. Coprostanol and cardiovascular health, what happens that this microbiota not only have the effect on the inflammation part of the story, but the cholesterol inside our body is converted into coprostanol inside the gut, and lot of cholesterol is absorbed, and it is basically removed from our body system by these bacteria. So high SCFA fecal levels increases the increased cholesterol to coprostanol conversion, and that is linked to the lower serum cholesterol level. So this is one of the other mechanism by microbacteria. As I told, lipopolysaccharides are the substances released from the gram-negative bacteria, and they enter the circulation during the dysbiosis, and they cause lot of foam cell formation and further atherogenicity inside our body. TMAO is very important, and this particular reagent is being targeted and evaluated whether inside our body, besides the addressing cholesterol and other factors, can we address TMAO to reduce our cardiovascular events. So what is TMAO? On the left side we see that choline and carnitine, particularly in our diet, which come from red meat, eggs, and sometimes milk, they go inside the gut, and in the gut lumen it is converted into the TMAO. So from it is when converted to TMAO through liver, so it has got so many of atherogenic effect that we can see it can impart in thrombosis, atherosclerosis, heart failure, kidney fibrosis, and so many other factors is produced by through this TMAO. So first this is two-way conversion. First the bacteria convert this choline into TMA, and from TMA it is converted to TMAO, which comes into the circulation, causes lot of atherogenic effect. There is also TMAO level which is more than 3, so this becomes very atherogenic, and there are certain medicines are being evolved to reduce the level of TMAO in our body. Bile acids, we know that it is something which is used in digestion, but besides this having effect on the gut, it has its effect on the cardiovascular disease also. Primary bile acids, it is synthesized in the liver, so it is secreted into the intestine thereafter. From intestine, the gut microbiota convert these primary bile acids to secondary bile acids, which goes back into the circulation, and plays its role. So when excess of the primary bile acid in case of dysbiosis also causes atherogenicity, as I will tell in the subsequent slides. So here, as we told, that primary bile acid comes into our intestinal circulation, and from here it goes to the liver to make the secondary bile acids. So in gut dysbiosis, what happens that the primary bile acid concentration increases, so it disrupts the primary to secondary BA conversion, also takes the second place. There the FXR and TGR receptor activity is disturbed, and on one hand it causes the increased lipid accumulation, inflammation, as well as on the other hand it can cause the cytokine productivity and inflammation, and glucose hyperproductivity. Their clinical evidences are also seen in the biliary diseases, like in case of primary biliary cholangitis, prolonged QTc interval, abnormal LV ejection times is quite noticeable, and certain cholestatic disorders, like primary biliary cholangitis, etc., they are associated with the increased risk of cardiovascular disease, as well as doubling the prevalence of the lower extremity arterial disease. So they are quite references of this kind of effect is there. Other substance, the metabolite is phenylacetylglutamine, which causes increase in platelet activity and thrombosis, and instantaneous thrombosis is also seen while there is increased formation of phenylacetylglutamine. So this happens in the gut dysbiosis, and if we keep our gut biosis intact, so we can defer these kind of cardiovascular events. So just coming through the path, these are the whole pathways where it is gut microbiota is having its impact. Few I just mentioned, like increased lipopolysaccharides, which causes direct inflammation of in the guts and improves and the cascades of the inflammation cascades inside the liver is activated, where it can cause, on one hand, cardiovascular diseases, insulin resistance, even the NAFLD, and which is known these days known as MACLD, is also somehow affected through this mechanism. Other mechanism is like TMAO, as I told, it causes atherosclerosis, thrombosis, cardiorenal fibrosis, and inflammation of the inside our body. And these are all things that just recapitulating again. Small cell fatty acids, they are very important part the positive gut microbiota. It is seen that the patients who has low SEFA, they have increased blood pressure, and the interference in the myocardial repair is also there, and inflammation modulation also there. So SEFE is very, very important substance from the gut microbiota, and it is produced in presence of the polysaccharides inside our fibers. Other, as I told, the bile acids also modulate the lipid metabolism, glucose metabolism, and all these events are present in presence of the dysbiosis of our gut microbiota dysbiosis. Dysbiosis means the normal gut microbiota which is disturbed. So this is microbiota, and inflammation has a cardiovascular disease activities, because through gut microbiota we have seen there's so many of inflammatory markers which I am not naming them, just short of time. So inflammation is a key driver of CVD, and gut dysbiosis increases systemic inflammation via multiple routes. Name of a few, if we can name few, there are IPS, IL-6, foam cells, cytokines, etc. So the clinical implication is seen that in case of hypertension, there is some microbiota dysbiosis is there, which contributes to elevated blood pressure and inflammation. And it is seen the patient of hypertension has less diversity, microbial diversity, increase in certain microbacterial strains, which can be measured in the time to come. Smoking also alters gut barrier functions, so it causes the gut dysbiosis, which is unclear whether this is changing in the cardiovascular risk, but there is definitely some dysbiosis takes place. When we see that certain bacteria, like as we mentioned, that bacteria inside our gut can also change the cholesterol to cholepostenol. So this also takes place in presence of microbacteria. So it leads to improved lipid profile and potential reduction in cardiovascular death if there is a good gut microbiota are there. And similarly, certain metabolites, microbial metabolites also play their role. Coming to the lipid metabolism, as I mentioned, that gut microbes modulate the lipid cholesterols. Cholesterol levels are converted into the stenols, which are another steroids inside our colon. Similarly, the bacterial membranes also absorbs cholesterol in their own formations. Deconjugation of the bile, as I told you, that from primary bile acid to second biliary acid is important, and if it is not converted, there is a lot of atherogenesis. Similarly, production of small chain fatty acids also takes participation in the cholesterol formation. And Microbiota target therapies may help manage dyslipidemia and reduce the cardiovascular risks. So to address this thing, there is new microbiota target therapies. We know that we have been using a lot of prebiotics or probiotics, but certain molecules to address, like there is DMB or other kind of medicines, which reduce, as I mentioned earlier, the TMA and TMAO are highly pathogenic. And it is seen that if we reduce this TMAO itself, can increase the coronary events by 4 times than normal. Fecal microbiota transplant is another concept which is in cardiovascular disease. It is found that when it is was done in the mice, there was reduction in the cardiovascular events was noticed. So we come to the dietary effects and what kind of diets can confer to which kind of microbiota. So in the red highlighted things are bad diets, like high fat diets, that is changed to certain change in strain of the microbiota and is linked to type 2 diabetes, loss of beneficial microbes. Plant-based diets, which is rich in the fibers, it improves the lipid metabolism, increase the small chain fatty acids, reduce inflammation by changing certain bacteria inside the gut. Vegetarian diet similarly is useful, causes reduced reduction of LDL. Similarly, Mediterranean diet, it has maximum effect in reduction of the cardiovascular events and the MASLD, reduce the pro-inflammatory cytokines. Mediterranean diet is basically rich in fruits, fish, and the type of it was rich in the extra virgin olive oil type of the omega-3 rich diets. So coming to the certain drugs, which drugs are useful and bad. Metformin, liraglutide are good for our gut because it's improved metabolic outcomes through the improvement in the beneficial modulation of the gut microbiota. Omeprazole or pantoprazole, besides this is the other than the clindamycin, this is the other medicine which is mentioned in the literature causing the Clostridium difficile infection. So if patient is not being corrected from their diarrhea and they having continues to have diarrhea, kindly consider omeprazole or other PPI agents. This could be the cause of the uncontrolled diarrhea. Empagliflozin, again in the green, it causes also improved cardiometabolic benefit and is seen in certain change in the gut microbiota and microbiome. Captopril was, we don't use these things. Similarly, antibiotics are, broad spectrum antibiotics cause lot of dysbiosis and may impair the cardiovascular drug reaction. So prebiotics are the substances, because we use a lot of prebiotics, probiotics and symbiotics. So prebiotics are basically non-digestible compounds which are selectively stimulate the beneficial bacteria like lactobacillus, bifidobacterium, etc. They promote the SCFA production and small chain fatty acids, particularly butyrate part of that fatty acid. It is anti-inflammatory. It maintains the gut barrier. From there, the bacteria do not just dislodge and their metabolites do not go to the circulation and this. Probiotics are the life microorganism which conferring the health benefits according to WHO. So effective strains which we have been using in our country are bifidobacterium, lactobacillus, and Agarmencia, municipala, and etc. VSL number 3 that is one of the very useful agent which is being used and has been studied in various references. That is, we have 12 strains, which most of the strains are lactobacillus, streptococcus, etc. This is also very useful effect in the reduction of the inflammation by the bacteria. So there are certain probiotic supplementations, particularly which bacteria and their results has been noticed that the supplementation of certain microbiome is on the left side has been conferred by certain microbiomes. So to sum up the dietary and probiotic interventions, these are helpful and they improve the lipid metabolism, they improve the blood pressure and they have anti-inflammatory effect, and reduction of TMAO levels also has effects on the atherogenesis, so have positive advantage in the cardiovascular events. So phytochemicals are the substances which are found in the fruit. So there are certain fruits and their active products which have their change in the gut microbiota, like these are list of the fruits which are changed in the gut microbiota. These are the references by their changing of gut microbiota, which is can have lot of benefits beside having their diet management part, they have a lot of benefits. And when the gut microbiota is managed, it's not only the obesity, it's not only the cardiovascular events, but even the cardiovascular, the cancer events, because the Cancer Society that says one should eat at least 10 fruits. We cannot eat 10 number of fruits within a different ratio should be taken every day to avoid the cancer. So these are the big, maybe because of the gut microbiota, they may be having their own effect. So another list of the various fruits. So there are certain futures research is needed, because precision nutrition, if we are still in a very native stage, we don't know that which particularly microbiota we will be using, and the researches are on where the microbiome modulation will be sometimes the story of the day, and just examining the stool examination will be giving more information about the cardiovascular events to come. So to sum up that, the gut microbial metabolites like particularly TMAO promotes atherosclerosis and thrombosis. Short chain fatty acids preserves the vascular and metabolic health. Bile acids modulates the cholesterol metabolism. And the mechanism and pathways I have already discussed. The therapeutic approach of these changing the gut microbiota could be that it influences the microbial composition and activity. Probiotics and prebiotics moderate the gut microbiomes. And null enzyme inhibitor, which targets the TMAO biosynthesis, is also being researched for the future use in our human cells. So with that, I just thank you.
For apprising us the importance of gut microbiota and cardiovascular disease. So house is open for any comments or questions.
Thank you, Dr. Manjanda. Very nice talk, an eye-opener for most of us, you see. I think you have proved our observation in the last 20 or 30 years that the incidence of diabetes, incidence of cardiovascular disease has increased for the simple reason because of the change in our dietary habits, you see. I mean, sticking to fast food. The other thing I want to add is indiscriminate use of antibiotics, which destroys the gut, you see, flora and all the gut microbia. Probably that contributes a lot to all the disturbed gut flora, causing all these lots of problems. See, that's my comment.
Yeah.
Thank you.
The bad thing for the gut and the whole inflammation are industrial alcohol, industrial like colas, sucrose, industrial sucrose, red meat, and unsaturated fats. These are all the things that are in our diet are very bad, and all kind of toppings. You'll find the bakeries items, the recycled oils, etc., which cause a lot of bad effect to our dietary contents. So we have all youngsters. I know what is going to happen tomorrow, but you are right. Gut is this diet is very important part of our health. Hmm. Yeah. Thank you.
Thank you, sir. So next in IPF session is Dr. Puneet Khanna. He is Senior Consultant and HOD Medicine, Department of Respiratory and Sleep Medicine, Manipal Hospital, Dwarka. He is again going to talk to us about an important topic, OSA Newer Insights. Thank you, Dr. Puneet, for coming.
Thank you, Professor Gupta, for having us here. And at the outset, my heartfelt congratulations on a very successful organization. So in next 20 minutes or so, I'll try my level best to make you all awake. It's not about sleep, and I don't want to make you sleepy. In fact, this is going to be an eye-opener about what we normally spend almost 1/3 of our life in this particular process, and this is one neglected area which we don't think about. I'm going to talk about some newer insights in obstructive sleep apnea. We've all heard about sleep talks many times before, but you'll be surprised to know that the Indian literature is full of description about sleep and sleep habits and its importance in health. So almost like, you know, by 200 BC and even before that, there has been description in our old literatures that sleep is one of the most important component of our health, and our happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, all stems from a good aspect of sleep. And if we take sleep at proper time, it gives us happiness in the mind, it helps decreases the heaviness of the body, it creates the acting power of mind, maintains equilibrium and gives almost equal happiness as we see in a yoga therapy. The current scientific evidence points to each one of these points, and it shows that whatever is being written in these shlokas has been proven to be right by the scientific evidence. In fact, if you go deeper into our literature, the word sleep or the Hindi word of nidra is basically a derivation of word ni and dra. Dra in Sanskrit basically means desire. So nidra is considered to be a sleep where there is no desire, or it's a state of deep mental relaxation with no awareness or desire. And I want you to focus on this particular phrase for next 20 minutes, because what we are going to show in next evidence-based slides is that the deepest or the most fruitful aspect of sleep is that component which is missing in 80% of patients these days, where they do not even enter into the deepest state of sleep. And that is the basis of why the diseases are happening with such high frequency in our society. So the question is, how much sleep do we really need? And there has been so varied opinion about it. You will see patients asking that I can sleep and manage my day only with 3 hours of sleep in a day. And they feel proud about it, but they don't realize is that that is the genesis of disease that they are going to catch up in later years. And on the other hand, you have patients who are sleepy most of the days. So because it's a sleep is a temporary phase or a temporary state of unconsciousness, most studies, they agree on this, that up to 5 to 9 hours of sleep is basically a healthy sleep. So there is a U-shaped curve in this. So if you are sleeping less than 5 hours per night, then there is a higher risk of cardiovascular morbidity and mortality, and higher odds of having diabetes and insulin resistance. And the same is true if you are sleeping for more than 9 hours per night, or a cumulative sleep in a day, because that indicates some underlying disorder which is going to cause more problem and more health effects. But that is not uniform across the age spectrum. So if you see, as the age progresses from a newborn to elderly, the duration of sleep or the requirement for a healthy sleep goes down. But the most productive years of a human being between the age of 18 to 65 years to say, for most of the time, 7 to 9 hours of sleep is usually sufficient. But sleep deprivation is a fact. People say that they do not get adequate sleep, but sleep deprivation is a broad term. There are many meanings of sleep deprivation. There can be an inadequate sleep. That means the quantity of sleep is less, where you are having lesser hours of sleep and can lead to cognitive impairment. Then there can be a sleep fragmentation, which means that there is no problem in initiating sleep by the patient, but they have problem in maintaining sleep. So that is what we call sleep fragmentation. Then there is impaired sleep because of the so much of call centers and so much of night shifts happening these days in metros and other cities, where people do not get adequate sleep because the physiological circadian rhythm is disturbed because of their work in the shifts. Particularly in health profession, every resident probably has gone through this phase of doing night duties repeatedly, and unfortunately this is the problem only in our system, where people keep on doing night shifts or alternate day night off kind of duties for many years together. Nowhere across the world except in our system people are doing regular night duties except in this kind of situation. There has been study on sleep physiology. We tend to go from based on EEGs in a definite pattern during our sleep. We start with beta waves, and then on EEG we go down to a deeper stage of alpha wave, and then to theta and delta wave. And these first 4 stages are what we call non-REM sleep or non-rapid eye movement sleep. And then we enter into a REM sleep, which is called a rapid eye movement sleep, and I am very briefly going over them. So we have a waking stage where our EEG shows beta waves, when the body is just starting to prepare for rest. Everything is active. We are just about to close our eyes and see. Then there is non-rapid eye movement sleep, which lasts usually from 90 to 120 minutes. Each stage is roughly about 15 to 20 minutes. It starts with stage 1, where there is 50% reduction in activity. Just from beta, slightly waves start to going down. Then comes stage 2, which is an important aspect to focus, where the sleep study or a polysomnogram shows that there is alternative of positive and negative waves, and there is a period of spontaneous muscle tone and then followed by muscle relaxation. Then again muscle tone increases and then relaxation. This is how the body is preparing us for relaxation of our peripheral muscles. Now this is very important. Why? Because these peripheral muscles also involve calf muscles. And when these calf muscles are relaxed, there is a vascular pooling in our legs. This decreases your vascular return. If your vascular return increases to your heart, your BP goes down, and this is what we call dipping. Now focus on this particular aspect, that dipping is a very healthy phenomena, and absence of dipping is the most common cause of hypertension in subsequent life, because the patient do not go into a muscle relaxation phase. Then you go into a stage 3 and 4, which are the deeper stages or slow wave or delta waves. This stage is very important for physical recovery and immune strengthening. So whenever you see a patient who is tired or is having wasting or is having a poor immunity, and if the possibility is there to analyze their sleep pattern, they may be having deficient stage 3 and stage 4. Now brain cannot remain forever during sleep in an inactive stage, so it has to come back to an active stage, which is what we see in rapid eye movement, where there is again an increase in heart rate and twitching of face and fingers and legs, but this is the stage of intense dreaming. Now what is the importance of this sleep? This particular aspect of sleep is that when the brain is active, it is reprocessing all the information that has happened in the daytime, and this is how memory strengthening happens. So there are certain things which we remember many days even after the incident has happened. That is because that has been reprogrammed during the REM sleep. So if you have a patient where there is a REM disorder or who do not go into REM sleep, they have severe memory impairment or cognitive impairment. So it is very important for emotional regulation, learning and memory, and all these aspects of sleep are very important for healthy lifestyle in the subsequent life. There are many common disorders. It's a huge topic. I'm going to talk only briefly about excessive snoring and obstructive sleep apnea. It is a noisy epidemic, more common than what you all think. It basically means that there is loss of air to lungs many times per hour, and this leads to lack of oxygen to brain, and this leads to shutting down of brain. Now, based on polysomnography, there are various definitions. It can be apnea, where there is cessation of breathing for more than 10 seconds. There can be hypopnea or obstructive apnea, where there is a varying degree of blockage or varying degree of decrease in the airflow that you can see on the sleep study. How do you diagnose OSA? It's very simple. On a sleep study, this is the gold standard for diagnosis. There are asymptomatic patients with sleep apnea if there are more than 15 episodes of apnea or hypopnea happening. If it is less, then you diagnose these patients are having some kind of abnormality. Then patients who do not show, who have symptoms or who come with daytime sleepiness, if there are more than 5 episodes of obstructive sleep apnea, they are also categorized as obstructive sleep apnea disease. How common is it? We have enough Indian data now, and the data from PGI Chandigarh has shown that the prevalence, at least in North India, for OSAs or obstructive sleep apneas is to the range of 4% on an average, with more predominance in males rather than females. And only if you, this is the entire sleep disorder breathing, but if you consider only the OSA out of it, it is roughly around the prevalence of 13.7%, which is a huge number considering the population that we have in our country. How do you identify and what you should think as a physician when you have to prompt this consideration of OSA? Patient will tell you whether they have excessive daytime sleepiness, drowsy during driving, drowsy during their daytime work, or if they are not refreshed in the morning time. The patient's family or bed partner is the most common person who is going to volunteer this history, that they will see the witnessed episodes of apnea or choking happening in the night. They have frequent snoring, and then if you have other symptoms like nocturia, polydipsia, morning headache, dryness, then these also are telltale signs of obstructive sleep apnea, and you should evaluate that. Now, anybody with obesity, hypothyroidism, and signs of upper airway narrowing, macroglossia, tonsillar hypertrophy, nasal obstruction, these abnormalities should prompt a physical examination and suggestion of OSA. Then there are certain conditions, medical conditions, where mandatorily a screening for obstructive sleep apnea should be done. Obesity, systemic hypertension, MI, diabetes, pulmonary hypertension. So all these diseases prompt a prompt investigation for obstructive sleep apnea in every patient. Obesity is the major risk factor for OSA. About 70% of patients with obstructive sleep apnea or OSA are having OSA. But important, consideration is this particular statement is that up to 30% of patients without obesity can also have obstructive sleep apnea. So you need to identify them completely. Higher the BMI, higher the odds of them having OSA. Very briefly about this aspect of OSA, where you need to understand that the basic pathophysiology lies in the tongue muscles and the obstruction at the level of oropharynx or velopharynx. Now, this is the MRI of a normal patient. The other side is the MRI of an apneic patient. You can see the tongue fall which is there, which has significantly narrowed the upper airway. Now, all obesities or all OSAs cannot be managed in a single way. There are various classifications now to define obstructive sleep apnea in different ways. So if there are certain underlying mechanisms where we have an anatomical compromise, some problem with the dilator muscles, some unstable ventilatory control leading to OSA. And then there are patients with cardiovascular risk and other disorders. I'm very quickly going over them because this is something which is a very new concept. Up to 30% of patients are having OSA because of anatomical problems. Now these are the candidates who must be referred to surgery and they will get completely cured of their OSA, but 70% of patients will get no benefit out of any kind of surgery in OSA. These are those non-anatomical contributors. The anatomical contributor is if you have a craniofacial abnormality like lower maxilla or enlarged tongue or macroglossia, and their corrective surgery in these 30% patients will make them completely okay and relieved of their obstructive sleep apnea symptoms. Then the non-anatomical contributor, the major problem is the ineffective pharyngeal dilator muscle, which is the genioglossus muscle or the lung muscle. And the chief factor that causes this is diabetes, hypoxia, obesity. All these symptoms can lead to ineffective genioglossus muscle activity. And the treatment for this is that you can do a CPAP or a hypoglossal nerve stimulation, which can improve the condition in such patients. Then there are certain patients who have more sleep fragmentation, where they say that they are able to initiate sleep very well, but they get up early in between. These patients have got low arousal threshold. So even just light, uncomfortable bed, uncomfortable pillows, any kind of stimulus will lead to breakage in sleep patterns. And these patients should not be prescribed CPAP therapy. You should identify them very correctly and then give them, corrective treatment, including some sedatives or hypnoptics, and they will get better with OSA rather than CPAP, because CPAP pressure itself will make, their sleep apnea worse, because they will feel more suffocated because of sleep apnea. Then there is a certain thing which is called loop gain, which is very simple to cane stroke breathing that you see in cardiac patients. It basically says that patients have got an abnormal ventilatory response to their carbon dioxide level. Sometimes they hyperventilate, sometimes they underventilate, and based on this we decide whether this patient to be given a CPAP or a BiPAP therapy. So that is why it is very important to go deep into their phenotype and understand the pathophysiology before you give them treatment, because not everybody is suitable for a automatic CPAP. So if the patient has got more of low dose hypnotic or high loop gain therapy, oxygen will benefit them, whereas BiPAP will be required for other type of patients. There are many screening tools, including the sleep scales and Epworth sleepiness scale, and the diagnosis is made on polysomnography. Study can be done at home, but the best study ideally for the diagnosis should be done in the lab, because then you can follow them later with other parameters. As far as the therapy goes, the number one is behavioral therapy, and auto CPAP is the cornerstone in most of the patients. Behavioral therapy includes nasal obstruction, weight loss, smoking cessation, and education about sleep, whereas mainstay of therapy is CPAP. Now there are so many questions that are asked about how to give CPAP and how to make them compliant with CPAP. The best thing is to titrate it. Manual titration of a CPAP machine during a normal sleep study is the best way to adjust the problems that can happen during subsequent therapies. And you must take care of the interfaces, the pillow mask, the gel mask, or the humidity which is there with the CPAP machine, which can make them more compliant for this kind of therapy. There is tremendous benefit of CPAP therapy. You can see this in the graph, that if you give the pressure, the normal patient has, without CPAP, has got such tiny airway which prolongs and the obstruction is relieved, and most of these patients gain very good comfort out with the CPAP therapy. It has been shown in many diseases, it improves the quantity of sleep as well as quality of sleep, and this eventually leads to resolution in diabetes as well as hypertension and many chronic disorders for which the genesis is basically obstructive sleep apnea. Now, which should be given, manual versus auto CPAP? The best is always a manual CPAP in the initial phase, and once you have titrated the pressure enough, switch over to auto CPAP. Prescription must include the education of patient about the entire device. It's not easy to sleep with a CPAP, so they must be made comfortable so that they can enjoy it. And the best optimization will be if you follow them regularly and aid them in therapy in their goal setting, and give them supportive care whenever possible. Why is it underdiagnosed? Because most of the physicians don't even look at this particular aspect while addressing the preventive part of disease. Physicians are usually the most common provider because they identify OSF first, but only 40% of them begin discussion about it. Moreover, the fears of CPAP therapy are not allied by many physicians. They rather say, okay, you cut down on weight and let's see. Many of these patients may not actually improve with weight loss because they may be having other phenotypes of CPAP therapy. And most importantly, the wrong statement is that they say once you will lose your weight, your CPAP will go away. That is not how it is going to work. It may come back. So they have to be educated very, very properly. Weight loss benefit management is only one aspect of it, not the complete treatment. There are not surgical treatment. That's beyond the discussion for this. But yes, positional therapy can help in some patients. And I'm just about to summarize, but this is something which is very important for our patients. There have been studies by many Ayurveda physicians and alternative therapy physicians that lifestyle changes work very well. There has been a very good study that even blowing 5 minutes of shunk every day, every morning will relieve moderate sleep apnea in many patients, along with standardized yoga protocols. So these therapies should also be incorporated in the lifestyle management. So I'll just summarize. We spend at least 1/3 of our lifetime in sleep. Sleep disorders are a major cause of morbidity, mortality, and poor quality of life. Polysomnography is the gold standard, but very important is that after this polysomnography, we must understand the endotypes and phenotypes of OSA so that we can give them the targeted therapy rather than giving them a blanket OSA CPAP for everything. Thank you very much, and thank you, Professor Gupta, once more for having us. Thank you.
Very much. OSA is also hidden issue, basically non-recognized. ਆਪਾਂ ਕਹਿੰਦੇ ਜੀ ਘਰਾੜੇ ਮਾਰਦੇ ਤਾਂ ਬਹੁਤ ਅੱਛੀ ਨੀਂਦ ਆਉਂਦੀ ਹੈ.
That's a myth.
So yeah, that is something that we should be aware that it is a disease, not a sign of healthy sleep.
It is said that sleep disease happens at night and the diagnosis is made in the day.
Made in the
So how the patient is behaving in the day is going to tell you how well he or how poorly he has slept.
And sleep is also becoming very important part of implication in almost all adverse health effects.
Absolutely.
So good sleep without snoring should be there, and snoring may be the indication of a disease which is manifesting in the day.
Absolutely.
Thank you very much. Now I hand over the session to Dr. M.R. Gupta to proceed with our general session. Thank you, sir. Thank you very much.
Now I invite our next speaker, Dr. Kheman Grover, attending consultant from Max Super Specialty Hospital, Batinda. His talk will be on total hip replacement. Dr. Kheman Grover.
Dr. Grover, please. So now I invite Dr. Meghna Agarwal to please give her talk on approach to hematuria. Dr. Meghna, please.
Good afternoon, everyone. I'm Dr. Meghna Agarwal, and let's begin approach to hematuria. It is defined by the presence of more than 3 RBCs per high power field in urine, seen in 5 to 6% of general population and 4% of school-going children. Now, depending on the source of bleeding, hematuria could be renal origin, ureteric, bladder, or of uncertain causes. Now, in the renal compartment, it can be divided into glomerular causes, interstitial cause, infective, physical, and structural diseases. Glomerular diseases like various types of glomerulonephritis, IgA nephropathy, thin basement membrane disease, Alport syndrome, and many other types of glomerulonephritis like lupus nephritis or ANCA-associated vasculitis can present with hematuria. Any interstitial disease like both non-infective and infective causes. Non-infective causes include most of the time these are drugs that cause inflammation in the tubulointerstitial compartment which leads to hematuria. Infective causes like bacterial, viral or fungal infections. Then physical causes like calculi tumor which can cause trauma to the kidney. Any inherited or acquired medullary sponge kidney disease which can lead to hematuria. Then AV fistula or infarction of the kidney can also be a cause of hematuria. Ureteric compression due to calculi stricture or malignancy can lead to hematuria. Then bladder cystitis, urethritis and prostatitis are some of the other causes. Apart from all these causes, there are some uncommon causes like exercise hematuria or factitious hematuria or use of anticoagulants. In patients who are presenting with age of more than 40 years, apart from ruling out all these causes, we could not find a cause for hematuria. Malignancy should always be looked in these cases. Now, the origin of hematuria, whether it is glomerular origin or extraglomerular origin. The glomerular origin of hematuria is typically cola or smoky brown in color. There are usually no clots. Proteinuria associated with glomerular hematuria is more than 500 milligrams per day. And there could be presence of RBC cast and dysmorphic RBCs. In contrast to extraglomerular hematuria, the color is reddish or pink. Clots may be present. Proteinuria is less than 500 milligrams per day, and the RBC cast and morphology is normal. Now, if any patient who is presenting to us with macroscopic hematuria, first we do any dipstick examination. In dipstick examination, if any pigment is positive, like hemoglobin or myoglobin or intact RBCs are present, it will give us a clue towards the source of hematuria. For example, if the person has proteinuria as well as intact RBCs in urine, it will lead to a diagnosis of glomerular cause of hematuria. But intact RBCs without presence of proteinuria leads to a diagnosis of extraglomerular cause of hematuria. Now the third scenario, when we have heme pigment positive, that could be due to hemoglobin or myoglobin, but RBCs are absent. It could lead to a diagnosis of intravascular hemolysis or rhabdomyolysis. There are various types of drugs and dyes that can impart a different color to the urine, but RBCs and pigment is absent in those cases. These are some of the drugs that can impart different color to the urine. For example, desferrioxamine, hemoglobin urea and myoglobin urea can impart pink color to the urine. Similarly, very commonly used drug like rifampicin can impart orange color to the urine. Then beetroot injection, rifampicin, phenytoin, and hemoglobin urea can impart red color to the urine. Chylurea can cause white colored urine. These are some of the rare causes of hematuria. AV malformations and fistulas, these could be congenital or acquired. The patient can present with gross or microscopic hematuria. AV fistula can also cause high output cardiac failure, but it is not seen in all of the cases. Then nutcracker syndrome. Nutcracker syndrome is a common entity which is seen in children, pediatric age group, in which the left renal vein is compressed between the aorta and proximal superior mesenteric artery. The patient can present with both microscopic and macroscopic hematuria associated with flank pain. Flank pain is usually not seen in all of the cases. Then we have the third entity, that is loin pain and hematuria syndrome. This is a poorly understood entity as the patient presents with loin pain which is unremitting. associated with hematuria. The particular feature of this hematuria is that the patient has dysmorphic RBCs. The RBCs are dysmorphic, that indicates that these are of glomerular origin. Although the patient has normal kidney function, this entity is poorly understood till date. Some of the clues in history that points towards a specific diagnosis. For example, if the patient is presenting with pyuria and dysuria, it indicates a UTI, or in elderly people it could also indicate a bladder malignancy. Synpharyngitic hematuria, that is hematuria that is presenting after or within 24 hours of an upper respiratory tract infection. It could be seen in cases of IgA nephropathy, Alport syndrome, or post-infectious glomerulonephritis. Although hematuria in those cases is seen after 1 week. Then any positive family history of hereditary nephritis and polycystic kidney disease can point toward a source of hematuria. Patient presenting with acute flank pain radiating to groin, suggesting ureteral obstruction due to any cause, could be calculus or blood clot. Then elderly men who are presenting with hesitancy and dribbling of urine, suggesting prostatic obstruction, could also lead to hematuria. Any rigorous exercise or trauma, history of bleeding disorder, cyclical hematuria in women of reproductive age group, which suggests endometriosis of the urinary tract. Then there are many medications that are associated with hematuria and nephritis of the kidney. Residents in endemic areas for schistosoma hematobium, which is also a cause for hematuria. Then there are patients who present with sterile pyuria with hematuria. The causes for the same are renal tuberculosis, analgesic nephropathy, and interstitial disease. Physical examination finding that can point toward a diagnosis is, for example, if the patient is severely dehydrated and presenting with hematuria, it could be due to RVT, that is renal vein thrombosis. Then peripheral edema leads to a diagnosis of nephrotic syndrome or vasculitis. The patient who had a recent cardiovascular event due to atheroembolic phenomena, the patient can present with renal artery thrombosis or embolus. Then any abdominal bruit can points toward a diagnosis of AV fistula or renal artery stenosis. Then enlarged prostate, phimosis, and meatal stenosis can also lead to hematuria. How to collect a urine sample in patient who is presenting with hematuria? First morning urine midstream sample is used for cast and crystals, and the second sample is used for microscopy. 50 ml of urine is taken and it should be analyzed within 3 hours of collection. If the urine could not be analyzed within 3 hours of collection, it should be stored at 2 to 8 degrees Celsius with adequate preservatives. Avoid urine collection within 72 hours of strenuous exercise and during menstruation. Now, after doing a dipstick examination of the urine with a reagent strip, that is standard 10 parameters of reagent strip, we centrifuge 10 ml of aliquot of urine at 400 grams for 10 minutes. 9.5 ml of supernatant is removed, then 0.5 ml is resuspended and transferred to a glass slide. This glass slide is then put under a microscope. For different types of lipids and crystal, we use polarized light microscope, and for high magnification and urine sediments, we use phase contrast microscope. This is the standard 10 para strip to use, which is to be used in to do urine light microscopy. Now, blood or hemoglobin that is present in urine, it is based on the peroxidase-like activity of the hemoglobin and myoglobin. The peroxidase enzyme is capable of detecting both intact erythrocytes as well as pigment in the urine. Intact RBCs will hemolyze on the test pad and will impart a green color to that pad, or RBCs may also show a speckled pattern in the absence of free hemoglobin. How to differentiate between hemoglobin versus myoglobin? Both will produce a positive reagent strip test, but if the urine is red and the plasma is clear, it indicates myoglobin, but if both are red, it indicates hemoglobin. These are some of the false positives and negatives that can be seen when testing certain constituents of urine, like albumin. For example, if serum albumin is less than 0.25 to 0.3 gram per liter, low urine specific gravity, that is less than 1.010, tubular protein or presence of monoclonal heavy chain. In all these cases, false negative results can be seen even when the albumin is present in urine. Then ascorbic acid and bacteria can lead to false negative glucose test in urine. These are dysmorphic erythrocytes. These erythrocytes are characteristics of glomerular hematuria, which is characterized by an irregular outer cell membrane. RBC casts are also associated with the glomerular cause of hematuria. We'll see it in next slide. Now, renal casts. Renal casts are formed by molding of cells and amorphous material in tubules. Shape depends on the site of origin. Matrix is formed by TAM horsefall protein. The first panel is showing RBCs in urine, but these are normal RBCs. Some of the RBCs have crenated membrane. Mind that these are not dysmorphic RBCs, they are normal RBCs. In the second panel, we can see that the RBC membrane is dysmorphic, but also the outer membrane is showing blebbing in the inside picture. These are acanthocytes. So, presence of acanthocytes or dysmorphic RBCs indicates glomerular origin of hematuria. 45 and 1 rule is used when differentiating extraglomerular and glomerular cause of hematuria. 40% of dysmorphic RBCs, 5% of acanthocytes, or only one RBC cast is sufficient to label it as glomerular hematuria. These are neutrophils and granular phagocytic macrophage in under phase contrast microscopy of urine. Then depending on the origin of the tubular epithelial cells, from deeper or superficial layer, they have different morphological pictures. These are squamous epithelial cells and then different types of cast. The first one is hyaline cast, the last one is waxy cast. Waxy cast is usually seen in CKD patients. Then erythrocyte cast, hemoglobin and leukocyte cast, epithelial and bilirubin cast. If the patient is presenting with persistent hematuria, although we have done an extensive workup in those patients, but no obvious cause could be found, then he or she should be looked for cancer of renal, bladder or prostate. Cigarette smoking, occupational exposure to aniline dyes, aromatic amines, dietary nitrites and nitrates, analgesic abuse or chronic cystitis, use of cyclophosphamide, pelvic irradiation and schistosomiasis are some of the causes which can lead to urothelial carcinoma. Now, initial workup for persistent hematuria include urine analysis and microscopy to determine the morphology of RBCs, crystals and casts. Apart from these, we have to go for complete blood count, complete metabolic profile, coagulogram of the patient. Repeat urine analysis in a few days if these come out to be negative. Further urological evaluation is only warranted when out of 3 samples that are tested for urine, 2 of them are showing hematuria. To rule out the non-glomerular causes of hematuria or to rule out any structural disease of the urinary tract, we can go for radiological investigation like CT, USG or IVP, urine cytology and cystoscopy if required. If all these scans come out to be negative, still the patient, 1% of older patients are at risk of malignancy in the coming 3 to 4 years. So we have to stay vigilant in those cases, and the recommendation in these cases is that urine cytology and analysis should be performed in those patients at 6, 12, 24 and 36 months. If the patient is presenting to us with visible or non-visible hematuria, first of all, UTI and along with the urological assessment is done in all cases. But if the hematuria is asymptomatic and non-visible, then we go for nephrological examination like blood pressure measurement, GFR, plasma creatinine and urine ACR. The patient who has aged more than 40 years, he should undergo urological assessment. But if the patient is less than 40 years of age and any of the parameters like BP, eGFR or ACR are abnormal, then nephrology assessment is must in these patients. If after all these findings no cause is established, then annual assessment of BP, eGFR and ACR is indicated and referral to simultaneous department according to the need of the patient. Thank you. Any questions?
Thanks, Dr. Meghna Goar, for your very useful and informative talk on hematuria.
Thank you, sir.
Now any comments and queries are most welcome. Any comments and queries, please? Thanks.
Thank you, sir.
Now I invite our next speaker, Dr. Rajni Jindal. He is from Jindal Heart and Infertility Center. She will be delivering her talk on polycystic ovary and the forgotten uterus.
And the forgotten uterus. Thank you, sir. Thanks for the introduction. Today I'm going to talk about this common disorder, polycystic ovarian disease. Since I am a gynecologist and I deal with females, so we see a lot of young girls and even married couples who are struggling with infertility, and young girls who are struggling with irregular menstruations and delayed menarche, obesity, hyperandrogenism, hirsutism. So this is what this disorder is, polycystic ovary. So we are treating polycystic ovary because people are sensitized to it. Patients do come with this problem. It's a common problem. And today I want to talk about the uterus, what effects polycystic ovary has on the uterus in the short term and in the long term, which cannot be forgotten. Because the people with PCOD, they need lifelong care and they need follow-up regular. Even after they've completed their families, they've had children, they still need to see their gynae to prevent the other problems which are associated with it. So it is a multifactorial disorder which is affecting 8 to 13% of all women of reproductive age. And this was first described in 1935. So we don't have a clear etiology to this problem. We don't know why it happens. But like diabetes, it is a multifactorial problem, and genetics do play a role, and environment and lifestyle also plays a very big role in this disorder. The diagnostic criteria are also controversial, but since like so many years we've been studying, there are two important things. 2 out of these 3 criteria should be present in a female if we want to label her as polycystic ovary. The first and foremost is oligo-anovulation or anovulation, because the infrequent oligo-ovulation means usually a girl would, after menarche, after the start of menses, she would menstruate every 28 to 30 days regularly. So in patients who have polycystic ovaries, the ovulation will not happen regularly. So she will miss her periods. She will not menstruate every month. She may not menstruate without medicine. And she would also show some biochemical changes like hormonal changes. Her LH, luteinizing hormone, which is coming from the pituitary, is raised compared to the FSH. Then she has signs of excessive androgen in the body, like excessive hair growth, facial hair, and hair on the upper body, upper back, so which is called hirsutism. So these 2 are the main criteria: irregular menstruation, infrequent menstruation, which is because of irregular ovulation, and second, hirsutism. So the third criteria, which is the picture morphology of the ovary, the picture on ultrasound, polycystic ovary, this is not an essential criteria, because in young adolescents, even a normal ovary could give that picture of a polycystic ovary. In young girls, there are a lot of follicles in the ovary, and sometimes they are mislabeled as PCOD. So when somebody has started menarche and she has irregular period, so we should watch such girls for 2 years. If she persists to have irregular cycles, even after 2 years of beginning of menstruation, then we should think about polycystic ovary, not the first 6 months or the first 5 months, because the menarche can also mimic PCOS. The first 2 years after menarche, girls can have irregular periods, and that is because of the immaturity of the HPO axis, and not every time because of polycystic ovaries. Now here is a little picture. On my left, we have the ultrasound picture. So this is how it appears on ultrasound. You can see that the ovary is bigger in size, and the outer surface is very smooth. Normally, it is not so smooth. And then you have a peripherally arranged multiple small follicles. These are basically atretic follicles. And then if you look at the stroma of the ovary, the stroma is very thick. This stroma of the ovary is very thick. In a normal ovary, you see follicles all over. They are spread throughout, and the number is like 8 to 10. But in a polycystic ovary, the number could be anything between 20 to 30 to 50, depending on the severity of polycystic ovary. And if you see the laparoscopy picture, this is the uterus. Uterus is normal in size, and here you can see that the ovary is almost as big as the uterus. In a normal patient, the ovary would be like this, 1/3 of the size of the uterus. So the severity of PCOS will depend on the size of the ovaries and the number of follicles also, and the thickness of this stroma. So this is how it is diagnosed. So ultrasound is a very good tool to diagnose. We don't need to do a laparoscopy in a patient with PCOD. Just an ultrasound, and then clinical picture, then history, and hirsutism assessment, then hormonal test. So this is what is important to label somebody as a polycystic ovary. So now, what is the impact on the uterus? In a PCOS, it can have several changes on the uterus. First, menstrual cycle dysfunction. This is a diagnostic criteria even for PCOS. But PCOS can also lead to change in the morphology of the uterus. So certain studies have been done on rats, and they have been exposed to increased androgens, and it has been seen that it leads to certain changes in the uterus, like decrease in the length of the uterus or increase in the muscle of the uterus. And those things can later on present like preterm labor, premature birth, and all those things. Though it has not been proven conclusively that it changes the morphology, but there are studies going on, and we'll have more knowledge, we'll be more knowledgeable in the years to come. Then PCOS also affects the pregnancy. It affects the implantation and the uterine receptivity. So this we commonly see in patients who have PCOS, even after treatments of fertility, the pregnancy rates are lower because of reduced implantation. And even if they get pregnant, there is increased risk of miscarriage in such patients because of impaired uterine receptivity. Receptivity depends on the inflammation, because it is a chronic inflammatory state also. And there is immunoregulation is disturbed in such patients. We are going to see that in detail. And then in the long term, long prolonged exposures to increased estrogens and androgens can lead to endometrial hyperplasia, so which is a matter of concern. So even after the childbirthing and everything is done, we need to monitor our ladies who have PCOS for endometrial hyperplasia. And for this, we need to do a simple ultrasound and measure the endometrial thickness at regular intervals, like at least once a year. And if she has menstrual disturbances or heavy bleeding, then it can be done whenever she has that problem. But at least once a year, that patient with PCOS should get an ultrasound done to see what her endometrial thickness is. So I've already touched this. So there is something about cervicofundal uterine peristalsis, which they say is decreased in women with PCOS, and this can also contribute towards infertility. Now, uterine dysfunction in pregnancy is mainly because of impaired endometrial receptivity, compromised decidualization when the pregnancy occurs, then hormonal dysregulation, then heightened inflammation and immune system dysregulation. So PCOS women, they may have increased risk of incoordinate uterine activity during pregnancy and labor and implantation failures and miscarriages also. So even during pregnancy, we need to monitor them. We need to see whether there is any cervical shortening, and this monitoring is also done with ultrasound. If we see that the cervix is getting shortened and the patient is going to have a preterm labor, then certain interventions can be done, like a cervical stitch can be put, or she can advise rest, bed rest, and all those things can be prescribed to this patient so that she takes the pregnancy to term and she delivers a good weight baby. So here, this is a very important, simple graphical representation of a normal menstrual cycle. So if we see a normal lady who is not a PCOS, we see the pituitary hormones. FSH is this red one, and then LH. So we see that in the mid-cycle, around the day 14, day 12, there is a peak, and then it falls down. And this LH peak leads to ovulation. And rest of the days, you see that FSH and LH, they are both at a lower level. Whereas in PCOS, this LH, the yellow line, it is tonically raised throughout the cycle. So this LH is always raised for this patient. LH leads to more androgen formation in the body. And even the FSH, the peak of the FSH is not so prominent, and LH is the main dysfunction actually. This is coming, peaking and going down, but this tonic LH leads to anovulation, it leads to abnormal follicle formation, it leads to increased androgen synthesis, and it leads to all the problems which are associated with PCOS. If we look at our common hormones, estrogen and progesterone, so because of those FSH and LH changes, in a normal lady, so this green one is the androgen. This is the androgen which goes up and it falls down. And in the later half of the cycle, the progesterone will peak, which is represented by the purple line. So progesterone will peak in the second half of the cycle, after the day 14. In a PCOS patient, this progesterone is always low. Progesterone is one hormone which reduces cell proliferation, it reduces hyperplasia, it will reduce the cell activity, cell division. So this is the hormone which is controlling the thickness of the endometrium in the uterus. So in a PCOS, because the progesterone is always deficient, that check on the endometrial lining and thickness is not there. And on the contrary, the estrogen and androgens are raised. The green is androgens, which are raised in PCOS patients. So usually these patients have hirsutism. They have a lot of hair on the body, like male type distribution of hair on the body. So these are the two things which are very, very important. And the treatment also, we have to bring down the LH, we have to increase the progesterone. Some of these patients could be resistant to progesterone, so there we use metformin and oral contraceptive pills. So the treatment remains the same for all the disorders which are associated with PCOS, but the important thing is we cannot ignore these women once their family is complete. We have to educate them and keep them on follow-up. At least once a year, we should check for other problems which can come because of polycystic ovary. I've already explained all this. So basically, progesterone will increase in the second half of the cycle, and this doesn't happen in a polycystic ovary. And deficient progesterone, and there is a constant E2 estradiol which is present. In a normal female, we would see that estrogen is low, then it peaks and it becomes low again. In a PCOS, it is raised. LH, estrogen is raised throughout the cycle, which is leading to endometrial changes, and those changes if they persist for few years, they can lead to heavy menstrual bleeding and unpredictable bleeding patterns. So even insulin resistance, so PCOS and metabolic syndrome are very much associated. So it's not only the uterus and the ovary which is being affected, it's the whole body. It's like diabetes, where even the lipids are deranged. They are prone to diabetes, they have insulin resistance, they always have increased insulin and increased androgens. And this amplifies the stimulatory effects of estrogens, which leads to unopposed estrogen exposure in the endometrium and heavy menstrual bleeding and unpredictable bleeding patterns. So this is just a diagrammatic representation. We can see here, this is white line, this is the endometrium, this is the normal endometrium. But in a PCOS, you can see it has become thicker. This becomes thick, and sometimes the patient doesn't even know. She says कि मुझे तो periods पहले भी नहीं आते थे, अब भी नहीं आ रहे, और हमारे पास आती है वो. She comes with heavy bleeding. That bleeding has been going on since a month. And then we look at her on ultrasound, हम देखते हैं कितनी bleeding हो रही है, उसके बाद भी endometrium is 20 mm, very thick. So in such patients, we need to do an endometrial biopsy, endometrial curettage करना होता है, and it has to be sent for histopathology to rule out whether she has any atypia or cancer forming in the uterus. So that is very, very important in such patients. So first in ultrasound, if the thickness is low, normal, like 7 to 12 mm, it's okay, we can leave the patient. If the thickness is more than 15 mm, we definitely do an endometrial biopsy for such patients. So again, in adolescence, when a girl comes with irregular menstruation, so it's not good to label her as PCOS just on an ultrasound diagnosis, which is showing a big ovary and number of follicles are raised. There, we have to wait for 1 to 2 years, because 50% of these adolescents would not have PCOS, and the problem will go after 2 years. So when symptoms extend beyond 2 years, the menstrual dysfunction could be considered as a marker of hyperandrogenism, PCOS, and metabolic disorders in later life. I think we've already discussed this. Increased androgens, increased androgen receptors, decreased progesterone, and this leads to endometrial dysfunction. Endometrial dysfunction in pregnancy, again, it is because of the type of estrogen receptor is also different in these patients. They have more of androgen receptor alpha, whereas in normal patients, we have more of androgen receptor beta. So in PCOS, higher ER alpha receptors in the mid-cycle versus ER beta receptors, they lead to decreased progesterone. And increased progesterone resistance is also seen in PCOS patients. Sometimes just progesterone is not going to treat her because they might be having different genetic expressions and increased estrogen resistance, which can lead to decreased implantations. So as in PCOS, especially in obese PCOS and in PCOS where hyperandrogenemia is there, metformin is a very good drug. It is a cheap and good drug which decreases the insulin resistance. It increases the implantation and endometrial receptivity in PCOS, and altered endometrial receptivity present through a number of possible mechanisms at the molecular level. So it is because of the insulin resistance and hyperinsulinemia, because of obesity, because of the pro-inflammatory cytokines, because of hyperandrogens, and because of progesterone resistance. So all these 5, 6 problems, they can lead to pregnancy losses. And metformin has been found to improve decidulization in the stromal cells and improve the implantation also. So usually metformin is given in a dose of 1500 milligrams daily in our patients. And we don't start off with 1500. We usually start with, we gradually increase the dose because the side effects are there. So people may not tolerate 1500. We usually start with 500 to 750 and gradually increase and take it to 1500. So which is a very good drug, and it should be continued in these patients. Throughout life also we can give, because insulin resistance is going to present later as diabetes and dyslipidemia, and all those problems will come. So metformin, systemically, it is going to improve the insulin resistance and serum androgen levels. And intra-ovarian changes are also happening because of metformin. It will improve the ovarian environment by local effect on ovarian steroid genesis and intra-ovarian insulin resistance. So there are 2 organs which are making the androgens in PCOS. One is the ovary. Ovary, under the effect of extra LH, is making androgens. And the adipose tissue is also giving more androgens. So in obese PCOS, so the most important intervention is diet and exercise and weight loss in those patients who are obese. Because in PCOS, we can have 2 types of, we can have different spectrum of phenotypes. We see a variety where the patient is very lean and thin, and she has a polycystic ovary, she has hyperandrogenemia, she has hirsutism, irregular periods, but she's very lean and thin. So this patient is also a very difficult patient because she is prone to all the complications that are seen with PCOS. Even during pregnancy, during fertility treatment, this patient is at very high risk of ovarian hyperstimulation syndrome. So lean PCOS, and then the second variety is the obese PCOS. In an obese PCOS, the first and foremost is the diet, weight loss. Sometimes their menstrual irregularity can reverse just with weight loss and healthy diet and healthy lifestyle. Her symptoms can reverse. So even the intra-ovarian environment is affected with metformin. It improves the paracrine insulin relating signaling, it improves the receptivity, so it is beneficial at all levels. So endometrial hyperplasia. Now progesterone-based contraceptives, they are used. Normally when a patient comes with endometrial hyperplasia and we've done an endometrial biopsy, we have ruled cancer, we have done a curettage, but we need to give her something so that her endometrial thickness remains thin and she doesn't have abnormal uterine bleeding. So usually we give progesterones in such patients. Even intrauterine progesterones can be used, like we have devices, progesterone releasing devices, which we put in the uterus, and that device gives progesterone for 5 years, and the patient doesn't need to take it orally. Then we can give progesterone on a cyclical basis also. We can give it in the second half of the cycle, especially when the patient wants to conceive. We give it in the second half, and that also gives protection to the endometrium. But in certain patients, their progesterone resistance could be present, where just progesterone may not help. There we need to have an alternative plan to prevent endometrial hyperplasia. So there we use metformin and oral contraceptive pills. Low-dose oral contraceptive pills along with metformin is used in those patients who have progesterone resistance. This is an ultrasound image of the endometrium. So this is the endometrium. It is thick, and then you have this hypoanechoic areas in the endometrium. So this is a typical endometrial hyperplasia, where we call it a cystic hyperplasia of the endometrium. And this is a Swiss cheese appearance. So this is very typical of polycystic ovary. So association between polycystic ovary and endometrial cancer was described 60 years ago. And if we see at the risk of endometrial carcinoma, it is 3 times higher when we compare the PCOS to the non-polycystic ovary patient. And endometrial carcinoma risk becomes 4 times higher in PCOS women with endometrial hyperplasia. Even in endometrial hyperplasia, it can be of 3 types. It could be a simple hyperplasia. A simple hyperplasia is not that bad. There we give 6 months of progesterones and the signs are reversed, and we can give then cyclic or long-term progesterone. Such patients, we usually don't do surgeries in simple hyperplasia. We don't do hysterectomies. We treat this with progesterone. But if the endometrial hyperplasia is associated with atypical cells, atypia, there we need to do something. And there we need to counsel the patient, follow her up. Sometimes even that can reverse with progesterone, but regular follow-up is important. If that changes to cancer, then definitely patient needs radical treatment for cancer. So this is the ultrasound picture of endometrial cancer. Here you can see that the endometrium is thick, plus you can see this is the hyperechoic and heteroechoic endometrium. So there, when we see something like this, we need to do again a biopsy and confirm the diagnosis. A hysteroscopy biopsy or a simple endometrial biopsy, endometrial curettage, a fractional curettage. So such patients would need a good thorough curettage, then a histopathology would be done, and then the patient would be treated for endometrial cancer. So our PCOS patients, they are high-risk patients. They have to be followed up for all these changes by ultrasounds. Metformin and cyclic OCPs have successfully reversed early stage endometrial carcinoma in women after 6 months of treatment. And metformin is known to have a synergistic anti-tumor effect to progesterones on the endometrial cells, even in vitro. It has been found to be helpful, synergistic anti-tumor activity. And mechanism of action is through increased progesterone receptor mRNA and protein expression in endometrial cell lines. And short-term pre-surgical treatment with metformin also decreases cellular proliferation, which is assessed by Ki-67 and proliferation index. And metformin induces apoptosis also, cell death and apoptosis in endometrial cells. So metformin is a good and cheap drug which is available to us for our patients with PCOS. Along with progesterone or oral contraceptives, it can be used in these patients. So we've already done this. Now, prevention, how can we prevent endometrial carcinoma? First and foremost, reduction of BMI in those patients who are obese. Then progesterone-based therapies, either systemic or local. Then 30% of women with PCOS do not respond to progesterone. So in these patients, we can combine metformin and OC pills, which is a good alternative. Metformin has a synergistic action to progesterone, and short-term metformin pre-surgery will also affect the cell proliferation. And in vivo and in vitro studies have shown value of metformin in reversing simple endometrial hyperplasia, but we need further studies. So the key points regarding polycystic ovary and uterus molecular pathways, there are alterations in the uterine molecular pathways. increased estradiol, enhanced ER alpha receptor activation, increased progesterone receptor expression, upregulation of androgen receptors, increase in expression of ER alpha and androgen receptors in the epithelial and stromal cells, higher PR expression, particularly in the epithelium, enhanced P160 steroid receptor co-activator. These are the molecular pathways which are responsible for giving us these changes. So to conclude, PCOS is a complex and multifactorial disorder which is affecting around 30% of the subfertile couples. So 18 to 13% in the general population, in the normal population, 30% in the subfertile population we see PCOS. Endometrial and uterine dysfunction plays a pivotal role. Women with PCOS present with menstrual dysfunction affecting the uterine health in the long term, leading to endometrial hyperplasia and cancer also later. And metabolic disorders associated with PCOS, they include hyperandrogenism, hyperinsulinemia, insulin resistance, dyslipidemia also, and diabetes also. Type 2 diabetes can come these patients at a younger age. Data regarding the effects of PCOS in uterine morphology and function, pregnancy, as well as initiation and induction of labor are sparse. And recent studies indicate that adverse endometrial changes could be reversible with anti-androgen and metformin. However, no specific treatment strategy can be recommended at this time, highlighting that more studies are urgently needed. And this underlines the need to address these issues in future studies. Thank you.
Thanks, ma'am, for your very informative talk on this very important and common condition nowadays. I think obesity and dietary habits are very important causes for this disease now, because young food is being taken by the younger generation, causing obesity and then increasing incidence of PCOS.
Yes, yes. Especially the obese PCOS, so it is rising. And these patients are good patients, you know, they need to adopt healthy lifestyles and they'll be cured of the disease. The thin PCOS is more difficult. So obese, there we need to stress upon decreasing BMI. Thank you.
Thank you, ma'am, for taking up your valuable time to apprise us about this important topic. We are really thankful to you. No, we have included, in the morning there were 3 lectures from dental doctors, and you won't believe we did not know 2-3 things about that. Dr. Parth has presented a lecture where he told us that implants, like heart, you are giving implants to the vertebral collapse treatment also. I think, I am sorry to say, even the orthopedicians will not be knowing that implants are being, like stunting is being done for heart disease, or you can say brain. So it is being done for collapse of the vertebra also. I didn't know that, in fact. Reinforcement is separate, that we know. So they are putting the stunt in the balloon in the vertebra and putting cement in that, so increasing the width of that. So I think all the lectures, all the subjects should be included. So next time we are, compartmentalizing the things, that is dental, eye, ENT. So we are trying to incorporate all the subjects so that we should have an overview of all the subjects. Sometimes patient come to me, we can be able to refer that. If we don't know, so we will be confused, patient will be confused. So that is the purpose, and thank you very much for apprising us about PCOS. Thank you.
Now I invite our next speaker, Dr. Jovan Preet Singh, Assistant Professor, Department of Medicine, DMC Ludhiana. His topic is Approach to Connective Tissue Disorders.
A very good afternoon. At the outset, I would like to thank Vipul sir for inviting me here. So after such enriching mechanistic talks, I'll give your brains a break and I'll take you more through a visual perspective that how to approach a case of connective tissue disease. So when we talk about the connective tissue diseases, it includes SLE, Sjogren's disease, systemic sclerosis, inflammatory myositis, undifferentiated connective tissue disease, and mixed connective tissue disease. So when should we actually suspect connective tissue disease? If somebody has small joint predominant arthritis, which is symmetric, if one has photosensitive rash, which includes Malwa rash and other photosensitive rashes, if somebody has persistent oral or ocular dryness, Raynaud's phenomena occurring well into adulthood with no family history, skin thickening over the fingers in particular, puffy or swollen fingers, if somebody has subacute proximal muscle weakness, particularly in middle-aged females, or if there is a non-UIP pattern of interstitial lung disease. So these are the people where we should consider connective tissue diseases strongly. Now I'll take you through each one of them one by one. When should systemic lupus erythematosus be considered? If one has Malwa rash and there is a classical nasolabial sparing, because that area is said to be photoprotected area. And if there is a history of photosensitivity, if there is painless ulcers, particularly occurring over the hard palate, if there is a alopecia, serositis, which includes pleural, pericardial effusion or ascites, if there is small joint predominant symmetric arthritis, involving particularly the small joints of hands with early morning stiffness, if there is a cytopenias or fever of unknown origin. These rashes, these Malwa rashes can at times be too florid. If you look at the second image, there is a classical sparing of nasolabial fold, but if they are too florid, they can at times do not respect that nasolabial sparing, as you can see in the first image. Then they can be distributed over the extensor aspect of forearms, over the nape of the neck, shoulder region, upper back. So these are called as subacute cutaneous lupus rash. So they can be of papillosquamous variant or annular polycyclic variant. And at times they can be very disfiguring, as you can see in the first image, that is a DLE rash. There is a central atrophy, scarring, telangiectasias with hyperpigmented erythematous rim, and they can cause permanent scarring alopecia, mostly located over the scalp and the neck region and the face, but at times they can involve the hands as well. And chilblain lupus, generally if we see a patient who is working at high altitudes, in extreme winters, they can have chilblain lesions, but if one is developing it in Punjab or in warm weather, we should always suspect SLE. So these are tender erythematous violaceous papules or plaques which are on the acral surfaces. They are associated with desquamation, they are associated with itching. So if one is developing it in warm weather, or for that matter, even in winters in Punjab, I would strongly suspect lupus. Then at times, the hands can have such kind of mulberry appearance. So this is as a result of palmar vasculitis, which is causing cutaneous ulceration and necrosis. And lupus profundus. So lupus profundus is basically a DLE rash, and if you can see that there are some sunken areas here. So these sunken areas are because of the involvement of the underlying subcutaneous fat. So inflammation of subcutaneous fat is called as panniculitis, and if there is an overlying DLE rash, so this is called as lupus profundus. So these are the different kind of cutaneous rashes which we see in patient of SLE. And this is the hard palate ulcer I was talking about. So this is classically painless ulcer. It looks very formidable, but it is painless. Patient only complains of pain when he tends to swallow something, when he tends to take meals. Otherwise, it doesn't cause pain. So this is the classical site of oral ulcer in lupus patients. Then this is Jacquard's arthropathy. So if you look at the first image, so there is very deforming arthritis. So patient has swan neck kind of deformities. But the moment you ask this patient to keep their hands flat on a surface, these deformities tend to disappear. So such deformities which are reversible is called as Jacquard's arthropathy, and it is very much seen in CTDs, not only in SLE but other connective tissue diseases as well. Now moving on to this next connective tissue disease, which is the Sjogren's disease. So oral or ocular dryness. I'm sure all of us had oral or ocular dryness at some point of time in life, but if it is persistent, if it is occurring almost daily for at least 3 months, then we should think of Sjogren's disease. Atypical caries. So caries, I'm sure many of us do have dental caries, but if somebody is developing caries involving the frontal incisors, so that is a very pertinent feature of Sjogren's disease. Parotidomegaly, as you can see in this image, that this female has bilateral parotid enlargement, which is again classical of Sjogren's disease. Again, small joint predominant symmetric arthritis, Jacquard's arthropathy, which I have told you, hypokalemic paralysis. It's a very close differential of Guillain-Barré syndrome. A patient suddenly wakes up in the morning as he's quadriplegic. You check potassium, it's very low. And in that patient, on evaluation, if you find the cause to be distal renal tubular acidosis, then one of the leading causes of distal renal tubular acidosis is Sjogren's disease. Then ILD, particularly if there is a NSIP or LIP pattern of ILD, then Sjogren's disease must be considered. Now this is keratoconjunctivitis sicca. In first image, there is a fluorescent staining of the cornea, and in the second image, there is a lysamine green staining of the conjunctiva. So you can see because of the dryness, there is a multiple epithelial defects which are highlighted as fluorescent staining dots, and similarly over the conjunctiva highlighted by the lysamine green stain. And this is the Schirmer's test. It is said to be positive if it is less than equal to 5 mm in 5 minutes. And these patients, because of the salivary hypofunction, these can have hyperlobulated fissured tongue. And at times they can have palpable purpura. Particularly these patient tends to complain that after prolonged standing they used to develop such purpura over the lower extremities. So this dependent palpable purpura, which is nothing but cutaneous signature of leukocytoclastic vasculitis, is again a feature of Sjogren's disease. And they can have annular polycyclic rash just like systemic lupus erythematosus. And this is what I was talking about. So many patients, they will never, some patients even don't complain of ocular dryness, but the moment you see such kind of teeth, you should always suspect Sjogren's disease. So if caries are involving the frontal incisors, it's a very pertinent feature of Sjogren's disease. Then lymphocytic interstitial pneumonia. This pattern of ILD is very specific of Sjogren's disease. There are very few diseases in which this pattern of ILD is seen. One of them is Sjogren's disease, another is HIV, third is severe combined immunodeficiency. So you can see there are multiple thin-walled cysts involving bilateral lung parenchyma. So this is very classical for Sjogren's disease. Now moving on to the next connective tissue disease, which is systemic sclerosis. So Raynaud's phenomena is universally seen in systemic sclerosis. You should always suspect systemic sclerosis in a patient of Raynaud's phenomena. Now Raynaud's can again be primary or secondary. So when should you think that it is secondary, not primary? Many patients, particularly who occurs in high altitude, who lives in Himachal or Jammu and Kashmir, they do have this bluish discoloration of fingers. But when should you start suspecting that it is a connective tissue disease? So primary Raynaud's, which occur at high altitude, which is a normal thing, usually occur in less than 20 years of age, and usually there is a positive family history. So if there is no family history, if somebody is developing beyond 20 years of age, or if there is involvement of the thumb, because generally in primary Raynaud's, thumb is spared. So if there is involvement of the thumb, or if somebody is developing digital tip ulceration, then you should start thinking secondary Raynaud's, and you must send ANA, because these patients can very well have this connective tissue diseases. Then Raynaud's phenomena, then if it is severe enough, then it can cause digital pit ulcers or scar. So Raynaud's phenomena by and large can be seen in all the connective tissue diseases, but if it is severe enough to cause digital pit ulceration, then the diagnosis of systemic sclerosis is leading. Then sclerodactyly, if one has skin thickening over the fingers, if one has telangiectasias over the palms, over the cheeks, over the lips or tongues, then also you should think of systemic sclerosis. Calcinosis is nothing but soft tissue calcification, which is again a very characteristic feature of systemic sclerosis and dermatomyositis. NSIP pattern of ILD or pulmonary artery hypertension are quite frequently seen in systemic sclerosis. Now Raynaud's, I have told you, is pretty frequent, but if Raynaud's, if it is severe enough to cause digital ischemic ulceration, which is because of the small arterial disease, you should start thinking systemic sclerosis. At times they can have digital gangrene because of the involvement of the larger vessels, and because of the skin thickening, these patients can develop traumatic ulceration at the PIP joints. This is one of the patients I had who had this kind of white substance exuding out from the finger. So this is calcium deposit. So this is calcinosis. And if you look at the X-ray, so it looks very ornamental, but these are all actually calcium deposits in this patient. So this is again very much suggestive of systemic sclerosis. Now they can have skin thickening. there is a marked thickening of the fingers, and because of the perioral thickening, these patients have difficulty opening mouth. So again, if somebody is not able to open mouth, we have very few causes. One of them is this systemic sclerosis. Another one, if somebody has involvement of the temporomandibular joint, TMJ arthritis, or if somebody has TMJ dislocation, or in gutka chewer, they can have submucous fibrosis or tetanus. So these are very few conditions where we can have this decreased mouth opening. Then this is the another patient where you can see there is a marked skin thickening involving the trunk. Then they can have salt and pepper pigmentation. Again, this is very classical of systemic sclerosis because of the retention of the melanin in the perifollicular area. So they can have such kind of salt and pepper pigmentation. And these are the mallet telangiectasias I was talking about. So apart from the cheeks, they can also have these telangiectasias over the palms, lips, and tongue. And this is watermelon stomach, what we call as. So just like watermelon, these patients can have this gastric antral vascular ectasia, and in again NSIP pattern of ILD. Now moving on to the next connective tissue disease, which is the autoimmune myositis. So a young female presenting with subacute proximal muscle weakness developing over weeks to months. Again, you should start thinking inflammatory myositis. They can have concomitant dysphagia, they can have neck flexor weakness, and the classical rashes of dermatomyositis, calcinosis, and ILD. Particularly if there is a overlap of NSIP and OP pattern of ILD, we should suspect myositis. So this is the Gottran's rash which you can see in this patient. So there is a macular erythema involving the fingers, and this is the holster sign. So holster is basically a leather case which is used to keep the gun, and it is tied to the belt. So this is the holster area. It is over the lateral aspect of the thigh. So this patient has both of these rashes, again seen in patients with autoimmune myositis. The other rashes which can be seen in dermatomyositis are the Gottran's papules. So these are erythematous violaceous papules present over the knuckles, over the PIP joints, over the DIP joints. At times, they are not papules, but there is a flat erythema. There is a macular erythema which can occur over these areas, as well as other extensor surfaces of elbows, knees, and ankles, which is called as Gottran sign, as depicted in image B. And in C image, you can see that there is a photosensitive rash over the anterior V of neck, which is called as V sign. And this rash can also be distributed over the nape of the neck, over the shoulders and the upper back, and this is called as shawl sign. And there could be periangular telangiectasias, capillary dilation, hemorrhages, cuticular overgrowth. So those are the other findings which can be seen in patient with dermatomyositis. Now if you look at both the images, they looks very similar, but what is important is that in dermatomyositis, this erythema is located over the joints. It is over the knuckles, over the PIP joints, over the DIP joints. Vis-a-vis in systemic lupus erythematosus, it is in the interphalangeal area. It is sparing the joints. It is not over the knuckles, it is not over the PIP joints, it is not over the DIP joints. So this is the difference between the rash in dermatomyositis and SLE. Now at times these patients can have these ulcerative skin lesions. They can have this erythema over the palmar aspect of this thing. And this is a very sinister sign. We should always be on watch out for this, because these patients can have rapidly progressive ILD. They can develop respiratory failure within 2-3 months, and it is associated with high mortality. Again, calcinosis, again a patient who had this kind of calcium deposits all over the body, and very much similar looking X-ray, and they can have this is all white looking as the calcium deposit. So extensive calcinosis again is a feature of dermatomyositis apart from scleroderma, particularly in childhood onset dermatomyositis. Now another entity which is quite, I would say it's not very old entity, antisynthetase syndrome. So this condition should be considered if a patient has complex of fever, interstitial lung disease, myositis, arthritis, and Raynaud's. But what is mandatory is the presence of amino-acyl tRNA synthetase antibodies, most common being anti-Jovan antibody. And this is again a very classical finding seen in patients with antisynthetase syndrome. They have such kind of cracking or fissuring of the fingers, particularly over the radial aspect of the index finger. And if such rash appears on the feet, then it is called as the hiker's feet. Now when should we start thinking of overlap connective tissue disease rather than plain SLE? If a patient of SLE has myositis, if a patient has pulmonary artery hypertension, ILD, severe Raynaud's, puffy fingers, or erosive arthritis. So presence of any of these in a patient of SLE should make us think of overlap CTD rather than SLE. So this is what is shown in this image is the puffy fingers, which is a very classical feature of mixed connective tissue disease. Now mixed connective tissue disease, as the name suggests, is a mixture of different connective tissue diseases, be it lupus, systemic sclerosis, rheumatoid arthritis, dermatomyositis, or polymyositis. But again, to make a diagnosis of MCTD, serology is important. We need high titer anti-U1 RNP positivity to label one as MCTD. If you look at the different criteria of MCTD, what is common to all the criteria is that serology is must. Serology must be positive to label a case as MCTD. Now, what is undifferentiated connective tissue disease? If a patient has some features of lupus or scleroderma or myositis or Sjogren, but it is not fulfilling the classification criteria of any of these. Say a patient has arthritis and ANA positive, I will call it as UCTD. Say as somebody has Raynaud's with ANA positivity, I'll call it as a UCDT because it is not fulfilling criteria of any of the connective tissue diseases. So what is UCTD? Again, they can have symptoms of either of these, but do not meet the classification or diagnostic criteria for any of the condition. Now going to the investigations, if you have suspected connective tissue disease in a patient, each investigation is of paramount importance. If somebody has cytopenias, say anemia, leukopenia, thrombocytopenia, you should think of SLE or Sjogren's disease. If inflammatory markers are raised, you should think of inflammatory myositis. If LFTs are deranged, if OTPT is increased, you should think of hemolysis, myopathy, or autoimmune hepatitis. If there is a hypokalemia, you should think of Sjogren's disease. Proteinuria is seen in SLE, Sjogren's, and MCTD. CPK muscle enzymes are raised in myopathy. LDH could be raised either in hemolysis or myopathy. Coombs test is positive in SLE. Complements are low in SLE and Sjogren's disease. Cardiac biomarkers are raised, which is because of the myocarditis, is seen in SLE, MCTD, and myositis. Effusions on X-ray or ultrasound. So evidence of serositis is seen in SLE, Sjogren's, and MCTD. Erosions on X-ray are seen in MCTD and scleroderma. Calcinosis is seen in scleroderma and myositis. Acroosteolysis, the pulp loss and the resorption of the distal phalanx is seen in scleroderma. ILD changes are seen in Sjogren's, scleroderma, myositis, and MCTD. pH is seen in scleroderma, MCTD, and antiphospholipid syndrome, and myocarditis again is seen in SLE, myositis, and MCTD. Now this is the last slide. If we have suspected connective tissue disease, the go-to test is ANA, that is the most specific test. So if ANA is positive in a patient and patient has predominant skin and joint involvement, you can go for the ANA profile, and depending upon which antibody is positive, you can label it. If dsDNA is positive, Smith is positive, it's likely a case of SLE. If there is a history of relevant drug exposure and antihistone antibody is positive, you should think of drug-induced lupus. If somebody has amalgam of Raynaud's, sclerodactyly, myositis, telangiectasias, ILD, and the scleroderma specific antibodies are positive, we'll call it as systemic sclerosis. If high titer U1 RNP is positive, we'll call it as mixed connective tissue disease. If anti-amino acyl tRNA synthetase antibodies are positive, we'll call it as inflammatory myositis. And if there is a persistent Sicca symptoms and ROLA antibodies are positive, we'll call it as Sjogren's disease. Thank you.
Thank you, Dr. Javin Singh. I think again connective tissue disorder is a very, very sort of a subject. I mean, I find it is very hard to at times to diagnose it. Most of the times the patient with polyarthritis, for years together they keep on taking steroids and anti-inflammatory drugs without any being proper diagnosis, you see. I mean, since the rheumatology has come a long way in the last few years, probably you people, you see, who are the expert in it, I think people, you see, who present with the sort of polyarthritis, they must be worked out properly before making any diagnosis. Again, you have shown the number of tests, you see. There's not even a single test for any single entity, you see. There's all a combination of tests, you see. The first thing is you have to have a differential diagnosis, and only then, you see, you go further for the test, you see. Again, as far as the treatment is concerned, more or less treatment, most of the connective tissue diseases, the treatment remains just here and there, more or less the same, you see. The only thing is ultimately the diagnosis where you stand for it.
True.
So thank you very much. So I must compliment and appreciate your lecture because we had very good experience with young speakers. To start with Dr. Meghna Gupta, Dr. Meghna Agarwal, Parth Bansal and Achal Goendi. So I have invited all the four for next conference also.
Thank you. Thank you.
So great to have you here and keep the light and spirit of education burning. And with your connection with Dr. Aman Sharma will take you further under the guidance of Dr. Gurpreet Singh Wander, who is my close friend, mentor, and this all you see is because of his promotion, his motivation and inspiration.
Thank
So
you.
you come from an institute which is very dear to me because half of my batchmates are there. So thank you very much.
Welcome,
And be our brand ambassador. Motivate next time more PGs to present papers here. So note the dates. Give me your new topic so that I may incorporate you in my scientific program 1 year before. Thank you so much.
Thank you very much.
Thank you.
Thank you, sir.
Now I'll invite another young person, Mr. Manoj. He is going to apprise us about the Asia Home Blood Pressure Monitoring Survey. We have been associated with home blood pressure monitoring study with Omron, and he is presenting 2 papers for that in next MAPICON. So please apprise us about your studies. Thank you.
Yeah, thank you, Dr. Professor Vitul Gupta for organizing this MAPICON 2025 and inviting us and giving support to us always. So I welcome all the delegates who attend physically and who are attending from virtual also. I am Manoj. I am working as a global medical aware executive in Omron Healthcare. So this is our survey which is planning to do it in the upcoming days, the Asia Home BP Monitoring Survey. So you can see the QR code. You can scan this QR code and you can also participate in this survey. So from this, so the purpose of this survey is to collect physician insights on home BP monitoring. So the participants who are participating in this survey is the physician in India who has patients with hypertension. All the physicians can take part in this survey. So the benefit of this survey is, we have a previous survey results in 2020. You can find it from Indian Hypertension Research. In that study shows that in India, the recommending, even though the HBPM recommendation was high, but the people are not aware. So the Asia 2020 paper shows that 1 in 5 physicians, only 5 in 1 physicians know the exact correct value of HBPM monitoring. So this survey will help us to know the awareness, and it will help to improve the guidelines in India. So you can scan the QR code and please participate in this survey. So from this survey we can get the more impact and more results which will help for the Indian hypertension guidelines. Thank you.
So dear friends, we have come to the last part of today's session, that is the poster presentation. Hopefully I think the people with the poster presentation are here. And the first is Dr. Ankur Gupta. He is from NC Medical College, Panipat. The poster is critical illness, polyneuropathy with severe diabetic ketoacidosis. Dr. Ankur Gupta, please.
Good afternoon, everyone. Today I am going to present poster presentation on critical illness polyneuropathy with severe diabetic ketoacidosis. Introduction. Critical illness polyneuropathy is the acute or subacute onset of extensive symmetrical weakness in critically ill patients, usually with sepsis, respiratory failure, multi-organ failure, or septic inflammatory response syndrome. ICU-acquired weakness includes critical illness polyneuropathy, critical illness myopathy, critical illness neuromyopathy. Clinical presentations include distal weakness, wasting, and sensory loss, as well as paresthesias and decreased or absent deep tender reflexes. Case details: a 27-year-old female was admitted with a history of fever with chills since last 3 days, breathlessness on exertion since 2 days, vomiting 3 episodes, and altered sensorium since 1 day. There was no history of diabetes, hypertension, thyroid disorders, and other systemic illnesses. On physical examination, the patient was febrile with a temperature of 101 degree Fahrenheit. Pulse rate was 98 beats per minute, regular, and all peripheral pulses were palpable. Blood pressure was 120 by 80 millimeters of mercury on admission. There was mild pallor, no icterus, clubbing, cyanosis, edema, or lymphadenopathy. Systemic examination. Central nervous system examination, there was altered sensorium with GCS of 9 by 15, tone normal in all the limbs, and she was moving all 4 limbs spontaneously. Reflexes were normal. Respiratory system, cardiovascular, and abdomen examinations were within normal limit. On day 2, clinical course. On day 2, she started developing acute onset flaccid paralysis in all 4 limbs. After 4 to 5 hours, she developed paradoxical breathing, not maintaining saturation in room air. Patient was intubated immediately and kept her on mechanical ventilation. Later, she went into cardiac arrest and was revived. Her random blood sugar was 550 milligram per deciliter, and urine ketones were positive. On further investigations, GAD antibodies are positive. CPK total increased to 1171 units per liter, and EMG and nerve conduction studies were done and revealed primary muscle disease with axonal polyneuropathy. MRI suggested diffuse cerebral edema, and CSF for HSV are negative. Investigations. On day of admission, the hemoglobin was 10.2 gram per deciliter and total count was 7800. The platelet count was 2,28,000 and mean corpuscular volume was 88. The serum urea was 22, creatinine was 0.54 and uric acid was 1.4. The random blood sugar level was 550 milligram per deciliter. Sodium was 138 and potassium was 1.9. Procalcitonin was 2.5. The total bilirubin was 0.46, of which direct was 0.06 and indirect was 0.41. The SGOT and SGPT were 10 and 16 respectively. ESR was raised for about 44. Urine ketones were large and urine sugars and urine ketones were positive in urine. The pH was 6.95. PCO2 was 15. Bicarb level was 6 and PO2 was 75. The CSF examinations, the appearance was clear. There were no cells in CSF. Sugar was 106, proteins were 88, ADA was 5, and HSV of PCR was negative. On day 3, the hemoglobin was 11.2 and total counts were 5800. The platelet count remains the same, that is 2,28,000, and MC was 89. The urea, creatinine, uric acid were within normal range. The RBS was 220 milligram per deciliter. Sodium was 141 and potassium was 2.5. Procalcitonin was 2.6. The total bilirubin total was 0.46, of which direct was 0.06 and indirect was 0.41. SGOT and SGPT were within normal range. ESR was raised, that is 40, and lactate was 1.8. Serum chloride was 99, calcium was 8.85, magnesium was 1.18, and phosphate was 4.46. The urine ketones and sugar, they were moderate and 2+ in quantity. The pH was 7.35, carbon dioxide was 36, bicarb was 21, and PCO2 was 55. Discussion. Clinical illness polyneuropathy, critical illness myopathy, and critical illness neuromyopathy are often referred to as ICU-acquired weakness. The probable risk factors include severe sepsis, hyperglycemia, severe electrolyte imbalances, metabolic disturbance, increased duration of multi-organ failure, hyperosmolality, parenteral nutrition, renal replacement therapy, vasopressors, corticosteroids, neuromuscular blocking agents, and aminoglycosides. Clinical suspicion is aroused when there is a failure to wean off a mechanical ventilator despite the improvement in underlying critical illness. Muscle wasting is variable. The precise mechanism of developing CAPNM is unclear, but circulating factors include cytokines associated with sepsis and multi-organ failure is thought to play a key role. It has been reported that 70% of the patients with sepsis syndrome have certain degree of neuropathy and severe respiratory muscle weakness requiring prolonged mechanical ventilation resulting in failure to wean off. There might be muscle wasting due to loss of thick myosin filaments. However, the process may take place for many days and needs tracheostomy for prolonged mechanical ventilation. Some patients have residual long-term weakness and atrophy and muscle weakness, which is not present in our patient. Conclusion, critical illness polyneuropathy, critical illness myopathy, and critical illness polyneuromyopathy are commonly seen in neuromuscular weakness in the patients admitted in ICU. Once the diagnosis of CAPNM has been established, it is advisable to initiate the management as early as possible in early stages. Further management strategies should target the pro-inflammatory cytokines, free radical pathways, controlling the other risk factors that include hyperglycemia, electrolyte imbalance, and sepsis. Thank you.
What was the outcome? Patient alive?
Yes, sir, patient is alive.
Actually, 2-3 things you see, I don't think you see they match with your sort of presentation. Number one, it is hard to believe that the patient was a non-diabetic. That probably the first time you said the patient presented with 550 milligram of blood sugar, you see.
So they didn't give any history.
There is something wrong somewhere.
So it might be wrong. She might be having diabetes previously, but she and her family members didn't give any history of diabetes.
Number two, why are you correlating it with diabetic ketoacidosis when you have one thing that the potassium was very low at the time of presentation?
Yes,
why
sir.
not all this flaccid places is secondary to hypokalemia rather than diabetic ketoacidosis?
Yes, sir, it can be.
I mean, you presented that the polyneuropathy, and rather than polyneuropathy, is more of a polymyopathy, you see, because the CPK level again was very high.
Yes, sir.
So that again goes in favor of muscle sort of weakness rather than the nerve weakness.
Right, sir.
So I mean, in your sort of presentation, both the thing is as well as polyneuropathy or polymyopathy. Number one, presenting for the first time with high level of this blood sugar, then presenting with hypokalemia, then on hypokalemia base, and once you treated hypokalemia, once you treated blood sugar, that's why most of the things they went back to normal.
Right, sir.
So I think we have to look into this sort of a thing, you see, rather than saying that this is all because of diabetic ketoacidosis. I think we have to work it more, you see, to make sure that it is not hypokalemia or some other problem rather than being diabetes.
Sure, sir.
You are PG student there?
Yes, sir, I am PG student.
Which year?
Sir, second year.
Second year. Okay. और ये आपकी केस रिपोर्ट है ना एक?
Yes, sir.
केस रिपोर्ट ना? तो एक तो जब वो हेडिंग होता है ना, when it's case report, you know what are the guidelines for case report? You know the names of that guidelines. Whenever we present any case report, there are official approved guidelines that we have to follow.
Sorry, sir, I have not gone
कोई बात
through
नहीं,
that.
मैं just उसमें है कि जो टाइटल में ना केस रिपोर्ट वर्ड शुड आना चाहिए. क्योंकि हमें नहीं तो देखने में लगता है कि तुम एक स्टडी पब्लिश कर रहे हो, बट यूर इज जस्ट ए केस रिपोर्ट. तो टाइटल में जस्ट राइट दैट केस रिपोर्ट. और अगर एक लाइन में तुमने बताना हो कि व्हाट इज द लाइक इम्पॉर्टेंट इन दिस केस सो दैट यू आर प्रेजेंटिंग. सी रूटीन चीज़ें हम कॉन्फ्रेंस में प्रेजेंट नहीं करते. देयर इज समथिंग स्पेशल दैट वी प्रेजेंट. सो व्हाट इज स्पेशल इन दिस केस दैट यू आर प्रेजेंटिंग? अगर 2 लाइनों में तुमने बताना हो शॉर्टली.
Sir,
once you are presenting it, you must, what is the key sort of thing you want to convey?
sir, she came with the high blood sugar, first newly diagnosed diabetes, and with the
she was newly diagnosed diabetes.
newly diagnosed, sir.
Okay. Young patient newly
Yeah.
diagnosed. Okay. और क्या स्पेशल था इसमें?
And-
दिस इज स्पेशल. अगर यंग पेशेंट न्यूली 77 ईयर में ये नई चीज़ होती है.
नहीं सर और साथ में वीकनेस सर जनरलाइज्ड वीकनेस. ऑन डे ऑफ एडमिशन देयर वाज नो वीकनेस, बट सडनली देयर वाज सडन वीकनेस.
Okay.
But then again, we are not sure still till today whether that is a part of diabetes or is a part of a metabolic sort of electrolyte imbalance. You see, that is still a point to be proved. So that means, you see, I mean, your case probably is still not complete unless we are sure about all that, no?
Yes, sir.
I think you have to work it out more then you can let us know, or you can find yourself, or your boss, you see, and then you can look into more into it.
Yes, sir.
Okay. Thank you.
गाइडलाइंस का नाम है केयर गाइडलाइंस, CARE केयर गाइडलाइंस. जस्ट गूगल पे सर्च करना केयर गाइडलाइंस फॉर केस रिपोर्ट. ठीक है.
Thank you, sir.
Thank you.
Thank you, sir.
Next is Dr. Himani Pandey. Case is acute myocardial infarction in situs inversus with dextrocardia, treated with percutaneous coronary intervention. Dr. Himani Pandey. She is from Medical College, Faridkot.
Good evening, everyone. So the topic for my poster is acute myocardial infarction in situs inversus with dextrocardia, treated with percutaneous coronary intervention. Starting with introduction. So dextrocardia is a rare congenital cardiac anomaly affecting about 1 to 2 per 10,000 in general population that involves an abnormal positioning of the heart in the right hemithorax. You can see in the chest X-ray, the heart is placed in the right hemithorax. So this condition is along with some other abnormalities. If there are some accompanying abnormalities, this is known as situs inversus. When the other organs are also going to be placed on the right side, then that is known as situs inversus. So if such patients presents with anterior wall MI, a standard ECG may not be able to interpret the location and extent of myocardial infarction when the diagnosis of dextrocardia is not known. Starting with the case, so we have a 70-year-old male, non-diabetic, non-hypertensive, right-sided, coming to us with right-sided chest pain since 2 days. And there is no complaint of any breathlessness. On examination, first coming to the vitals, BP is 110/70, pulse rate is 83 beats per minute, and on cardiovascular examination, maximum cardiac impulse is in the right fifth intercostal space. Heart sounds louder on the right side of the chest, and there are no murmurs. ECG on presentation, Q waves were seen in the lead V1, right axis deviation is present, negative P waves in lead 1 and AVL. ECG with right-sided leads were showing Q waves and T wave inversions in V1 to V4. Trop-I was 4.3. Chest X-ray confirmed dextrocardia with situs inversus. So on doing 2D echo, dextrocardia with situs inversus, RWMA involving the interventricular septum and apex was present with moderate LV dysfunction. The left ventricular ejection fraction was 36%, and on doing coronary angiography, LAD with SVD was present, that is single vessel disease. Proximal LAD plaquing with mid LAD 95 to 99% stenosis was there. PTCA to LAD was done successfully, and post-procedure stay was uneventful, and patient was discharged after 2 days. So the diagnosis was situs inversus with dextrocardia, evolved anterior wall MI, post-MI angina, moderate LV dysfunction, LVEF 36%, CAD, single vessel disease. Coming to discussion, the incidence of coronary artery disease in dextrocardia with situs inversus is not well established. Clinical presentation is similar to other patients of ACS, with ECG showing right P and QRS axis and poor R wave progression in the precordial leads. If ACS is suspected in patients with situs inversus with dextrocardia, both chest and limb leads should be reversed to reveal all the ECG changes. Conclusion. Patients with dextrocardia have a similar incidence of coronary artery disease as normal individuals. Situs inversus dextrocardia can present with STEMI, and this condition should be identified early as it influences the interpretation of ECG and subsequent management. Clinical diagnosis and electrocardiographic localization of myocardial infarcts, as well as coronary angiography and PCI, remain a great challenge in these patients. Both immediate and long-term management in dextrocardia patients presenting with ACS is similar to general population. Thank you.
Looking at this X-ray you have just shown, can you make from the X-ray the patient is dextrocardia with the situs inversus?
Not completely, sir.
Why not?
Because for situs inversus to be there, we have to see other organ placement also.
Yeah, that's what I'm saying. See, just observation. I mean, even if I'm looking at this X-ray, if it is not reverse X-ray otherwise, when you see the right dome normally is raised and the left dome. If you see this X-ray, the left dome is raised. That means the situs inversus. But the liver has gone to the other side. You see?
Yes, sir.
That's why that side is raised.
Yes,
so
sir.
looking at this X-ray as a radiologist, I mean, even I'm just for your information that you can make a diagnosis, actually probable diagnosis that this patient probably has dextrocardia with situs inversus.
Okay, sir.
Because the right, rather than the right dome, it's the left dome which is raised rather than the left dome.
Okay, sir.
That's number one. Number two, dextrocardia doesn't give you immunity not to have this myocardial infarction. As you say, I mean, how you can say the dextrocardia patient, the only thing is it's on the other side, but still the patient can still have myocardial infarction, still have coronary artery disease.
Yes, sir.
So, I mean, the other thing is, you have presented, it's okay, very good. No, I still can't understand that the person with dextrocardia can have myocardial infarction.
Yes, sir, surely.
What we are trying to tell the people or public, you see, what is your sort of presentation?
Sir, patient can have dextrocardia with coronary artery disease. There's no doubt about it. But I think we have less number of patients being diagnosed with dextrocardia and coronary artery disease simultaneously.
Dextrocardia itself is a rare thing. That's okay, fine. It's not very common. It's a rare thing. But again, you see, people, the only thing is the position he changed. But
Yes,
the patient is still, you see, maybe the operator, the cardiologist or interventionist, you see, he may find it technically difficult.
Yes, sir.
That can be there. But he is not immune to have a coronary artery disease.
Sure, sir.
पेशेंट की एज कितनी थी?
Sir, 70 years.
70. तो आपने पहली बार इसको डायग्नोस किया डेक्स्ट्रोकार्डिया या ऑलरेडी डायग्नोस केस था ये?
सर, पहली बार डायग्नोस हुआ।
70 साल की उम्र में पहली बार उसको पता लगा कि उसका हार्ट उल्टी साइड पे है।
So maybe he was diagnosed earlier, but
पूरी लाइफ में इसको कभी कुछ प्रॉब्लम नहीं आई।
sir, he was non-diabetic, non-hypertensive. It didn't give any
उसको
history of any.
उसको भी बड़ा सरप्राइज लगा होगा ना जब आपने बताया होगा कि तुम्हारा हार्ट उल्टी साइड पे है। और उसको हार्ट के अलावा और कोई ऑर्गन भी उल्टे पुल्टे थे?
नहीं सर, इसमें तो
ओनली हार्ट था ना, बाकी सब कुछ ठीक था?
सर, अल्ट्रासाउंड रिपोर्ट्स मैं सर
साइटिस क्या था?
साइटिस इन्वर्सिस था ना?
नहीं, क्या कौन से ऑर्गन थे? और
सर लिवर ऑन दी अदर साइड।
लिवर उसका दूसरी साइड पे था?
हाँ जी।
अल्ट्रासाउंड में आया डायग्नोस आया?
हाँ, लिवर सर।
और कौन सी थी?
सर उसकी सर लिवर ही था बस।
अच्छा, ये बताओ, जो साइटिस इन्वर्सिस होता है इसमें जरूरी होता है कि सारे ऑर्गन उल्टे पुल्टे होने होते हैं या एक आधा भी हो जाता है?
नहीं सर, कुछ ऑर्गन्स भी हो सकते हैं।
हाँ, तो जरूरी नहीं है ना, अगर सारे होते हैं दैट इज कॉल्ड साइटस इन्वर्सिस टोटैलिस। ठीक है, तो जरूरी नहीं होता वो हो, यूजली एक आधा ऑर्गन हो सकता है जो शायद आपके केस में हुआ हो। ठीक है, पर आप कह रहे हो कि 70 साल में पहली बार उसको पता लगा है ना कि वो, तो यही आपके केस की स्पेशलिटी यही होगी।
So many people do come to us. They are not aware about these diseases. So
जब भी आप केस रिपोर्ट प्रेजेंट करो ना, उसमें ये बताओ कि व्हाई योर केस इज इम्पोर्टेंट। मैं पहले भी उनको यही बोला था, तो यू मस्ट गिव स्ट्रेस ऑन दिस कि व्हाई योर केस इज इम्पोर्टेंट। अदरवाइज वो एक्यूट एमआई का केस है, कोरोनरी स्टंटिंग की, वो तो रूटीन में ही करते हैं, कोई नथिंग स्पेशल इन दैट ना। हाँ,
70 साल का तो आया तो आपको पता लगा कि डेक्स्ट्रोकार्डिया है, अदरवाइज पेशेंट को तो नहीं पता था ना। बट इवन डेक्स्ट्रोकार्डिया वी स्टिल डिड द पीसीआई एंड एवरीथिंग एंड पेशेंट वेंट होम ऑलराइट ना।
हाँ जी।
अगेन सेइंग डेक्स्ट्रोकार्डिया इज नॉट गिविंग एन इम्यूनिटी टू नॉट हैव ए कोरोनरी आर्टरी डिजीज। एनीवे, ओके, थैंक यू वेरी मच।
बाकी जो मैंने उनको बताया कि एज पर केयर गाइडलाइन टाइटल में जरूर लिखो केस रिपोर्ट ना, इफ इट इज अ केस रिपोर्ट। ओके, जब भी आप केस प्रेजेंट करोगे।
And next is Dr. Narinder Pal. He is also from Medical College, Faridkot. And his case is acute pancreatitis with splenic venous thrombosis, a rare complication of organophosphorus poisoning. Dr. Narinder Pal.
Good afternoon, one and all present here. Today the topic for my presentation is acute pancreatitis with splenic vein thrombosis, a rare complication of organophosphorus poisoning. So background, OPC poisoning is a common medical emergency in developing countries, usually presenting with cholinergic features due to acetylcholinesterase inhibition. Pancreatic involvement is a rare but potentially serious, with acute pancreatitis reported as a complication. So case presentation, we report a case of 20-year-old male who presented with a history of intentional OPC ingestion. The patient initially exhibited muscarinic and nicotinic symptoms of OPC poisoning and was managed with standard atropine and praldoxine therapy. During the hospital stay, the patient developed abdominal pain, distension and vomiting. Laboratory investigations revealed elevated serum amylase and lipase, suggestive of acute pancreatitis. His CECT whole abdomen was done, which was suggestive of relatively well-defined hyperdense collection measuring 6.6 into 3.5 into 5.9 centimeter in the peripancreatic region related to the tail and distal body of the pancreas, extending into the left anterior pararenal space. Maximum AP diameter was 3.3 centimeter. An ill-defined hyperdensity involving the distal body and tail suggested necrotic changes. Peripancreatic fat standing was present. Additionally, a focal non-enhancing hyperdensity involving the splenic vein was noted. It was consistent with splenic vein thrombosis. So the diagnosis of acute pancreatitis was made according to the revised Atlanta criteria. As the patient was having characteristic abdominal pain, there were elevated pancreatic enzymes and characteristic imaging finding of acute pancreatitis was there. So discussion, acute pancreatitis following OPC ingestion is uncommon and may be overlooked due to overlapping systemic manifestations. The pathophysiology is thought to involve the hyperstimulation of pancreatic acinar cells by excessive acetylcholine, and severe forms may be complicated by peripancreatic collection, necrosis and vascular involvement as seen in this case.
See, how you sure, you see, that this pancreatitis is due to organophosphorus poisoning?
Sir, the patient was non-alcoholic, non-smoker. There was no history of any other drug abuse in the patient.
Have you done the lipid profile?
Sir, lipid profile, no, lipid profile.
Because people with a high level of triglyceride,
Yes,
you see, they are highly prone for pancreatitis.
Yes.
Being a young girl, you see, I mean, rather than just coming to the conclusion that probably this pancreatitis is because of organophosphorus, because you see organophosphorus poisoning so common.
Yes, sir.
But I don't think I've ever heard of having a pancreatitis with I mean, still I am doubtful, you see, whether this pancreatitis is because of organophosphorus poisoning rather than anything else, you see. I mean, we must have sort of to exclude all other causes of pancreatitis rather than organophosphorus poisoning.
Yes, sir. Yes, sir.
If you are presenting a rare case, there has to be a differential diagnosis that to prove that it is because of organophosphorus poisoning. So Dr. Noria has rightly said that what investigations did you do to exclude other causes of acute pancreatitis? So did you do some other investigations for to rule out other causes of acute pancreatitis?
Sir, it was mainly based on history, like during the course of hospital stay.
No, history is different. Incidentally, if I am going to meet Dr. Noria, I meet Dr. Pramod there also. That doesn't mean that there is an irreversible relationship between the two.
Yes, sir.
Until unless we do all the other tests, that this test be done, this is because of acute pancreatitis, it cannot be. It cannot be because this test was negative, this test was negative. So we conclude that organophosphorus poisoning is the cause of acute pancreatitis. So whether this is a coincidental finding or it is cause-effect relationship.
Yes.
Right? So what are the other causes of acute pancreatitis?
Sir, like alcoholism, there can be genetic factors like CFTR mutations, SPINK, PRSS1 mutation, or it could be gallstone-induced pancreatitis, drug-induced pancreatitis. So commonly तो यही होते हैं.
What was the age of the patient?
Sir, 20-year-old male.
20-year-old.
Yes, sir.
Patient survive कर गया? Survived?
Yes, sir. Yes, sir. Initially he was managed with mechanical ventilation. After extubation, he started complaining of pain, abdomen and all.
एक तुमने टाइटल में लिखा हुआ है splenic vein thrombosis, उसका तुमने कुछ बताया नहीं. You have written in the title.
Yes, sir. Sir, it was shown on the CCT whole abdomen that there was hypodensity involving the splenic vein. It was consistent with splenic vein thrombosis.
The other thing is you didn't do the test for hypercoagulability. Because even if he has splenic vein thrombosis,
Yes, sir.
that you see young patient, you must exclude the other causes of hypercoagulability. Why she should have splenic vein thrombosis? You didn't do any gastrical lavage by any chance?
Gastric lavage, sir.
Was done?
Yes, sir. Gastric lavage was done. Samples were sent.
Something wrong can there be also to cause pancreatitis? There are so many questions.
Yes, sir.
I think he is simply just saying it's an organophosphorus poisoning. I think it doesn't go to, at least to my mind, you know. I mean, very difficult for me to swallow it. I think you should work it out again, go back and look at it to see and go to the history and the patient, you see, I mean, just follow up the patient more
Yes, sir.
carefully and just see to it.
Yes, sir.
Thank you.
Thank you.
एक जो मैंने पहले दो स्टूडेंट को बोला हुआ है, रीड द केयर गाइडलाइंस फॉर केस रिपोर्ट, बिकॉज योर्स इज आल्सो केस रिपोर्ट. ठीक है.
Next is Dr. Poonam Yadav, again from Medical College, Faridkot. Triple immune-mediated neuromuscular syndrome, coexistence of polymyositis, polyneuropathy, and myasthenia gravis. Dr. Pooran Yadav.
Good afternoon, everyone. Today's topic of discussion is triple immune-mediated neuromuscular syndrome, coexistence of polymyositis, polyneuropathy, and myasthenia gravis. So, the inflammatory myopathies are group of acquired skeletal muscle disease that can coexist with other autoimmune conditions. That is known as overlap syndrome. So, the immune-mediated neuromuscular disorders affect muscles, peripheral nerve, and neuromuscular junctions, causing complex presentation. So, on case presentation, there is a 35-year-old male with gradually progressive bilateral limb weakness. The weakness was more for proximal muscle than distal muscles, and numbness and bilateral ptosis, and signs of bulbar dysfunction over 5 months. Examination showed head drop, generalized reduced muscle power, weak deep tendon reflection, no muscle fasciculations. Investigations include elevated CPK level that was 2646, positive ANN, anti-PM SCL antibodies, but negative anti-acetylcholine antibodies, and normal tumor markers. Neurophysiology showed EMG showed myogenic and neurogenic patterns. NCS confirmed polyneuropathy. And for muscle myopsy confirmed inflammatory myopathies. For myasthenia gravis test, that IcePAC and neohistamine challenge tests were positive, and repetitive nerve stimulation shows decremental response. So, discussion include pathogenesis. MRI revealed muscle hyperintensities, normal abdominal ultrasound, and upper GI studies. Discussion includes pathogenesis involve autoimmune attacks on nerve muscle and NMJ with molecular mimicry or abnormal immune response. For management for this patient include corticosteroid immunosuppression, IVIG and physical therapy, and nerve monoclonal antibodies. Rare combined occurrence emphasizes need for multidisciplinary diagnosis and treatment. Conclusion for this study is a case of triple immune-mediated neuromuscular syndrome with polymyositis, polyneuropathy, and myasthenia gravis diagnosed in a young male patient, and it was managed with multimodal investigation and treatment includes biopsy, EMG, NCS, and antibody testing. For these type of cases, early recognition is vital for timely corticosteroid, immunosuppressive, and IUIG therapy for preventing morbidity and mortality. Thanks.
I still fail to understand. See, you say patients having myasthenia gravis.
Yes, sir.
And you have not done any investigation to make sure that patient has thymoma or not. Because thymoma is the most common sort of a thing. You see somebody presenting with myasthenia gravis, the first thing is always look for the thymus. I mean, all your investigation and everything, I can't see anything anywhere regarding thymus or thymoma.
CT was normal, said no thymus gland and annulment.
It is not there. I mean, you have not mentioned anywhere, and probably I mean, it is very difficult to say make a diagnosis without being the thymus gland being investigated. Because see, if you have a thymoma, it's very simple. And if you remove thymoma, see, most of the time the symptom of myasthenia gravis disappear.
Yes.
Because it is a 35-year-old male.
Yes, sir.
And presenting to you for the first time with myasthenia, again you see the presentation doesn't go very well. So at the age of 35, why one should have myasthenia at this age for the first time?
Yes.
And then you said immune mediated, because myasthenia gravis itself is an immune sort of a thing. So all these other finding of neuromuscular syndrome and all the things, this is all part of the same process. So probably in your case, I mean, I would say rather than the triple immune mediated neuromuscular syndrome, it is probably basically myasthenia which is causing all other problems.
Sir, there was muscle biopsy was positive, inclusion.
Positive for?
Inclusion bodies for inflammatory myositis, and anti-SCL and that antibody is also positive.
So you treat myasthenia with corticosteroids only?
Yes, sir. There were first we started on corticosteroid, then IVIG therapy.
What about what is the neostigmine and sort of a thing, you know, for myasthenia and all that, osis, prostigmine, neostigmine?
That has been started on discharging the patient. On initially we started corticosteroid.
But it's still not on, because unless you start this, even they are used as an emergency. See, somebody comes in with myasthenia crisis, you have to use all those drugs.
Yes.
थोड़ा repeat करना, तुमने triple क्या याद में? What is the triple in your case?
Sir, polymyositis, polyneuropathy and myasthenia gravis.
Okay. इसको तुमने ट्रिपल बोला है, पर माइस्थीनिया तो इसमें नहीं आ जाएगा, मायो दोनों के कॉम्बिनेशन में नहीं आ गया. माइस्थीनिया मतलब हाउ इट इज डिफरेंट फ्रॉम मायोसाइटिस एंड न्यूरोपैथी.
Sir, myositis.
Simple reason, because of ptosis, they made the diagnosis of myasthenia gravis. That's what I'm saying. You see, unless you have worked out about the myasthenia, it is very difficult to pinpoint that is all related to the triple sort of immune medical system rather than one underlying one pathology.
न्यूरोस्टिक में तुम कह रहे हो कि डिस्चार्ज पे दिया गया.
सर हाँ, स्टार्टिंग में कॉर्टिकोस्टेरॉइड चालू किया था.
नहीं, वो तो बता दिया तुमने. सर ने न्यूरोस्टिक में पूछा कि देखो मेरा मेडिसिन फील्ड नहीं है एक्चुअली ना, आई एम फ्रॉम फॉरेंसिक मेडिसिन फील्ड, तो मैं क्वेश्चन ऐसे ही तभी पूछ रहा हूँ. बट आई रिमेंबर कि हमें एमबीबीएस टाइम पढ़ाते थे कि माइस्थीनिया में न्यूरोस्टिकमिन देना है. ट्रीटमेंट वही है, बट वो तुमने मेंशन नहीं किया. तो बट यू हैव गिवन इट ऑन
यस ऑन मेंटेनेंस थेरेपी यू हैव गिवन पैरागस्टिमिन.
चलो ठीक है, तुम्हारा भी केस रिपोर्ट है, बट रिमेंबर दैट केयर गाइडलाइंस एंड ठीक है. yes. याद रखना सभी ना, अगर एक पॉइंट याद रहेगा तो.
yes.
थैंक यू. थोड़ी सी मेहनत और करो. Next is Dr. Parveen Kumar Nair from Civil Hospital, Faridkot. The study of serum magnesium levels, glycemic indices, lipid profile, and correlation with microvascular complication of type 2 diabetes. Dr. Parveen Kumar.
Ji sir, thank you sir. A very good afternoon to all. Today's topic of discussion is study of serum magnesium levels, glycemic indices, lipid profile and correlation with microvascular complications in patient diagnosed with type 2 diabetes mellitus patients. Starting with the introduction. Type 2 diabetes is frequently associated with microvascular complications, namely retinopathy, nephropathy and neuropathy, impacting morbidity and quality of life. Magnesium is essential for glucose metabolism and insulin signaling. Deficiency may worsen glycemic control and complications. We investigate the interrelationship between serum magnesium, glycemic indices, lipid profile and microvascular complications in type 2 diabetes patients. The objectives are to assess serum magnesium levels in type 2 diabetes patients, to evaluate glycemic indices, namely fasting blood sugar, postprandial blood sugar and HbA1c, to analyze lipid profiles, and to correlate all parameters with microvascular complications. Material and methods. design. It is a cross-sectional study. It is a cross-sectional hospital-based studies done during a timeline of 1 year period. Participants, it includes 100 type 2 diabetes patients. The inclusion exclusion criteria are the patients who are on drugs, supplements altering magnesium, and are chronic diarrhea patients, alcoholic patients, pregnancy. Assessment.
एक्सक्लूजन है या इंक्लूजन है? दोनों
एक्सक्लूजन है सर.
एक्सक्लूजन है ना,
जी
तो तुमने इकट्ठे ही लिख रखे हैं ना
सर. इंक्लूजन वर ऑफ एज ग्रेटर देन 40 years of age पेशेंट.
दोनों को अलग अलग लिखना है ना फिर.
जी सर.
इंक्लूजन अलग है, एक्सक्लूजन अलग है.
यस सर. Assessment. We assess by clinical, lab evaluation, microvascular complications like retinopathy by fundus, nephropathy by USCR, neuropathy by clinical examination. The result. Out of total 100 diabetic patients, 44% of the population were having hypomagnesemia, that is serum magnesium levels below 1.7 milligram per deciliter. There was a negative correlation of magnesium with fasting blood sugar, postprandial blood sugar, HbA1c, total cholesterol, LDL, all with significant p-value of less than 0.05. The positive correlation of magnesium was with HDL with significant value of p less than 0.05. Lower magnesium in retinopathy and nephropathy subgroups. Diabetes duration significantly longer in those with complications. Discussion. Our study confirms that hypomagnesemia is common in type 2 diabetes patients and is associated with poor glycemic control and adverse lipid profile. Magnesium deficiency also correlated with higher prevalence of microvascular complications. Conclusion. Hypomagnesemia is prevalent in type 2 diabetes patients and is associated with worse glycemic control, atherogenic dyslipidemia, and higher risk of microvascular complication, especially retinopathy and nephropathy. Regular monitoring of serum magnesium should be included in diabetes management to enable early interventions. Yes, sir.
You know very well that diabetes itself,
yes, sir,
and the people with diabetes have high sort of complications of microvascular problem, retinopathy, neuropathy, all those things you see. And is it possible that probably magnesium is by chance, I mean whatever you have studied, that you found it is low in sort of people who are diabetics, and how we can say that it is magnesium probably is contributing to not the control of diabetes or propagating more of microvascular complications? Because you see, these days most of the gastroenterologists, they recommend almost to every patient the level of magnesium, because there are a lot of problems in gastroenterology, like loss of appetite, you see, other problems, diarrhea and all that. But I have not heard that magnesium is causing or uncontrolled sort of a diabetes or promoting microvascular complication because of magnesium only.
So magnesium is involved in a number of coenzymatic reaction, and it was found that in the studies published, it has found that in patients with uncontrolled insulin, in patient with higher glucose levels, there was magnesium deficiency which was found. It promotes insulin signaling and post receptor and insulin phosphorylation, which helps in the insulin sensitivity, which leads to the uptake of glucose in the muscles.
कितनी लंबी स्टडी है आपकी ये?
जी सर.
ये कितने टाइम की स्टडी है?
1 year की सर. 1 year सर.
1 year?
जी सर.
आपने देखा सप्लीमेंट देके कोई एज एनी इम्प्रूवमेंट?
सर फॉलोअप का वो नहीं.
मालूम है magnesium low है, you supply, you give the patient magnesium and then find it out whether there's any change or not.
Yes, sir.
That will prove your fact, na?
Yes, sir.
Whether your glycemic control is controlled, whether your microvascular compression has reduced or not. But simply by saying the low level of magnesium is contributing to the microvascular complication and poor control of diabetes.
Yes, sir.
No?
Yes, sir.
The other thing is compare like 100 patients with low magnesium and 100 patients with the normal magnesium. Only then we can justify whether this is because of magnesium or not because of magnesium.
Yes, sir.
तुमने सिविल हॉस्पिटल में जो डीएनबी कैन
Yes, sir.
रेजिडेंट ओके कितनी सीट्स हैं वहाँ पे डीएनबी की
2 seats, sir.
2 सीट्स हैं अच्छा और ये तुमने नेफ्रोपैथी किससे स्टडी की है नेफ्रोपैथी स्टडी लिखा है ना जो माइक्रोवेस्कुलर स्टडीज रेटिनोपैथी तो फंडस एग्जामिनेशन किया तुमने
सर.
न्यूरोपैथी क्लिनिकल एग्जामिनेशन और नेफ्रोपैथी
USCR, urine albumin creatinine ratio, sir.
यूरिन एल्ब्यूमिन क्रेटिन रेशियो
जी सर.
इसके साथ किया पर न्यूरोपैथी जस्ट क्लिनिकल एग्जामिनेशन से
Yes,
किया है
only
Nothing
clinical,
that- चलो बाकी जो सर ने कहा है ना मैग्नीशियम
Magnesium supplement they can at least you should follow and see. So only then we come to the result. Na?
जी सर.
Anyway, thank you.
Thank you, sir.
Friends, next speaker is Dr. Ranjit Roopchand Sahare. He is again from Civil Hospital Faridkot. The future of healthcare is intelligent. I don't know what is future of healthcare is intelligent. Integrating artificial intelligence in clinical practice. That means AI in clinical practice.
Good afternoon, everyone. My topic is future of healthcare is intelligent. Introduction. Healthcare systems are complex and challenging for all stakeholders, but AI has transformed various fields, including healthcare, with potential to improve patient care and quality of life. Rapid AI advancement can revolutionize healthcare by integrating it into clinical practice. Reporting AI role in clinical practice is crucial for successful implementation and equipping healthcare provider with essential knowledge. Methodology. Search strategy and inclusion index database including PubMed and Medline, Scopus and Embase were independently searched with no time restriction. Database and search protocol and keyword. In the review the article, the author extensively examined the use of AI in healthcare setting. The use of AI in personalized medicine, medical diagnosis and patient monitoring could revolutionize the practice of medicine. AI application in healthcare would also help in predictive analytics and ethics. The exploring historical journey of artificial intelligence. In 1942, Enigma broken with AI. In 1955, the father of AI, John McCartney. In 1995, the chat box is given by Alice. In 1997, Man vs. Machine is given by the Deep Blue. In 1998, the emotional equipment robot has been implemented. In 2008, the voice recognizing feature. In 2011, the question answer was introduced. And in 2020, the ChatGPT was introduced. The conditions were external to healthcare system, addressing the liability issue and legal informative sharing, complying with standard and quality requirement, integrating AI relevant learning in higher education and healthcare staff, capacity for strategic change management, developing a systemic approach to AI implementation, ascertaining the resource for AI implementation, involving staff throughout the implementation process of AI system, and developing a new strategy for internal and external collaboration. Result. AI useful in disease diagnosis. AI improve the diagnostic accuracy like breast cancer, skin cancer, and diabetic retinopathy. AI enhance the speed and accuracy of microbiological and pathological testing. AI also useful in treatment support. They personalize the medicine through AI-driven recommendation and dose optimization. Predictive analytics for chronic disease risk and preventive strategy and reduction of hospital readmission. AI-powered virtual assistant and chat box improve the adherence and education. AI also useful in mental health. AI enable to CBT apps improve the depression and anxiety diagnosis and management, and diagnostic accuracy gain. Like breast cancer, the AI diagnose 90% versus radiologist diagnose 78%. Pneumonia from the chest radiograph with sensitivity and specificity with AI 96% and 64% respectively versus radiologist 55% and 73% respectively. Discussion. AI offered a transformative benefit in a clinical decision making, efficiency and cost effective. Ethical challenge including data privacy, algorithm bias and reliance on high quality data. Human AI collaboration is crucial to prevent bias, error and maximize clinical utility. Emerging the framework by FDA and MAA guide AI integration into the clinical pathway. The future look promising. AI-based automation, like new job creation, opportunity to build advanced AI capability, emergence of general AI to create a synthetic system as sophisticated as a human, but some barrier that restrict its universal acceptance will remain. Absence of interoperability, regularity implication, moral and ethics implementation, and shortage of relevant and sufficient talent. Conclusion. AI holds a transformative potential for healthcare by improving diagnosis and treatment outcome, enhancing patient engagement and education, and reducing human error and operational cost. However, responsible implementation must address data privacy, bias, and education of healthcare provider. Thank you, sir.
एक सिंपल सा सवाल है, आप इंटेलिजेंट हो या एआई इंटेलिजेंट है?
सर ह्यूमन और
हैं जी?
सर ह्यूमन एआई बनाया तो ऑब्वियसली सर ह्यूमन इंटेलिजेंस।
ह्यूमन इंटेलिजेंस है ना, तो फिर ये नहीं ना कह सकते ना एआई की बात।
नहीं सर।
तो हु हैज क्रिएटेड एआई?
सर वो ह्यूमन ने सर ऑब्वियसली।
हमने ही बनाई है ना?
यस सर। सर दोनों का सर कोऑर्डिनेट हो जाएंगे तो सर फिर
अनफॉर्चुनेटली प्रॉब्लम इज एआई डेफिनेटली आज से 20 साल पहले कहते थे कि कंप्यूटर आ जाएगा तो सारी जॉब्स खत्म हो जाएंगी। जॉब्स कोई खत्म नहीं, बढ़े हैं। तो एआई इज प्रॉब्ली इट हेल्पिंग अस यू सी टू एनालाइज डाटा एंड ऑल दैट यू सी टू शॉर्टन आवर टाइम एंड ऑल दैट, बट अगेन गुरु तो गुरु रहेगा ना। यू कांट डू विदाउट स्कूल एजुकेशन और कॉलेज एजुकेशन यू सी। आई मीन it is not possible that with AI all the medical colleges will be closed, you see, there will be no need of doctors, you see. I mean, the doctors still be there. The only thing, it is only helpful, it will aid into your diagnosis, it will help to sort out your data and all that. I mean, suppose you see there are 10 patients of diabetes, all 10 are behaving differently. So how you can feed the data to AI? AI will only simplify your data.
Yes.
Ultimately, it is you have to decide it what is wrong and what is right.
Yes. Definitely.
ये तुमने जो एग्जांपल दिया डाटा कहाँ से लिया है तुमने, जो व्हाट इज द सोर्स ऑफ दिस डाटा? जो
सर ये रेफरेंस दिया सर यहाँ पे।
रेफरेंस कहाँ का है? इंडिया का है या बाहर का है?
नहीं इंडिया का है सर।
कहाँ का है इंडिया का?
सर
नहीं जो आपने बेसिकली वो चेस्ट एक्सरे का दिया, निमोनिया का डायग्नोसिस, वो वाला रेफरेंस, उसका रेफरेंस क्या है?
सर ये फर्स्ट रेफरेंस जो है मैंने दिया तो वहाँ से है।
तो अगर तुम 2-3 बातें बता सकते हो यहाँ पे तुम्हें लगता है कि एआई कैन हेल्प, वैसे बताओ, मतलब वेयर एआई कैन हेल्प इन मेडिकल डायग्नोसिस।
सर वैसे सर हम क्लिनिकल राउंड में सर कोई जीएफआर कैलकुलेट करते हैं, वो भी सर ऐप से कैलकुलेट कर लेते हैं इजीली।
जीएफआर
एग्जांपल सर फ्री वाटर डेफिशिएट सर।
हाँ जी,
फ्री वाटर डेफिशिएट सर इन हाइपरनेट्रीमिया।
फ्री
वाटर डेफिशिएट।
फ्री वाटर?
हाँ सर इन हाइपरनेट्रीमिया पेशेंट सर we
ये
give a
कैलकुलेशन तुम
calculation.
AI से
हाँ,
कर
simple
लोगे
simple calculations
वो तो
will
जैसे
be-
अब कैलकुलेटर से करते हैं वो तो वही चीज़ होगी ना और कहाँ पे लगता है तुम्हें AI कैन हेल्प
और सर
सी डेफिनेटली देखो ह्यूमन माइंड को AI इसका कंपैरिजन नहीं हो सकता बट डेफिनेटली इट कैन हेल्प जैसे डे टू डे में अभी गूगल मैप से हम रास्ता पूछते हैं तो इट हेल्प्स अस ठीक है AI बेसिकली एरर रेट रिड्यूस करेगा जहाँ पे रेपिटेटिव वर्क हो रहा है ना सेम वर्क को रिपीट कर रहे हैं हम
बहुत ज़्यादा है वहाँ पर ह्यूमन इन्वॉल्वमेंट है मुश्किल है एक आदमी के लिए 24 घंटे में इतना काम करना आई थिंक दैट इज द प्लेस वेयर योर AI will come into action
yes sir
but AI can analyze multiple sort of data in a short time
yes thank you sir
Next is Dr. Mekha George from Medical College, Newport. TTP with colitis, hidden GPA, unfriendly UC or simple infection when rare overlap creates a therapeutic challenge. Dr. Mekha George.
Thank you, sir. Good evening, one and all. Thrombotic thrombocytopenic purpura with colitis, hidden granulomatosis polyangiitis, thrombotic thrombocytopenic purpura with colitis, a hidden GPA, that is granulomatosis polyangiitis, usually known as vaginous, an unfriendly ulcerative colitis, or a simple infection, when a rare overlap creates a therapeutic challenge. So TTP is a rare life-threatening microangiopathy that is caused by ADAMS13 deficiency. ADAMS13 is basically an enzyme that cleaves the von Willebrand factor that helps in clotting. So colitis in TTP may result from infection, vasculitis, or ulcerative colitis. Differentiating this is a challenge but crucial, but because the management varies. Rare co-occurrence of TTP with vasculitis poses a diagnostic dilemma. So the pentad of TTP is MAHA, that is microangiopathic hemolytic anemia, fever, neurological symptoms, renal manifestations, and thrombocytopenia. Only 25% present with the pentad, and my patient was one of them. A 22-year-old male, known case of TTP on steroids and rivaroxaban, in relapse in 6 months with progressive worsening RFT and platelets, had presented with bleeding PR since 1 month with reduced urine output and generalized anasarca. Patient was treated in an outside hospital with hemodialysis, blood products, and colonoscopic application of hemoclips, which transiently stopped the bleed. Colonoscopy revealed ulcers at the hepatic flexure, and the biopsy showed a query infective etiology. The TLC was elevated, the procalcitonin was elevated. Steroids were withheld, and the patient was discharged on broad spectrum antibiotics. Patient presented to us with recurrence of the PR bleed the very next day and severe anemia with an acute on chronic kidney injury. Patient was hemodialyzed and blood products were transfused in our center as well. Bilateral normal sized kidneys with increased renal echogenicity was shown in the ultrasound. C-ANCA levels were positive. Patient and also which unfolded the possibility of a concurrent vasculitic disease, jaise vaginous, or a rare ulcerative colitis. ANA titers, though elevated, were inconclusive profile. Patient was considered the possibility of ischemic colitis secondary to vasculitis or IBD and started on steroids, mesalazine with broad spectrum antibiotics including an oral antibiotic of rifaximin. Patient's PR bleed stopped within 12 hours of our administration of these drugs, and the patient was planned for a fecal calprotectin, renal biopsy, IV rituximab, and was referred to higher center for the same and a hepatology opinion for plasmapheresis. The special investigations that my patient had gone through over the years, since the past 6 years, when he was initially diagnosed, for the diagnosis of TTP, he had a PBF which revealed hemolytic anemia, G6PD levels, high quality liquid chromatography, Coombs test, bone marrow biopsy with flow cytometry, protein electrophoresis, FDP levels to rule it out from DIC, and finally an Adams 13 level, which revealed the diagnosis of TTP. For autoimmune disease panel, he was given an ANA and an ANA profile, and C-ANCA. For the PR bleed, colonoscopy, and biopsy. The biopsy had shown moderate chronic inflammatory infiltrate with prominence of eosinophils in the lamina propria. Conclusion, colitis in TTP is a rare and diagnostically challenging. Differentials include infection, vasculitis, or UC. Early recognition and multidisciplinary management is essential for optimal outcomes and organ preservation. In the past presentations, I've heard the question, why is this case important? The patient came to us with sepsis, one of the golden rules that we learned since internship. It says sepsis mein steroids mat do. It will worsen. But my patient was bleeding almost for the past 1 month. His HB when he came to us was 4, and we treated him with IV antibiotics. But it did not resolve the PR bleed. He fell to an HB of 2, which is when we realized we had very limited to lose. We started him on steroids, and within 12 hours of his oral Vicilon and rifaximin and mesalazine, he improved. I know that I do not know the diagnosis of the patient yet because we treated him for practically everything. But this case I wanted to present to prove that we have to believe that we made the correct diagnosis on clinical improvement and laboratory improvement. And until that happens, we need to search for the correct diagnosis. Thank you.
What was your basically initial diagnosis?
Initially, it was infective colitis, sir, because there was a biopsy with them. That said, a query biopsy.
Infective colitis?
Yes, sir.
So how come this TTPA came into the picture?
The patient is a known case of TTP, sir.
That's what I'm saying. Sorry. The original diagnosis, the initial diagnosis was TTPA. So he presented to you with bleeding PR,
yes,
which you diagnosed as query infective ulcerative colitis.
Or vasculitis.
Or vasculitis.
Yes.
Okay. So then you treated that with your antibiotics and steroids.
Yes.
Patient responded. But he presented with severe anemia also, no?
Yes,
because
sir.
of bleeding.
Yes, sir.
So you still don't know what was the cause of colitis?
Sir, since the biopsy had driven a query infective, we were not, it's unlikely to be ulcerative because there was only hepatic flush
It
involvement.
is not ulcerative, yes, that I'm sure,
Yes.
you see. I mean, what was basically, how did you diagnose TTPA? So who diagnosed TTPA?
TTP was diagnosed 6 years ago, sir, at his age of 16.
No, who diagnosed it?
It was diagnosed in DMC.
In?
DMC Ludhiana. And these were the investigations. Final was the Adams 13 levels.
So what I'm feeling is just trying to correlate it, that you have TTPA, you came with bleeding, you had a renal problem, you say, and you say ANA was positive.
Yes, sir, but profile did not reveal anything.
Yeah, but that again doesn't mean anything, you say. That is not one thing for sure, that it has to be positive. Why don't you think on the line of SLE? I mean, that probably will fit into each and everything. Causing low platelet, causing your renal involvement, causing your ischemic colitis. What else do you need? All three things are there.
Yes, sir. So will a profile
SLE
be
causes
positive?
thrombocytopenia, SLE causes renal disease, SLE causes ischemic colitis.
So will a profile be positive in SLE, sir?
That's what I'm saying. ANA is positive. Profile doesn't mean again.
Okay.
You need to be not to be 100% that profile has to be positive.
Okay, sir. Okay.
What I'm trying just to say is, I mean, I've not seen the cases you have presented it. I'm just on your presentation. I mean, I'm saying is made a diagnosis of TTPA. I mean, that was 6 years ago. I mean, the patient must be on steroids for TTPA.
He was on relapse actually. He had not taken his medications.
So what is your follow-up now?
So actually once he went to this thing, all I could follow up was for 2 days he did not bleed, and then it became sort of like a financial problem also for them, so I was also a little uncomfortable to keep going.
That's a very common problem with all our patients.
Yes, sir.
Anyway, thank you very much.
Thank you, sir.
मेरा एक्चुअली मेरे लिए तो सारी नई चीज़ें हैं, बिकॉज आई टोल्ड माई फील्ड इज़ नॉट मेडिसिन, बट भाई जनरल मैं आपको बताऊंगा भाई आपने केस रिपोर्ट लिखना है, बाकी देखो जब भी आप प्रेजेंटेशन करते हो एक आधा रेफरेंसेस जरूर लिखना चाहिए, मस्ट राइट, चाहे उसको उसका फॉन्ट छोटा कर दो, बट यू मस्ट राइट सम रेफरेंस, यू नो.
So we have come to the last lecture, last sort of presentation. is by Dr. Nayan Kumar Amarutia from Medical College, Maulana. In case of Millet-Gobler syndrome, one of the presentation of posterior circulation syndrome, stroke, PCA stroke.
Good afternoon, everyone. Today I am presenting a case of Millet-Gobler syndrome, one of the presentation of posterior circulation stroke. Millet-Gobler syndrome is a classical crossed brainstem syndrome characterized by the unilateral lesion in the basis pontis ventral pons. This condition manifests with an ipsilateral lower motor type of facial nerve palsy and the contralateral hemiparesis or hemiplegia attributed to involvement of corticospinal tract in the pons above the medullary decussation of the pyramid. Ipsilateral sixth nerve palsy suggests the medial extension of the causative lesion. Case report: 79-year-old male patient presented to IMSR emergency with the chief complaint of sudden onset left-sided upper limb and lower limb weakness since 5 days, right-sided deviation of angle of mouth since 5 days, along with dribbling of saliva from the right angle of mouth and unable to close right eye since 5 days. Patient was non-case of hypertension since 1 year, not on any medication, and non-case of chronic liver disease, hepatitis C related, on treatment since 1 month. On presentation, on examination, patient was conscious following verbal commands not oriented to time plus person. CNS examination, power in the left side, upper limb and lower limb, it was 0/5, 0/5. Right side, it was 5/5, 5/5. Tone in the right upper limb and lower limb, it was increased, while in the right sided, it was normal. Reflexes, left sided biceps, it was 3+. Triceps 3+, knee and ankle left sided it was 3+, rest were 2+. Left sided plantar was extensor and right sided plantar was flexor. Cranial nerve 7th examination, right sided loss of forehead wrinkles was present, unable to close right eye, watering from right eye was present, loss of nasolabial fold on the right side, a deviation of right angle of mouth with dribbling of saliva, loss of taste sensation of the right side of the tongue. Cranial nerve 6th examination, patient was not able to perform abduction due to the paralysis of lateral rectus muscle. Here there is a picture of patient suggestive of the right-sided element type of facial nerve palsy. Here a patient is not able to close his right eye. There is a deviation of angle of mouth and loss of forehead wrinkles. MRI brain, acute to subacute infarct in the brainstem involving the right pyramid median pontine region and the right medullary pyramid. Mild chronic ischemic changes, marked cerebral atrophy. Here MRI picture is there, FLAIR and T2 weighted images. Hyperintensity is noted in the involved area of the right ventral pons involving the region of corticospinal tract and possibly affecting the existing fibers of abducens nerve and facial nerve fascicles. Conclusion: Millet-Gobler syndrome is an uncommon condition, influence 1 out of 1 lakh population, with more common in the male than female, typically found in the brainstem cancers, tuberculoma, injury, and stroke. In younger individuals, often results from the infections or neoplastic lesions. In older population, hemorrhage and the infections are more common antecedents of the Millet-Gobler syndromes. So in this case, there was no involvement of vision, there was no dysarthria, there was no dysphagia. These are the classical in the posterior circulation, sir, but this was not in this case.
Where does the pons get its supply from? Pons की supply कहाँ से आती है?
The pontine artery, sir, and its branches. First basilar artery, that vertebral, then basal, and then pontine.
You mean the posterior circulation?
Yes, sir.
So when you talk about posterior circulation, it is more of the cerebellar part, rather than the pons.
Yes, sir.
But there is no cerebellar signs at all.
Yes, sir.
That means it's only pons is involved.
Yes, sir.
So when it's focal sort of infarct at the level of pons only.
Pons, yes, sir.
So that's why probably it is uncommon and it's name termed as Millet-Gobler syndrome.
Yes, sir.
Because it's the only involvement of the pons and
yes, sir.
a part of medulla also, I think. But you have ruled out the other causes, as you have mentioned, mostly cancer, tuberculoma, injury, and all those are not there.
No, they were not there, sir.
So probably it's all ischemic stroke.
Yes, sir.
The reason for ischemia?
And yes, sir. And risk factors were also there. Person was hypertensive.
Hypertensive.
Yeah, not on medication. Yes, sir.
You have not done carotid Doppler or echo?
Carotid was done, sir. It was echo was normal, sir.
Echo normal, carotid normal.
Normal.
So basically, maybe hypertension is the
Yes, sir.
basic reason for the stroke.
Yes. Appreciate it.
Treatment part?
Sir, we have given anti-ischemic therapies like ecosprin and all.
Treatment still remains the same?
Yes, sir.
Whether it's Millet Gobler or is otherwise anywhere?
We have treated on the line of stroke, sir, only. Ischemic stroke.
So your presentation was because the involvement of the pons only, you see.
Yes.
That's why you have presented this case, you see.
Yes, sir. Yes.
Which is, just only having involvement of pons is more rare than
Yes,
a stroke in general.
Yes, sir. Yes.
Okay, thank you.
Thank you, sir.
With this, we have come to the end of today's scientific session, friends. So we are thankful to all of you for your active participation, and thankful to all the people who are online, and hopefully to see you tomorrow morning at 9 o'clock for the last day of MAPICON 12th edition. Thank you. I think we have to just wait for a few minutes. You have to bear with us. Dr. Jankraj. Okay. Thank you. Thank you very much.